the day 2 sessions. So we'll limit to the time. For every speaker, we have allotted 20 minutes. So the timer will get displayed in the top end of the right side. So once the timer goes off, 20 minutes goes off, the screen will go blank. So request everybody to stick on to the timings. Okay. So with this, I'd like to invite the chairpersons over to the MCs.
Good morning, everyone. My name is David. So I welcome you all to the day 2 of Pedicriticon 2025. So for the first guest is Dr. I would like to welcome Dr. Madhu Hetsi. He's a professor from Siddhaganga Medical College. So please welcome.
I would also like to welcome Dr. Lajwanti ma'am. She is also the chairperson for the next talk. So we'll invite 2 chairpersons and we'll continue with the 2 talks simultaneously. Just to save the time.
Hello. Good morning, everybody. I thank organizers for giving me opportunity to chair the session. I invite Dr. Arun Kaushik, the speaker. He has done MBBS and MD microbiology and DNB microbiology, and is the manager of medical affairs. He works in Institute Biomurinics. His areas of interest are hospital infection control, mechanism of antimicrobial resistance, management of infectious disease or quality control, etc. Has many publications in national journals in various topics. Has been part of many research projects during his tenure in medical college. He has trained in ISO 15189 2012 and served as a quality manager. He has faced many audits for NABH, NABL, JCI. He has also worked previous experience in corporate hospitals. Over to you, sir.
So good morning, everyone. Thank you, organizers of Pedicriticon, for having us here. Thank you, respected chairpersons, for the wonderful introduction. So I am going to talk about the importance of need for speed. How does molecular testing support a clinician to take appropriate decisions and then treat the especially pediatric patients effectively? So today I'll be talking about the importance of utilizing the film array or the BioFire instrument. It is not a industry talk. It is I'll just tell the importance of how do you utilize this the wonderful instrument which is there. How do you utilize the panels which is available so that we can give faster results for for the treating clinician so that they can treat the patients better. So we call this a syndromic approach because it's not a single test. It is a multiplex PCR which is that which identifies multiple organisms within an hour's time. So it gives you all the results within an hour's time and which organism you're going to deal with and how you can treat the patient better. So this is the importance or this is the difficulty which most of the clinicians face. So we don't know, what is the organism. So sometimes we can misdiagnose the organism, we can not have the organism which is that, or sometimes we have limitations of the culture which is that. It is time consuming, it takes time for us to get the organism. Sometimes it can be no growth or no pathogen grown. So all these difficulties are there and viruses cannot be easily cultured, parasites cannot be easily cultured. This is where molecular testing plays a very, very important role. One more important thing is the turnaround time. If you see here, most of the cultures come within 48 hours if it is an automated system. If it is a manual culture, it takes at least up to 3 to 4 days. But with utilizing the molecular testing, we can reduce the turnaround time to less than 12 hours. So if the instrument is there in the hospital, it is hardly 2 to 3 hours. If it is there outside, maybe if you have to send the sample outside, 6 to 8 hours is what most of the time we get the results in. So it's very important for us to treat the patients appropriately, especially in pediatric cases in critical care. It's very important for us to correctly optimize the antibiotic at the earliest, because if we don't optimize, we'll have more number of resistance coming in, and sometimes we can lose the patients also. So very important for us to appropriately start the empiricals, convert the empirical to target therapy at the earliest. So this is where faster identification, faster reports play a very, very important role. So this BioFire instrument gives, it's a comprehensive test. In a single sample, in one comprehensive test, in about an hour's time, some panels are around 45 minutes, most of the panels are around 1 hour time, they will give you multiple results, a bacteria or a fungi or a virus or a parasite, along with the resistant gene pattern. You get all the carbonamases, you get the VIM from, you have the VAN A, VAN B, you have the MCR gene. So most of the common resistant gene patterns are easily available, and the runtime is only 1 hour. So by the time you send the sample, you start the empirical therapy, you have the organism in your hand, you know how to start or manage the patient appropriately. Even the empirical therapy which is started can be optimized appropriately. Though it is still empirical, at least we know we only give a gram-negative empirical, or we add up a gram-positive if required, or we add up an antifungal if required. So that's the importance of utilizing the molecular testing. So if you see here, this is a time where the empirical therapy is converted to a targeted therapy. Most of the AMR, AMS, and this is a sepsis month, a lot of talks on AMR, AMSP is going on. It's very important for us to convert the empirical to the targeted therapy. And this plays a very, very important role. So if you are able to give faster results, the right organism at the earliest, you can convert from the empirical to targeted therapy at the earliest, so that you are able to treat the patient better, because optimization of empirical therapy to the targeted therapy is the most important goal of any of the clinician. So if you see here, manual IDST takes around 3 to 4 days for us to convert from the empirical to the targeted therapy. With automation, with the Vitex and other instruments which is coming in with the MIC values, we can reduce it up to 48 hours, but not less than, because we require the organism to grow for us to identify, give the MIC values. But with utilization of the molecular testing, we can reduce it to less than a day's time. Sometimes 12 hours. It again depends on where the instrument is. If you have in-house, it is hardly 2 to 3 hours. If it is outside, it only the time of travel, logistics is where it is there, because the runtime is only around 1 hour. So how does the syndromic testing help? It helps us to identify the relevant pathogens. Next, it identifies the unsuspected pathogens, because sometimes you may not be expecting a virus or a fungi in a patient. That also can be easily identified using the molecular testing. It has to identify the additional underdiagnosed pathogens. It can be a combination virus plus fungi, or a virus plus bacteria. The bacteria can only be a secondary infection. The virus can be the primary infection. That can be easily identified. Others, you have to send for viral PCR separately. It's again additional cost, additional time. So that all can be identified at the same time. It identifies co-infections, virus plus virus, or gram-negative plus gram-positive, or you have 2 gram-negatives at the same time, or you have 2 different organisms or 3 different polymicrobial infections. All can be easily identified. It helps clinicians to make appropriate decisions at the earliest. And finally, it is cost saving for a patient, because the amount of antibiotics, irrational antivirus which you give can easily be reduced. So the empirical therapy itself can be optimized, which is almost equivalent to your targeted therapy. So that is what we have seen with our own experience also. Most of the clinicians are able to give the right targeted empirical therapy on day 1, and most of the time it only continues, because what organism they get, the gene pattern they get, they can optimize the antibiotic which is given, and most of the time they continue it even as a targeted therapy. They don't need to change it over to any of the, or escalate or de-escalate. That's the importance of doing the molecular testing. So this is the instrument which is there. You have multiple modules, so you can run multiple samples at the same time. So the main importance is it enhances the pathogen identification, reduces the time to result. The faster turnaround time is there. It supports in the antimicrobial stewardship. It reduces the length of stay. Suppose you are able to target the therapy at the earliest, we have faster outcome of the patient, faster change of the patient from the critical care to the wards, and discharge of the patient. So it reduces the number of days or the ALOS for the patients, and it also reduces the cost for a patient. And finally, the bottom line is we're able to give good treatment for a patient at a lowered cost, and patients are also happy, and also the doctors, the hospitals are also happy. So that's the importance of utilizing the molecular testing in identification and diagnostics. So diagnostic stewardship plays a very important role, a very important part in the antimicrobial stewardship. So this instrument does the whole thing, the sample preparation, amplification, and detection all by itself. So all you need to do, just put the sample, around 200 microliters of sample, put the buffer and put it into the instrument. Instrument does the whole thing and gives you a result which can easily be understood by the clinician and then appropriately managed. So it works on the principle of PCR followed by the melt curve analysis. So the advantage of using a BioFire technology is, compared to other multiplex RT-PCRs, is we utilize the melting peak. So if 3 melting peaks are coming together, then we say this patient is positive for E. coli or Klebsiella, or this gene is positive. The advantage is that it done in duplicates or in triplicates, identifying the 2 out of 3 or 2 out of 2 should come positive for it to say it is positive. So the false negatives or false positive chances are very, very less. That's the advantage of utilizing it. And each melting peak is signature for that organism. So if it is E. coli, if that melting peak is there, then only it is E. coli. It will not get cross infection or false giving a different organism instead of the correct organism is always reduced. That's the importance of, that is where PCR versus a molecular testing like BioFire is. So this, if you are say it is E. coli, it is E. coli. But in a regular PCR, sometimes it can be misread. Because being a microbiologist myself, I know how PCR works. Sometimes, because of the amplicons, because of contamination, we might pick up a wrong organism. Or sometimes this can lead to false positives coming in because of the environmental amplicons coming in. All those are reduced because of this. And this is a nested PCR, so we're able to multiplex more number of organisms within a shorter span of time. This is how it comes, the melting peak. So that is very signature or very specific for that organism. So it is easier for us to identify the organism, and then we're confident that this is the organism which is coming out in the patient. And there are two controls in the instrument which runs. If both come positive only, the instrument flags it as positive. One is a process control and one is the RNA or DNA control. So it identifies the organism better. This is what I was telling. We are able to multiplex because of the number of wells which is there. This is again similar to that of a microarray principle. Because of 1 or 2 wells, we can do up to 50 targets, or we can mix and match more number of organisms with the resistant gene patterns. And most of the time we run in duplicates or in triplicates. So 2 out of 2 should come positive for it to say positive, or 2 out of 3 should come positive for us to say it is positive. Most of the time, if it is triplicates, all 3 should come within the same range. If it is in duplicates or 2 runs, then both of them come within the same range. So I'll just go into the different panels which is there. If there are more doubts, we can discuss further later. So first, most common panel which is most commonly utilized is a respiratory panel. This is very important, especially in CAP patients, because we're able to identify more number of viruses and certain atypical bacteria in this. So we all know the difference. Most commonly we utilize this for the upper respiratory. Your SARS-CoVs, your influenzas, RSVs, HMPVs are all there in this panel. So most of the time we usually recommend the nasopharyngeal or the oropharyngeal sample for this. We have the lower respiratory panel, commonly called as the pneumonia panel. I'll just come to that in the next. So all of us know what is the definition of CAP. So these are the common organisms which we usually expect in CAP, and most of them are there in the panel. We all know what is HAP, hospital-acquired pneumonia. Most of the time, if it is, if it is not a ventilator patient, but patient comes to a hospital and then gets the infection, it is commonly as a hospital-acquired pneumonia, and these are the common organisms which we usually expect in a hospital-acquired pneumonia. And third thing is ventilator-associated events, where VAP is one of the component of it, where most of the times, if the patient is ventilated, after 48 hours, if he or she develops fever or spikes fever, we usually term it as ventilator-associated pneumonia. Commonly, this is the organism. If you see the difference between a CAP and a HAP or a VAP, CAP commonly is more of viruses compared to bacteria. In a VAP or a HAP, it is more commonly the bacteria compared to that of the viruses. That's why we have 2 different types of panels which is there. Advantages, if you're able to give faster results to the clinician, the optimization of the antibiotic is better. More number of patients receive less unnecessary or irrational antibiotics or irrational antivirals compared to those whom we do not do the molecular testing. That is what we have seen. Many studies also establish this. If you're able to get the organism on day 1, we are more confident in treating the patient. This is where it plays a very important role. Though we might think, why to treat a virus? Why do you need to do a test? At least we know, okay, this is the only virus. If it is an RSV, patient clinically symptomatic, we will treat. If not, we can again symptomatically manage. But if there is a mycoplasma pneumonia which is there, or a chlamydia which is there, then we will have to go ahead and treat. Most of them are easily missed out in cultures. That is where we have to utilize the molecular testing, because I've heard feedbacks that it gives only more of viruses we don't treat. Why do we need to do a patient? Why do we need to do a test for 6,000 or 7,000 rupees? Advantage is that it gives us an idea. Okay, this is only a virus. We're not dealing with the bacterial infection. We no need to treat. If the patient is symptomatic, we have to treat. If it is influenza A, we have to give oseltamivir, we go ahead and give. That's the importance of doing a molecular testing. At least on day one, we know, okay, what we are dealing with, and we can optimize the therapy. We have to treat a virus, treat. If not, if it is a bacteria, treat. If not, you can again symptomatically manage the patient. So that's the importance of doing the molecular testing. We know the importance of how difficult it is to treat pneumonia. This is where faster diagnosis, faster identification of gene pattern plays a very, very important role. And if it is a patient of acute bronchitis or COPD, we again know how to manage the patient. We know what is we reduce the irrational use of antibiotics. Even for a GP, if they know this is an organism which is there, at least they will optimize the therapy than giving unnecessary azithromycins or other antibiotics for the patient. So this is how viruses play a very important role, especially in pediatric patients. If you see here, younger than 5 years, viruses are most common. So for the pediatricians who are here, it is a good panel because it identifies what are the virus which you're dealing with. You know whether to treat a patient or not. If the baby is symptomatic, treat. If the baby is asymptomatic, again manage accordingly. Because we have seen patients, especially pediatric patients, so it can go bad. If they are on mycoplasma pneumonia or anything else. So it's very important for us to identify the organism at the earliest. One more important thing in one of the panels, the pneumonia panel, we give you the bin copy, something called as the colony forming units per ml. So anything more than 10 per 6 or 10 per 7, we know it is a pathogen in a patient. If it is less than 10 per 4 or 10 per 5, it could be a colonizer for a patient. Then we appropriately treat a patient if required. That's another important thing of utilizing this BioFire panel. So these are different samples which we tell. I'll just go to the panel which is that. So this is a respiratory panel. Just to highlight the important organism which is that, we have the SARS-CoV here, we have the MERS-CoV here, we have the common coronaviruses which is here, HMPV is there, rhinoenteroviruses, the 4 types of para-influenzas, influenza A, influenza A H1, H3, the 2009 variant of H1N1 also is there. So the most of the common viruses which you usually expect is there. Certain viruses might not be here, but this panel is done to identify the most common viruses which we expect in patients. Okay, and the advantages, we only require 300 microliters of nasopharyngeal swab or nasopharyngeal sample in the VTM. So most of the time, because it's more a viral etiology which we usually identify in patients, utilizing this panel plays a very, very important role. And also it identifies the common atypical bacteria like mycoplasmas, chlamydias, even if it is whooping cough, bordetella, pertussis, parapertussis can easily be identified in this. So what IDSA tells, most of the guidelines tell, if you have a PCR, go ahead and do a PCR. If you have a multiplex PCR, please go ahead and do it, because multiplexing plays a very important role, at least especially in children, pediatric patients, immunocompromised. This panel plays a very, very important role, because faster we identify the organism, better the treatment for the patient. This is how the report looks when it comes out of the instrument. We can even see the report directly and then treat a patient, because it is always done in duplicates or triplicates. So the confidence limit of identification of the organism is very high. Very rarely we get false positives or false negatives. So we have one more panel called as a Spotfire panel, which we are usually targeting for in-clinic use. So this is again IVD approved, CLIA waived. So you don't even require a microbiologist to release a report. The confidence limit is high. This again, principle is almost similar, but it gives you reports or results in 15 minutes. And this is a panel which is available even on a mobile. It can be easily identified. So this is having 15 targets. 15 minutes is the runtime. And if you see, most of the things which I've covered in the respiratory panel is there. We have something called as a sore throat panel, where we have given the beta hemolytic streptococci also. That's an advantage of this. 15 minutes, by the time the patient goes and pays your bill and comes back, you have the report in your hand, so you know whether to treat a patient, not to treat. So it gives you an additional advantage in treating a patient. So whether to admit, not to admit, whether to treat, not to treat, whether to give antibiotics, antivirals, all can be easily identified on day 0 when the patient comes to even your OPDs also. That's the advantage of utilizing this. So this is coming. It's already there in 2 or 3 places. 2 or 3 pediatricians in the west and in the north are already validating it. They found very good results. We are trying to get it in south also. So this is a pneumonia panel. As I was telling you, it's have more of gram negatives and gram positives, which is here. Atypical bacteria is also covered, and the viruses. Because we expect more of these gram negative, gram positives, we usually recommend this for the HAP and the VAP patients, or patients who have lower respiratory tract infection along with the resistant gene patterns. So we know if it is a NDM or a KPC or ESBL or CTXM producing or MIC-MIC-C on day 0. When you send the sample, commonly we utilize this putum or the gastric aspirate in children, or ball or mini ball can be utilized for this patient. If the patient is already already ventilated, you can even send the ET secretion for these patients. So this is the difficulty with the common samples which is sent. This is where doing the molecular testing plays an important role. it identifies both virus only or bacteria, and it's all the combination it usually identifies. This is IDSA guideline which tells if you have a molecular testing for severe cap, it is good to use. Even for non-severe cap, if you have the if you have the instrument, if you're able to identify the viruses, commonly for viruses, consider if available. That's a guideline from IDSA 2024. So if we see here, most of the time, around 22 to 27% of times, what culture missed is easily picked up by the BioFire instrument. This is what I was talking about, the bin copies. This is almost called as the colony forming units per ml. Anything about 10 power 6 or 10 power 7, we have to treat it as a pathogen. Less than this could be a colonizer, but if it is a Ball sample, anything about 10 power 4, we have to treat. So we can easily differentiate between a colonizer and a pathogen, which is that. This is what I have highlighted here in many of the studies. And if you see here, most of the time, BioFire is the first test which is commonly done. And post that, we know how to treat a patient. Based on the organism, we will appropriately treat or manage the patient. So this is how the report looks. If you see here, 10 power 6 and 10 power 7, this could be a pathogen. 10 power 4, but again, it is Staph aureus. There is no McK or McC gene, so it's not an MRSA. This could be a colonizer and might not treat. But if any of the McK, McC gene comes positive, then you'll have to appropriately manage the patient. So this is again the difference, importance of it, how it has reduced, how you are escalated or de-escalated the therapy, and the turnaround time which is reduced. This next goes into the blood culture identification panel. We all know we are in the sepsis month, and yesterday was the World Sepsis Day. It's very important for us to identify sepsis and then manage the patient at the earliest, appropriately manage. So this is again all definition. I just skip all this. The SOFA scoring, Q-SOFA scores, the new scores, all these play a very important role. And if you see here, 40% of cases are children under 5 years of age. So very important for us to detect sepsis fast, treat them, because they can be, I believe in all your experiences, most of the children do not give out the right times. Okay. I'll just finish in 1 or 2 minutes, sir, please. They do not give out the the clinical presentation. So that could be an issue which is there. So most of the time, it's very difficult for us to identify the patients very easy. This is where this, doing the BioFire panel plays a very, very important role. So it identifies faster diagnosis, better treatment for a patient, also reduces the irrational antibiotics for a patient. I just skip all this.
Thank you, sir. We'll end the talk here. We have already exhausted the time. I would request to be please sit in the front desk till we invite the next speaker. Over to the chairpersons to invite the next speaker.
Good morning, everybody. Hello. Good morning, everybody. I call upon Dr. Suresh Kumar Panuganti, who is the lead consultant in Yashoda Hospitals. He works in the pediatric critical care and pediatrics. His main areas of interest are he works in pediatric critical care, neurocritical care, pediatric trauma, infectious emergencies. He is awarded P.N. Krishnamurthy Medal for the best outgoing student of the year in DCH. And he's a postgraduate teacher for more than a decade. Over to you, sir.
Thank you. Good morning, everybody. I think Dr. Arun, you have set the platform with a very nice talk. Now we'll move on to the different field in pediatric critical care, that is neurocritical care. Right. So neurocritical care. As asked to talk about TBI, traumatic brain injury, and the latest guidelines, what exactly do we need to do and all. So I'll take you through next 20 minutes through the guidelines, updated guidelines. At the outset, let me thank the organizers of Karnataka Pedicriticon. I think you're doing a wonderful job. So let's quickly look at the definitions, what exactly is TBI and how they are classified, how do we assess and how do we manage, and what are the new guidelines. What is TBI? It's damage to the brain caused by any external force which can impact the functions. It could be emotional, it could be cognitive, it could be motor. Any of these functions, when they are impaired, it's called a TBI. And it's one of the leading cause of death in children beyond infancy. In fact, children do better in terms of outcomes because of the neuroplasticity. But whereas in severe TBI, it's exactly opposite. Because of the weak neck muscles, when the child develops severe TBI, they tend to do very bad. So these are the leading causes of TBI. I'll not go much into this because I'll talk about the management per se, falls, road traffic accidents, or high impact injuries. These are the ones. Why do we need to differentiate children from adults in this particular scenario? Because the brain development is ongoing, the synaptogenesis, the myelination, this tends to go on for a longer period as compared to the adults who already have a developed brain. And not just that, because children, when they tend to develop TBI, they have a longer impact in terms of development or growth or learning or behavioral issues. How do we classify? Either based on pathoanatomy or clinical severity, and the other one is based on the mechanisms of injury that happens in the brain. Based on pathoanatomy, it can be focal or diffuse. As the name suggests, focal, one part of the brain can be affected. It can be either extradural or subdural or subarachnoid hemorrhage, whereas diffuse, usually it is caused because of the acceleration deceleration injuries. DAI is something what we see in children because of high impact injuries is classified as this. These are all for postgraduates. One is EDH, one is SDH, and the other one is SAH. Now, if we see based on the severity, it is classified as mild, moderate, and severe. There are two things which are taken into consideration. One is GCS, and the other one is the changes in imaging as well as focal neurological deficits. Mild TBI, child will present with a GCS of between 13 and 15, and there will not be any changes, or there might be minimal changes in the neuroimaging. Whereas moderate TBI, GCS is between 9 and 12, and there might be some focal deficits. As a severe TBI name suggests, there will be a lot of deficits, and GCS they present with less than 8 GCS. Now, what is this primary and secondary injury? If you see primary injury, because of the impact, there will be dysregulation. Because of the disruption of the membrane, there will be dysregulation of the electrolytes like sodium, potassium, and calcium, which in turn lead to a lot of process in the brain, leading ultimately to the cellular death. Whereas the secondary injury, it is mainly because of hypoxia, hypotension. What it does is, this is what we need to prevent in children, because secondary injury is the one which causes maximum morbidity and mortality. And most importantly, this is what we can actually prevent. Whereas the primary injury, already the cellular membrane is disrupted. There is not much we can do about it. And what are the guidelines? What are we talking about? One is BTF, that is Brain Trauma Foundation. This is the latest available, the third edition, which was taken into consideration till 2017, and the guidelines were released around 2020. New guidelines have not come up. And the second one is clinical practice guidelines were taken into account and systematic review were done. And then third one is recent literature from the last 5 years we have considered. And then BTF have formulated guidelines, which I'll talk about in the subsequent slides. Right. Pre-hospital management. Before the child comes to the hospital, what can be done? The main goal is here to prevent the secondary injury. That is the primary aim. That is prevent hypocarbia, hypercarbia, hypoxia, and hypotension. And what exactly needs to be done? If there is a possibility, always try and refer to the nearest facility where tertiary care PICU is done, especially with neurocritical care, or there is a neurosurgeon, and what needs to be done? Secure the airway if GCS is low. That is mainly to protect the airway because of the loss of reflexes. Spinal immobilization, if it can be done, kindly do it, but do not use these saline bottles where they are tied with a pillow cover or bedsheet, because that tend to cause more damage than benefit. Spinal collars are available nowadays. Please use that, and maintain oxygenation and avoid hypotension. This is the primary goal. And what do we manage? How do we manage in ER? Like all of us know this primary assessment ABCDE. Here we just do CABCDE or ACBCDE. That is cervical spine needs to be stabilized till we get a radiological clearance. Of course, we can have spinal cord injury without radiological abnormalities, SCIVORA. And the other C stands for any torrential bleeding is there. Control that bleeding, then protect the airway, breathing, circulation, disability, and exposure. What do we do? Airway, somebody needs to protect the airway. Inline immobilization needs to be done till we get a collar fixed, and then till we get clearance from the radiology department. Breathing, like I said, if child has low GCS, intubate to protect the airway. And then circulation, stabilize the circulation, because the hypotension is something we need to prevent aggressively. Secure two large bore IV cannulas, and do not go for jugular vein until we have a imaging and everything is clear. If we need to put a central line, go for a femoral, but do not waste much time in ER getting all these lines. You can secure two IV lines, and only colloids to be avoided in traumatic brain injury. There are specific indications for colloids which we'll not deal about here. Crystalloids, and more importantly, go for balanced solutions like plasmolite, because we tend to use lot of normal saline as fluid boluses. In the end, we end up with hyperchloremic metabolic acidosis, which in itself is a risk factor for requirement of inotropes and acute kidney injury. And disability, I have a slide on what exactly needs to be done and monitored. And exposure, look for any torrential bleeding, catastrophic bleeding. If we do not pick up and we try to stabilize, we are not going to win the war. Right. So pupils in TBI. This is a very interesting slide. How exactly we deal with. If you have bilateral pinpoint pupils, probably we are dealing with pontine hemorrhage. And if you have unequal pupils, yes, we know that probably child is having impending herniation or probably herniated. If you have bilateral fixed pupils, there is no prize for guessing. It's death already, brain death. And it's very useful to have a simple tool like that, pupil torch. I always carry a pupil torch because it's not easy to measure and write, because we need a serial values. If you have something like that, you have a pupil gauze here, the measurements here, and you can see the serial values. If pupils were 5 earlier, and if they're going down to 1 or 2, or from 1 it's going down to 6 or 7. That's how. And the second one is quite expensive. Most ICUs cannot afford to have unless they have a specialized neurocritical care. That's called a pupilometer, where you can exactly measure the value of pupil diameter. And what are the risk factors for injury? One is a severe headache, persistent altered mental status, or base of skull fracture. If you see any of these things, so probably you are looking at impending seriousness. Then who exactly needs CT? Do we need to do a CT for every child? We often face this question: child fell from the bed, child fell from the cradle. Do we need to do CT? We are not looking at the amount of radiation we are exposing. So we use PCAN, that is Pediatric Emergency Care Research Network guidelines, whom to do CT and where we need to avoid CT. This is a simple guideline based on the age. If you have a child less than 2 years, look at the clinical examination. If GCS is less than 14 and palpable skull fractures there or altered mental status, if any of those things are there, yes, go ahead and do CT. If none of them are there, look at for the additional findings like occipital or parietal or temporal hematoma on palpation, and no return to the baseline based on the level of consciousness, or severe mechanism, that is high impact injuries. If you have any of these, yes, do it. Otherwise, do not do CT scan. In more than 2 years, if GCS is 14, basal skull fracture or altered mental status, if they are there, yes, go ahead and do CT. If they are not there, look for other findings like high impact injury or loss of consciousness or vomiting or severe headache. If none of them are there, just you can wait and watch. So when do we do MRI? Do we really need to do MRI in emergency? Probably not. But now recent advances are there where we do rapid sequence MRI, where you want to prognosticate, where you want to protect your own skin. Because what happens most of the time in neuro ICUs, parents tend to blame 10 years down the line that we brought the child in reasonably okay situation, but since they did not manage, we lost the child, or we lost the child to bedridden situation. So to protect ourselves from that, we can do MRI if you have a quick in and out MRI, or if you are able to do MRI without sedation, or your radiology department is able to do a fast rapid sequence MRIs, yes, you can do it. Otherwise, you can always keep it for a second line, probably after stabilization, you can always do it. And there are some recent advances in terms of biomarkers where you can use for prognostication and medical legal purposes. Right. And monitoring. Once the child enters PICU, by now we would expect the child to have ET tube in place, 2 wide bore cannulas in place, ETCO2 in place. And once the child comes to PIC, it's always good practice to have a arterial line in situ, because arterial BP is much more reliable in critically ill child rather than NIBP. And if you have facility of neurosurgeon who can put an intraparenchymal or any other forms of ICP monitoring, it's always good. And we tend to avoid CVP in early stages until cervical spine is cleared. But yes, if it's cleared, you can even have that, because it gives an indirect or a direct marker of volume status. But with the advent of POCUS, we are moving away from that. And what are the targets? These are only the numbers which are given by the guidelines, though the evidence is not great, but it's always good to have some objective numbers for us to go through. The targets are for ICP. If you have ICP monitoring, always good practice to have less than 20. But again, don't go for one number. Serial monitoring and the serial trends of ICP is what gives a clue. And most important thing is aim to maintain cerebral perfusion pressure around 40. And these are the guidelines which are coming from a low evidence, but it's always good to have some number. In older children, adolescents, you can maintain up to 40 to 50 also is fine. And what are the first line therapies or first tier therapies for management of TBI? Most important is management of ventilation, and second one is management of ICP. Head end elevation up to 30 degrees. Do not elevate too much, because beyond 30 degrees, every degree you increase, you are increasing the ICP. And keep the head in midline position to improve the venous flow and to decrease the congestion. And sedation and analgesia, we tend to forget about analgesia because pain tends to cause spikes in intracranial pressure. Give adequate analgesia and treat seizures aggressively. What do we need to use for seizures? Levetiracetam, phenytoin, phenobarbital. There is enough data to suggest that levetiracetam is very safe as compared to phenobarbital or phenytoin, but use in high dose, you can load with 40 to 60 milligrams per kg, and subsequently maintenance, you can start from 10 mg per kg per dose, can go up to 60 mg per kg per dose. But phenytoin also has shown to be non-inferior or non-superior, so both of them are equally effective. If you have a facility of using phosphenytoin, it's much better because it does not cause arrhythmias as compared to phenytoin. And if you have a EVD, external ventricular device, in place, always go for CSF drainage, because that tends to reduce the ICP much quicker as compared to any of the other things. And previously, when I started post-graduation, we used to use mannitol as one of the osmotic therapies. Now we are moving away from mannitol, given the osmosis it can cause and electrolyte imbalances it can cause. We have already moved away from that, and we are using 3% hypertonic saline. But there are some institutes which use more than 20% hypertonic saline as well. But if you are using it, always make sure you are checking the serum electrolytes every 4 to 6 hours. That can be a cumbersome procedure, but it's always good to have, because you do not want serious imbalances in the sodium causing hyponatremia to hypernatremia and moving up and down so much. And there is a new recommendation regarding the short controlled hyperventilation. It needs to be used only in impending herniation. Do not wash out CO2 too much in every child. This is what I was talking about, the 3% versus the hypertonic saline. That is, some units do use 23.4%, but in my unit as a practice, we use 3% hypertonic saline. We give a bolus of 3 to 5 ml per kg, followed by infusion, which ranges from 0.1 to 1 ml per kg per hour. And we use a sliding scale depending on the sodium levels. Every 4 to 6 hours we measure, because we have a quick TAT for biochemistry values. And then mannitol is reserved for a very rare purposes. And our prescription does not have mannitol written as 6th hourly or 8th hourly. I tell my postgraduates and fellows to assess the child before the next dose, and only if it's really required, use it. Otherwise, do not give as a routine medication or an antibiotic which is written 12th hourly, 6th hourly, or 8th hourly. And like I said, watch serum sodium very carefully, in addition to osmolarity and volume status. How do you assess volume status? You can have a quick POCUS, point of care ultrasound, have a sonocyte, just put it across the IVC and look at the volume status and the variation with the respiration. Right. Coming to respiratory and ventilation management, most important thing I said in the beginning of the slides is prevent hypoxia, because that's one thing which can protect the brain from causing secondary damage. Protect from both hypoxia and hypotension. Both are independently associated with worse outcomes. PCO2, there is a clear recommendation: avoid prophylactic hyperventilation. Don't have to hyperventilate every child to bring down the PCO2. Only if it's required, that is impending herniation, only then go for it. And optimize sedation and do like bundle care, what the preterm babies we follow. Do all the procedures at once. Try and avoid poking the child every now and then. Give a small bolus of sedation or analgesia before doing suctioning. Have a closed suction catheter so that you don't have to de-recruit the lungs each time you want to do a suction. And seizure prophylaxis, there is a clear recommendation to use seizure prophylactic medications. I've spoken about levetiracetam and phenytoin, and if possible, use fosphenytoin if you do not have levetiracetam, but it's very unlikely that you have fosphenytoin but not levetiracetam. And if there is a facility to use continuous EEG monitoring or amplitude enhanced EEG monitoring, it's always useful. And do not use neuromuscular blockade often unless it's really required to control the spikes for temporary reason, because it tends to block you from seeing motor movements of the seizures. Again, you will have to depend on the autonomic components like heart rate, saturation, and others. And what are the second line therapies? If your first line therapies fail, that is refractory ICP, then you can go for phenobarbital or barbiturate coma. And if neurosurgeon is available, if not available, call him on an emergency basis and go for craniectomy or get a EVD placed so that you can titrate the CSF drainage. And there is enough evidence to suggest that decompressive craniotomy tends to reduce ICP significantly. Now they tend to put the bone in the abdomen, or there are bone banks available in most corporate hospitals where they can store the bone and then they can put it back within few weeks after the child recovers. And regarding the data, if you look at research, it's you have mixed data like with any other topic. If you go for Cochrane, there is not enough evidence. That's what it says. There is mixed data available. You can always discuss with the neurosurgeon early and go for craniectomy if it's possible. And does it end the monitoring? No, there are newer modalities which are available. That is advanced monitors for PbTO2, that is brain tissue oxygenation, NIRS, near infrared spectroscopy, and continuous PPX, that is pressure reactivity index. They can be used. Evidence suggests that when you use multimodal monitoring along with ICP monitoring, you tend to have better outcomes. What are the new guidelines say? Like already discussed most of the things, hypotonic saline instead of mannitol, but there is always scope to look for more randomized control trials. Sedation and analgesia, there is enough evidence. Seizure prophylaxis, levetiracetam is as good as phenytoin. If you do not have phenytoin, you can go for fosphenytoin. Ventilation, avoid prophylactic hyperventilation and use only in impending herniation. And temperature control, do not go for hypothermia. There is some data from Scotland and Ireland talking about selective hypothermia, but Indian data is very minimal. As of now, the data suggests just go for maintaining normal temperature. Take home messages: avoid secondary injury, use hypotonic saline, avoid prophylactic hyperventilation. Thank you.
Thank you, sir, for sticking on to the time. May I request yourself to be on the stage? May I request the chairpersons to hand over the token of appreciation to our speaker. I would also like to call upon Dr. Arun Kaushik onto the stage. Meanwhile, if there are any questions, we'd be happy to take it. Otherwise, we'll discuss during the coffee break. May I call upon Dr. Arun Kaushik onto the stage, please? May I request Dr. Chairperson to felicitate our speaker. May I request our senior consultant pediatrician, Dr. Ishwaraya sir, to felicitate our chairpersons, Dr. Madhu and Dr. Lajwanti. Now, with the end of this talk, we'll move on to the panel discussion. That is about the case-based approach to the different kinds of poisons. May I call upon Dr. Anupam Jaiswal. He is a senior consultant pediatrician from the Rainbow Children's Hospital, Banerghatta Road. Over to the chair moderator to introduce his panelists.
Good morning, everyone. Thank you very much for this opportunity and for having this. My name is Anupam. I'm a pediatric intensivist at Rainbow Children's Hospital, and we're going to go from topics to patients and how we apply what science we have to the patients that we have. And I'd like to call upon my panelists. All right. So.
To chair this session, may I call upon Dr. Anisur Rahman. He is a professor of the pediatrics at SIMSRH Medical College, TUMAKURU.
Yeah, next. All right, may I call upon Dr. Rachan Reddy, who is Assistant Professor and Head of Department, Chikbalapur Institute of Medical Sciences. May I call upon Dr. Krishna Kumar, who is the Medical Superintendent and Consultant Pediatric Intensivist at Nirmala Multispecialty Hospital, Mysore. All right. I think, yes, sir. Good morning, sir. Over to you, sir.
I'd like to invite Dr. Anupam Jaiswal, Consultant Pediatric Intensivist and Pediatrician, Rainbow Children's Hospital. He is an All India topper in Pediatric Emergency Fellowship Examination, STEP Fellowship, Best Outgoing Fellow Award for Clinical Excellence at the esteemed Guy and St. Thomas NHS Trust Hospital, London. And he's a Golden Retriever Award for Best Retrieval Fellow at Great Ormond Street Hospital for Children. And he's a lead fellow for morbidity and mortality at Great Ormond Street Hospital for Children, London.
Thank you very much, everyone, for this patient. Thank you for the introduction, sir. Thank you very much. So we'll just go on to the discussion. So. All right, so we'll just be talking about some cases, and then I've put together a few cases so that we can have a discussion and then get valuable inputs from people. First one is somebody named Pranav. We've changed names. This is an 18-month-old boy who just ingested toilet cleaner and arrived at us about 45 minutes to 1 hour after that, had one episode of vomiting. And he was excessively crying, had examination of involvement of oropharyngeal mucosa. And then there was soft stridor on inspiration. A smart PG went close by, tried to listen to it, and then made out that this child has also got some soft stridor on inspiration. There's no eye or facial injury. Now, evaluation-wise, may I request if, sir, you could just throw some light of what are your thoughts with regards to such a patient?
Good morning. With this case scenario, the child already is having stridor. That means definitely the airway is a little bit compromised. So we should be very cautious, and it would be better to go ahead and intubate the child, secure the airway first, airway and breathing, and then look for other signs.
Excellent. Thank you. Thank you very much, sir. So I think the important message here is that try to secure the airway and keep that going, keep it safe. Any specific therapies at this point, sir?
So going ahead with the specific therapies, one thing to remind that since that might be both alkalic or acidic form, so first main thing is to avoid gastric lavage. So the first thing is to avoid gastric lavage. The one more thing is NG tube. NG tube is quite tricky here. In expertise with endoscopic with the endoscopy, this one, so we can give NG tube, or else if you don't have that facility, you can just keep the baby on nil without any NG tube. And the specific treatment is for with your endoscopic management. So to see what type of injuries have been happened inside the esophagus.
Excellent. Thank you. Thank you very much, sir. So supportive measures, what would you support this child with, given that, we are keeping this child fasted and
Keep the child nil oral. Keep the child nil oral, and better not to put the tube. And if at all, if you want to put the tube, it should be under the endoscopic guidance, as told earlier. Start on IV fluids, and that endoscopy also, it should be within 12 to 24 hours. So look for the type of injury, extent of injury, or grade the injury with the endoscopy, and then further you can proceed with your management.
Great.
So
Thank you.
apart from this, there is no role for antibiotics as such. Only if you are suspecting secondary bacterial infection later on, then you can add up the antibiotics.
All right, sir. And then with regards to some, can sir throw some light on acid versus alkali in terms of the extent of caustic injuries that they cause?
Yes, sir. So alkali is more viscous, so there are more dangers. They can penetrate through the membranes and cause perforations and other ulcerations. So when compared to acidic media.
Excellent. Thank you very much, sir. So we just, I'm going to reiterate whatever we discussed about. So presence of stridor is an ominous sign. Be careful about this. Try and secure airway. You may have a small window period before you can do it. It may extend up to 1 hour or so. So important is to do it. How you're going to do it, when you place a cannula, the stridor may increase. Okay, are you going to gas this child down? So those are things that, as per your institute, as per your availability and your anesthetist skill, knowledge, are going to come into play. Lavage and antitube placement. See, the evidence is more often than not little tricky, like sir said. And then endoscopy and timing, which we said. And then steroids. That is one thing. If any of you can just throw some light, that use of steroids in such patients, when and how or no.
Use of steroids is not it's not a definitive indication in case of acid or alkali ingestion. So better to avoid steroids. It might even complicate with secondary infections also. So better to avoid.
Thank you, sir. And then other thing is dilution techniques. Are we going to use any dilution techniques like milk, water, or so?
Again, it has to be avoided. The dilution techniques has to be avoided in such cases, which it causes further ulceration and necrosis of the esophagus.
Also, as conventionally believed, giving milk to the child with acid or alkali ingestion, this has to be avoided. One thing is it bloats up the stomach, and it might worsen reflex, and it might even cause more damage to esophagus. So better to avoid these dilution techniques.
To add up with the steroids, a new study which has recent studies which have shown that type 2 and above, we can use steroids. The study shows there is decrease in chances of stricture formations with the use of steroids. So in cases with type 2, there are staging of your this one based on the severity. That is, stage 1 is your normal mucosa or mild edematous. Stage 2 is your mild ulcerations, superficial ulcerations. Stage 3 is your deep ulcerations, and stage 4 is your necrosis and stricture formation. So whereas in stage 2A or B, we can use steroids to avoid stricture formation. That was a recent study which has shown up. Thank you.
Thank you very much, sir, for this. And then just to reiterate that a lot of complications, nutritional issues, and long-term issues stay with these children or people ingesting this. This is just an example of some patients who have got gross things. One of them also ended up ingesting some milk to try and make things a little better. And then this is again a delayed one after 24 hours. So the important thing is to try and do an early endoscopy. For various reasons, for financial or lack of intervention or lack of inclination from parents or family, we may end up doing it late. But then it also shows, when you do it late, endoscopy, what you find, and where you have kind of lost time and effort, what you can put in early. Right. So these are the concerning patients. What we do, keeping nil per only, no milk or water, risk of mediastinitis has a high mortality, about 40%. And then if you have eye splash, then irrigate with saline and approximately about 20 minutes or so. Right. Moving on to the next case, we have Rishika, a 2-year-old girl with drooling, inability to feed, and then this child was just well fit and well. All of a sudden, has started having all these symptoms and signs, and then some piece of electronic equipment toy that she was playing with was missing, and then so we did an X-ray. So could one of you please, sir, throw some light on what we are seeing and what all we should be looking for?
Yeah, this is a foreign body which has been obstructed, and mainly two things we need to differentiate. One is whether it is a coin or a button battery. But as you can see here in the button battery, you can see a definitive rim. This rim suggests that it is a button battery. So if that ring were not to be present, then it would have been probably a coin. So anyway, in both the cases, we have to remove the foreign body.
Thank you, sir. Thank you very much. So evaluation of this patient and management, what are the foreign bodies that are to be removed?
So any foreign body obstructing the esophagus or the laryngeal airway, the immediate removal is recommended. Foreign bodies such as button battery, as sir told, or the coin, or any sharp objects, or in case of any magnet materials which can cause adhesion, has to be removed immediately, as early as possible.
We touched upon how to differentiate a coin from foreign body. Sometimes a lateral neck X-ray as well helps. Timing of removal, as it was pointed out, that the earlier the better, as soon as possible. And of course, if it challenges the airway or so, then it's done on a urgent or an emergent basis. What are the risks if it is left behind? That is battery.
If the button battery is left behind, then there are more chances of corrosion and even perforation. Later on, it might lead to stricture, fistulas, and in some cases, it might be even detrimental also. By if there is esophageal aortic fistula, then it is lethal. So these are the common risks that we have to keep in mind if there is a button battery ingestion. So better to remove it as early as possible if it is accessible.
Thank you very much, sir. So foreign body, the locations, and what we need to do. So we've touched upon the disk battery as pointed out, and then anything which is reachable that has to be removed. What about magnets? If you can just mention about magnets, please, sir.
So 2 or more magnets can causes adhesions, which further causes perforations. So that it's better to remove as early as possible through the rigid or flexible endoscope. I mean, this one when based on the position of the magnets present.
Right. And then the sharp objects has been touched upon. What about the foreign body? How long, if it is beyond reach, or if it is beyond the pylorus, if it is how long will you leave it, and what are the risks or complications that may happen with that?
Again, if any foreign body which is left for more number of days, the chance of injury to the gut is more. So what the guidelines say is, if it is more than 7 days, then better to go ahead and remove the foreign body wherever it may be.
Thank you very much, sir. So it also points out that if there's something stuck there, either it has already formed adhesion to the skin, or there is a stricture there, or already there is some form of narrowing there, which can just stay as a point for obstruction. All right. The next child is Rohit, 8-month boy with accidental ingestion of all out. It's a mosquito repellent. Presented with low GCS, poor respiratory efforts, and was desaturated with some tachycardia and hypotension. So this is how the child presented, and then this is what we had to do: put the child on a ventilator invasively, and then oscillate this child. So with this, actually, is there what is it that we can actually share with a crowd, sir? Any points that we could actually say how we could?
Based on the case history, the GCS score is 7. Anything less than 8, we have to intubate. And based on your ABG report severe respiratory acidosis, and the child shows lung features of ARDS, so it's better to intubate and start with a mechanical ventilator process.
And one more important caution that we have to take here is before intubating such cases, even though it is a mosquito repellent, they would have used kerosene as along with that. So better not to put the NG tube, and while putting the tube also make sure that uh, you take all the precautions properly and then put the tube to prevent aspiration.
Excellent, sir. Thank you, sir. Thank you very much for that. So once we do that, you can see that this child is on oscillator on 100% oxygen with reasonably high maps and amplitude. So we're kind of edging to the extent of what we can do from a conservative management. All right. So evaluation and management wise, ABCs we have touched: secure airway safely, and then obviously, like sir pointed out, the cardiovascular status in terms of these poisonings. Is there any light that you can throw, sir, with severe inhalation injury or ARDS this child is developing?
Because of the severe stages, mainly that there will be arrhythmias, so where we have to look upon it and treat accordingly in such a severe. Whereas at chest X-ray, as we told, there are more chances for this ARDS features, so we have to be treated indigenously.
Thank you, sir. Some general strategies, what we should do in addition to what has already been mentioned in such patients.
Again, this requires only supportive care, and there is no specific antidote as such. Thing is, initially it will cause chemical pneumonitis, so better to avoid IV antibiotics as such, unless you suspect secondary bacterial infection. So keep the child nil oral, observe for the features of ARDS or CNS symptoms or the cardiac symptoms, and if at all if there are any symptoms suggesting, then treat accordingly. So supportive treatment is the mainstay of therapy in this case.
Thank you very much, sir. And may I know if there's anything in terms of using conventional versus extracorporeal therapies in such patients, given that they have good outcomes?
In case of refractory hypoxia or in case of RDS, we can use ECMO. It's where the conventional therapy is not working, we can just go for extracorporeal treatment.
Thank you very much, sir. So the usual course is about they need about on average 48 to 72 hours of respiratory support, and following which they would usually turn around, failing which, like sir pointed out, consider extracorporeal therapies for oxygenation. Thank you. So just to throw a little light on these things and reiterate whatever we have discussed, all out is a combination of an insecticide as well as hydrocarbon. Hydrocarbon is used as a vehicle. So it uses hydrocarbon, its kerosene is actually industrial grade and a regular grade. So the industrial grade, what is used here, has got very low viscosity, so it can actually move around. And the other advantage it has in terms of use is that it can actually capture more number of insects. On the flip side, it's bad to our lungs because lower viscosity leads to higher aspiration hazard, and then obviously even as low as 1 to 5 ml of such liquid can lead to potential. Other thing is these patients, in terms of, can we just have a little thought on whether we should dialyze these patients or put in a GI absorption? What should we do from that point, sir?
Hydrocarbons are definitely not dialysable, so better to take care of the child and prevent acute kidney injury rather than allowing the child to go for florid kidney injury, where we land to a situation where we have to dialyze the child.
Thank you so much, sir. So we'll move to the next one. So this is Manjunath, 2-year boy with paracetamol ingestion, and arrived literally about 1 hour at the end of when they had consumed about 250 milligram per kilogram of dose. Examination is normal. We don't have any abnormal findings on examination. So how will we approach this child?
This is one of the most common thing we have to remember. Most of the times, the paracetamol poisoning is accidental because of the different doses and also because of the easily available drug. So one thing, whenever there is a paracetamol poisoning, we have to see whether it's acute or a chronic thing. Acute poisoning, it's more than 150 mg per kg per day, 140 mg per kg per day. In case if it is an acute case, any either acute or chronic, the one thing is we have to maintain is any poison cases, that is ABC. You have to maintain the airway, breathing, and circulations. Circulations.
Thank you, sir. What about the general therapies in such patient and specific therapies in such patients, sir?
General therapy, as with other cases of poisoning, keep the child closely under observation. Look for the signs or symptoms of paracetamol poisoning. Before that, if you are sure that the child has consumed the toxic dose of paracetamol, go ahead and start with the specific therapy, that antidote what we have, that is N-acetylcysteine. So, and also that stomach wash and activated charcoal are indicated. If the child has presented to you within 1 to 2 hours, go ahead and give stomach wash. And also activated charcoal is it is better to be given as early as possible, so that uh, it causes less absorption of paracetamol.
Thank you, sir. Thank you. So, sir, what about investigations, monitoring, and the practically speaking, what is the role of sending and trying to receive paracetamol levels? Can you throw some light on that, sir?
So paracetamol levels, one thing we have is something called as nanogram we put across. So we have to see the levels of paracetamol. Usually the level of paracetamol is measured after 4 hours. So something called as NM nanogram, where we plot on it. The x-axis shows the duration of hours and y-axis shows the paracetamol level. Once we have to start the paracetamol level after 4 hours, if it is more than 150 and it is coming, if this N-cysteine, that is the where we have to start the treatment on N-acetylcysteine. So if the N-acetylcysteine is coming more than the treatment value, so we have to immediately start on N-acetylcysteine treatment. If it is coming less than the treatment level, so we have to wait and watch for the symptoms.
One more important thing is that most of us will not have the facility to get the paracetamol level within such short time frame. So it's quite tricky for us to manage a case of paracetamol poisoning, just mainly on depending upon that nomogram. So if you are sure that the child has taken and he has presented to you earlier, better to treat rather than to wait for the paracetamol levels, which is very difficult to get in our situation.
Thank you, sir. Thank you very much for that. So another important aspect is a psychological aspect. A small child under 6 years of age is likely to get give out information more honestly, or the parents might give out correct information. Above 6 years, there may be intentional ingestion. So there is good evidence around it that if anyone who is above 6 years or more, you do not really take it as a word of mouth, because they may be co-ingestion, they may be intentional ingestion for self-harm. So those things are better off being looked at more seriously than just going by word of mouth. This is the nomogram that sir was talking about. So it essentially just if you look at it carefully, the line that goes at 4 hours starts off at around 4 hours, and then that is where if you have a level of 100 or above, then you absolutely go and treat it. There's good evidence to say that if it is within 10% of this level, you should consider treating these children because they are at risk of, you don't know what their baseline liver is or how it is functioning. So that is the whole point of actually having this. Plot it against if you can get paracetamol levels, and if you can't, then anything 140 or 150, please go ahead and treat it. Discussion and learning points wise, sir. So some bloods that we would want to send on these patients and the threshold for treatment. Can you throw some light on this, sir?
So treatment threshold for treatment, as you told, it depends upon the paracetamol levels, and more on our setting with the history and the clinical symptoms. So dose of N-acetylcysteine, there are two regimens. One was the conventional one, in which 150 mg per kg for 1 hour, then 50 mg per kg for next 4 hours, and then 100 mg per kg over next 16 hours. So totally it makes up to 21 hours. There has been a new regimen called SNAP regimen, where you use 100 mg per kg for 2 hours, followed by 200 mg per kg over 10 hours. And it ensures that the child is being treated as early as possible. And also it gives us more time for uh, uh, repeating the dose if there is persistent toxicity.
Excellent. Thank you. Thank you very much, sir. So just a few more things. Whatever be the case, make a decision by the end of 8 hours and institute N-acetylcysteine, beyond which the efficacy of it reduces and the benefit to patient reduces. The SNAP regimen, which is used, is predominantly used in adults and has been trialed in children, shows non-inferiority to the classical or the things. Another aspect is I would just like sir to throw a little light on acute overdose versus staggered overdose. What what is acute and what is staggered overdose?
Acute dose is consumption of 150 milligram per kg or more of paracetamol in a single day. And staggered overdose is consuming 75 to 100 mg per kg over few days. So this is the distinguishing point between the acute versus staggered. So whatever may be the case, the treatment has to be started at the earliest whenever the child presents to you.
Thank you. Thank you very much, sir. So we'll move on to another child who has come. Sushruth, he has acute injection of OP compound and then presented with poor GCS and airway secretions, was intubated by whoever could see them at that point, and then was transported because they did not have facilities out of there. So the child arrived to a hospital with who's intubated with surgical emphysema, pneumomediastinum, and then tube was completely obstructed, and obviously because of lack of expertise, inappropriate bagging. So how should we just approach this child, sir?
So one thing we have to remember, since the child has a poor GCS scale, they have intubated the child, but the child has went to emphysema. So the one thing we have to remember, before intubating, you have to atropinize the child, so which avoids such complications. So apart from that, as sir told, any poison case, we have to be constant on ABC, that is airway, breathing, and circulations. And third point is your decontamination of whatever the contents. The D stands for decontamination. That is one of the component of ABCD to be done in a OP poisoning cases.
Thank you very much, sir. Thank you. So just the general principles of management and some specific therapies, if we could just throw some light on, sir.
In this case, what might have happened is they have put the tube and the child has been brought with emphysema, all those things, complications related to intubation or improper ventilation. So probably what they could have done is they would have assessed the child properly, started atropine, and then reduce the secretions a bit and then put the tube. Probably because of over secretion, the tube might have been blocked, for which they might have used more pressure to ventilate the child, and which might have caused this emphysema and all those things. Make sure that you address the primary thing first, and also it is important to secure the airway whenever there is the low GCS. So few precautions has to be taken care of. So, and also this is a OP poisoning case. First thing is what we have to do is the decontamination. Put the do the gastric lavage, remove as much as possible, and as sir told, decontamination is also very important. Take off the cloths, clean the skin surface, skin, everything, so that you prevent ongoing absorption of the organophosphorus compound.
Thank you very much, sir. So in terms of doing this, is there any specific therapy in this that you would use medication-wise?
Specific therapy means we have a specific antidote for this, atropine. It has to be started at 20 to 50 microgram per kg every 10 to 15 minutes until the child is atropinized. And the end point here is not the secretions as such. Look for tachycardia, look for a child should be having fever, all those things. Then mydriasis. These three things has to be uh, monitored closely. Once you have atropinized, you maintain that atropinization either with continuous infusion also or intermittent boluses. So that has to be done. And along with that, another one is pralidoxime. So pralidoxime, again, there is controversy about using pralidoxime, but better to use it as it might not cause much harm. And the timing of pralidoxime, earlier the use of pralidoxime is better. So as early as possible, if you are using the pralidoxime, definitely it helps.
Excellent. Thank you. Thank you very much, sir. So other thing associated are cardiovascular dysfunction and then some ventilation supportive measures and outcomes in this patient. So this is just an example of what we did or what we had this patient. So can we just kind of break this down, sir, if you don't mind, please, just briefly. So we have an X-ray which shows, of course, left-sided heart dilatation, and of course the left side looks a little more hazy. We've got a cholinesterase levels which is less than 1, stonkingly low, and we've got evidence of myocarditis.
So this could be myocarditis with congestive cardiac failure. So in these cases, again, we'll have to go for supportive management for targeting myocarditis. And a few are the drugs which has not to be used in this case, cardiogenic shock. And the important thing is the drug of choice here would be norepinephrine rather than dopamine or even epinephrine. That is one important thing that has to be kept in mind.
And also we can use magnesium sulfate in case of arrhythmias, myocarditis followed by arrhythmias. One of the other strategies of treatment where we use in OP poisoning.
Thank you. Thank you very much, sir. So I'll just kind of run through this one. These are few things, and few important things to say. Atropine point is bronchuria should resolve because that is what you're aiming for. So that is one. Pralidoxime is PAM, and pneumonitis myocarditis to be looked for. So thank you very much for your patient listening.
I'd like to thank Dr. Anupam and other panelists. It was a very beautiful discussion regarding various poisoning in children. So I thank you all for sharing your knowledge regarding childhood poisoning.
Thank you, sir. Thank you, Anish, sir. So may I request all the panelists to be assembled on the dais? May I request Dr. Anish, sir, to facilitate all our panelists and the chairperson. I would like to call upon Dr. Anupam Jaiswal. He was the moderator for our session. Certificate. Sir, certificate. May I call upon Dr. Rachan Reddy, sir? May I call upon Dr. Krishna Kumar, sir? May I call upon Dr. Anumant Rayappa, sir, Senior Consultant Pediatrician, to felicitate our chairperson, Dr. Anish Surayman. Sir, certificate. Sir, come in. Thank you all the panelists. Thank you, moderator, and thank you for the chairpersons. Over to the MCs.
I'd like to welcome our next chairperson, Dr. Shivanand So. Sir is an associate professor of pediatrics and consultant pediatrician and neonatologist in Tatvarsha Hospital, Hubli. He has been a secretary IAP Dharwad district. He was treasurer IAP ECHG Karnataka state. He's also the treasurer IAP Dharwad district and NRP trainer, resource person for IMNC, FIMLCL, NBC, and BPNI, intensive care neonatologist and environment. To you, sir.
Good morning, one and all. At the outset, I thank the organizers, especially Dr. Kumar, Dr. Ashok, Chandan, and Arun for being a part of involving us to be part of this conference. We had an excellent conference and also a very good, what we say, yesterday banquet. So now we are moving with another topic. For this, I invite Dr. Srinidhi Ramakrishnan, who is a senior fellow pediatric intensive care unit from King's College Hospital, London. Sir has got various feathers in his cap. He is a Vishwanathan Gold Medal Clinical Pediatrician, IRP Madurai in 2022, former consultant and in charge PSU, Sri Devi Medical College, Hospital, TUMAKURU, trustee representative of PSU, South London King's Hospital, liver intensive care and transplant critical care, and CRRT fellow. Over to you, sir.
Thank you, sir, for the warm introduction. And I thank IAP TUMAKURU, Arun sir and Ashok sir for inviting me here. So straight away, I'll start my talk with a case scenario to make it more interesting. So you are seeing a scenario in the ER. So name is changed. Arav. Arav is a 4-year male child who was previously fit and well. He is presented to your pediatric ED in the late evening, probably a Saturday evening, with history of fever 3 days back, which is and also noticed some altered sensorium, vomiting, and yellowish discoloration of skin since today morning. So on examination, you are seeing him to be icteric, quite drowsy but arousable. There are no rashes or lymphadenopathy. His vital seems pretty stable, slight tachycardia, heart rates of 118, blood pressure is 92/58, respiratory rates of 24, SATs are in room air maintaining, temperature is normal. Neurologically, you seem GCS is slightly on the lower end, E3, V3 and M5, and early signs of cerebral edema you are suspecting. When you palpated the abdomen, the liver is palpable 2 centimeter below the costal margin, soft non-tender liver, and there's no splenomegaly, no ascites. Skin shows no petechiae or bruising. So very common scenarios, you get these sort of cases into your ED. So my topic for the day is pediatric acute liver failure. So why this topic is really important as in general pediatrician and intensivist is because of this data, which says from the National Liver Survey, which states that 47.7% of the deaths are reported. The data from India reports that the NLS, that is the native liver survivors of 47.7% in any acute liver failure, and deaths of 42.2%, and only 10% are undergoing liver transplantation. The proportion of patients with native liver survivors is even low in the lower age group. So this is the data from in the recent consensus, that is this taken from the Institute of Liver and Biliary Science, Indian Society of Pediatrics from 2024. So if we look at the intermediate pediatric acute liver failure, which accounted for about half of the cases in older studies, but now this is decreasing because we are able to diagnose what is the cause for this liver failure. And there is significant reduction of liver failure mortality in the West over time. But in India, it is still close to 50%. Why? because of either delay in diagnosis or limited number of trained pediatric hepatologists or intensivists or liver transplant programs that's happening in India. So coming to the definition of pediatric acute liver failure. So it is an acute onset of liver disease with no known evidence of chronic liver disease, biochemical evidence of acute liver injury, and hepatic based coagulopathy, which is defined as INR is more than 1.5, which is not corrected by vitamin K. So when it is not corrected by vitamin K is also important. By definition, it is 6 hour post 1 to 10 milligram of parenteral vitamin K. You check the INR and then you feel it is not corrected, or that is with clinical hepatic encephalopathy, or when you have INR more than 2, regardless of presence or absence of clinical encephalopathy. What is the natural history of pediatric acute liver failure? So three things can happen here mainly. One is they can be recovery without transplant, that is spontaneous recover or medical management alone. So you see most of the time this is going to happen in one or the other cases that you have managed. Second is recovery after transplant. So you have a clear-cut definition for ALF. You have referred the child for an immediate transplant. The child undergoes transplant and there is a recovery, right time and right patient, the transplant is done. Third is death despite the transplant. So it may be because of the disease progression itself or the secondary complication that happens after transplant, like the ICU complications. So this is a trajectory which shows the time in the x-axis and disease trajectory in the y-axis. So you see the green dot is the liver transplant. So when the liver transplant is done at the right time, not able to point. So you can see either recovery or the other one is liver transplant is done at the right time, but still death because of either disease progression or the complication, or recovery without liver transplantation. So now getting back to our case, Arav, who was in our ED with some jaundice. So the mother says that Arav's they had been on a holidays for 2 days, following which Arav developed some cold coryza and mild fever, for which she has been self-medicating him. But the problem was she's been giving some medicines which has been prescribed for her sister Arnavi last month. So that is, we are already guessing what's happening in this child now. So we had a previous talk on poisoning. So it could have been some overdosing of the drugs, because what was prescribed to our elder sister is being prescribed to the younger ones, because mom was on holiday and the child was having fever. Now, what are the other history to ask in finding the common etiology of acute liver failure? So you have a set of table. This is the etiology group and the possible history. So the common etiology will be infection. So you can ask about recent travels, any sick contacts. For toxin related, you ask about over-the-counter medications, herbal supplements, or any illicit drug use in 10-year or older children, consumption of any wild mushrooms in the particular areas, exposure to household or industrial chemicals, as we discussed in our previous panel discussions. Then we have some autoimmune history that can be obtained from the family. Also the metabolic pre-existing developmental delays, family history of liver disease, consanguineous marriages, or the family history of miscarriages, early infant deaths, and episode of altered mental status or confusion. So this was a table which said, now coming to the etiology of acute liver failure, there is slight difference in the etiology between infants and children. So when you come to infants, there are some particular set of etiology, either cardiac or ischemic induced liver failure, non-Wilson metabolic disease, like tyrosinemia and other metabolics which you see commonly, non-hepatotropic viruses, so herpes simplex, enterovirus, in fact Epstein-Barr virus and CMV also we see a lot of acute liver failures, gestational alloimmune liver diseases, hemophagocytic lymphohistiocytosis. These are some of the predominant etiologies which is different from the older children. So in older children, very common and most commonly seen paracetamol overdose, hepatotropic virus, we know hepatitis A, C, D, E, and non-paracetamol drug-induced liver injury, autoimmune hepatitis in adolescent, especially females. So this is the same pictorial graph which is taken again from the recent consensus, which says that they have divided the age group into the children more than 3 years and children less than 3 years. So if we see the difference, both are viral induced hepatic failure is there, but the only difference is what virus that is causing hepatic failure in a children less than 3 years and more than 3 years. So common in more than 3 years is a hepatotropic virus, whereas in less than 3 years it is non-hepatotropic virus. And acetaminophen or the paracetamol poisoning is the again predominant cause in more than 3-year children and slightly less among less than 3-year children. So now coming to how do we diagnose this? So common laboratory testing and diagnostic evaluation in any child with acute liver failure. So we have to identify, is there liver injury? So to identify liver injury, this will actually suffice, that is AST, ALT, GGT and ferritin. Then to define whether the liver function is also affected, we have to have something like prothrombin time, INR, bilirubin, total and conjugated, and total protein, including albumin, ammonia and glucose. And we have some general test because any acute liver failure generally decompensates very soon, and they'll go in for respiratory and cardiac compromise. So we do a blood gas, a complete hemogram, calcium, magnesium, phosphorus, urea, creatinine and electrolytes. So we have another set of clumsy table which says the exact investigation that needs to be done in a particular disease. So you have some of the disease which can be easily diagnosed. That is how the diagnosis of ALF in the recent years have been improving. Like systemic herpes infection, which causes acute ALF, can be detected by herpes blood PCR, urea cycle metabolic by amino acid profile, GALD screen, ferritin, tyrosinemia by urine succinyl acetone. Then you have the acetaminophen, which we discussed about levels, Wilson's disease, ceruloplasmin level, HLH. You have a set of investigations, and any infection that is causing, you always use the PCR, bacterial or viral, and then the blood cultures. So coming to finding the etiology in a setup, what is the role of liver biopsy? So liver biopsy, why is the first question to be answered in acute liver failure? Because the consensus and the guidelines, they have found that hepatic loss or the necrosis percentage on liver biopsy is an independent predictor for poor outcome, need for liver transplantation. However, this study was done with the adult, and that's extra to our pediatrics. Second is how liver biopsy is done is also important. Preferable route for liver biopsy here is a transjugular route, and whom to be done the liver biopsy. There's selected cases of acute liver failure of indeterminate origin. So when you don't have a diagnosis or suspected autoimmune, or when you have a suspected systemic disease like malignancy or mets, to confirm your diagnosis, liver biopsy will help. Now coming back to Arav. Arav was in ED, so he's being shifted to PICU. Why? Because in view of low GCS and suspicion of ALF, for the continuous monitoring and further management. So what are our main concerns of management of an acute liver failure? So acute liver failure, mainly encephalopathy is what we are worried. Coagulopathy is other thing that we are worried. Electrolyte imbalances, septicemia or infections, and acute kidney injury. So this chart describes everything that in PICU we have to do for a child who is in acute liver failure. So other important thing is the monitoring. So if you look at this table, they have divided the monitoring interval based on hepatic encephalopathy, which is grade 1, grade 2, and grade 3 and above. So the interval of the monitoring shortens as the encephalopathy grade keeps increasing. So the mainly we are monitoring for neurology, vitals, sugars, magnesium, ammonia, liver functions, and liver injury tests, and preferably in every shift or 8th hourly based on the hepatic encephalopathy. Now coming back to our case, So what is the specific management in PICU that we have to do for acute liver failure? So fluid, electrolyte, and glucose is very important. Maintaining glucose level between 90 to 120 milligram per DL. Protracted and profound hypoglycemia may be suggestive of an underlying metabolic defect. So have a glucose infusion, which is approximately around 10 to 15 milligram per kilo per minute, and IV glucose concentration needing above more than 20%, which may require a central venous catheter incision. Sodium is required at 2 to 3 milli equivalent per kilo per day, and maintaining sodium on the higher range, 145 to 155, may improve also the intracranial hypertension. Hypophosphatemia is very common and should be treated to keep serum levels over 3 milligram per DL, which we often forget in an acute liver failure. Fluid is restricted to 2/3, and diuretics can be used if refractory ascites starts happening in acute liver failure. However, HRS, hepatorenal syndrome, will precipitate when you start using more diuretics in a child. Next, we have hepatic encephalopathy or hyperammonemia and cerebral edema management in PICU. So the neuroprotection strategy is a standard protocol that we use with elevated head of 30 degrees, head in the midline, adequate ventilation, either choosing pressure or volume control based on your unit protocols, adequate sedation and analgesia based on the comfort score, dim, quiet, dark rooms with no sudden noises and light changes, minimizing tracheal suction, or if required, should be used with always bolus sedations. And lactulose, yes, we always prescribe lactulose at 0.5 to 1 ml per kilo, up to a maximum of 30 ml per dose, to produce at least 2 to 4 stools per day. And this is by acidic intraluminal environment when ammonia is converted into ammonium and that is not being absorbed. Rifaximin, yes, decreases the ammonia production in the gut and helps in acute liver failure and hepatic encephalopathy. Lola, L-ornithine, L-aspartate, there is a role and a study from adult, but however, in pediatric role has been not completely established, and few centers started using Lola, but some centers definitely are not using. The next important monitoring that we do is the ICP monitoring in case of hepatic encephalopathy. The gold standard, they say, is invasive bolt, but however, in an acute acute liver failure, the fear of bleeding is always there. Non-invasive role is very high and commonly done. ONSD, NRS, and TCD, optic nerve sheath diameter, the near infrared spectroscopy, and transcranial Doppler, which we had a workshop day before yesterday, where we discussed all these things. So very, very useful parameters in a PICU, bedside, reliable, reusable, and there is absolutely no adverse as such other than some heats from the ultrasound. And overall goal from neuro point of view, so we have to have our ICP less than 20 and cerebral perfusion of more than 50. Again, if we go in little deep, we have cerebral perfusion pressure based on the age, that is more than 4 years 50, and 4 to 10 years 55, and more than 60 for more than 10 years. So this is a pictorial representation for transcranial Doppler, where I have focused on the above image, the targeting the M1 of the middle cerebral artery, and the auto calculation of PI. So PI for children anywhere less than 1.4 is accepted. More than 1.4, the rise for the chance of increased intracranial pressure starts going up. So on the other side, the picture shows your optic nerve sheath diameter, which is being taken 3 millimeter below the optic disc and then transversely measured. So anything less than again, it's as an age dependent thing. So generally we say anything less than 0.5 is still accepted for no raised intracranial pressure. Next, coming to the important one, that is coagulopathy in acute liver failure. So in acute liver failure, generally what happens is it's a rebalanced homeostasis where proportional reduction in both pro and anticoagulation is happening. So IV vitamin K, we have to replenish. The dose is 1 milligram to 10 milligram. The preferred route is subcutaneous than IV or IM by the latest consensus from ISPAGAN. Routine correction of INR and prothrombin time, yes, definitely not recommended in lower invasive procedures like CVC or ascitic tap. However, having said that, correction of INR and platelet and fibrinogen levels prior to high-risk procedures, either percutaneous or transjugular liver biopsy is definitely indicated. So TEG is the commonly happening in many of the bigger institutes now. That is thromboelastograph. It is used to assess and correct coagulopathy as a real time. So you can see on the other picture where we have alpha angle K and which easily depicts which of the parameter is on the lower side, either platelets, fibrinogen, or the enzymes. Okay. Okay. So kidney injury. In acute liver failure, renal injury is presumed acute in nature and otherwise recoverable. It is mainly because of nephrotoxic drugs, systemic hypotension, and CRRT should be initiated in all ALF with persistent acidosis, dyselectrolytemia, fluid overload, and ammonia levels more than 150. So the what I want to stress here is the high volume CVVH versus low volume CVVH. King's College recommends for high volume CVVH, so that is up to 90 mils per kilo, then 20-35 mils per kilo for better clearance of solutes and ammonia.
Anyway, we are going to discuss this in the next talk. So we'll wind up.
Sure. Thank you.
For the want of time, would like to,
So
closing comments, please.
So this slide before closing. So bridging therapies is important of acute liver failure. Therapeutic plasma exchange, MARS, molecular adsorbent, that is albumin based dialysis, CRRT, and extracorporeal assist devices are used currently for. Okay. Thank you.
Thank you, Dr. Srinidhi. Dr. Srinidhi is a visiting consultant from UK. He is working at the same institute where the King's College criteria was developed. So it was indeed our pleasure to have him here. May I request Dr. Srinidhi to may I request Dr. Shivanand sir, chairperson for this talk, to hand over the moment of hello. Bunny keynote address bunny. Barade bunny. May I request Dr. Nayaz Ahmad sir, senior consultant pediatrician, to hand over a moment of felicitation to Dr. Shivanand, our chairperson. Thank you, sir. It was wonderful to have you here. Certificate course. Thank you. With the end of this session, we will move on to the keynote address. May I request Dr. Ashoka C, IAP TUMAKURU Secretary, and Dr. Chandan C.K. Ashoka C, President, IAP TUMAKURU, and Dr. Chandan C.K., Secretary of IAP, to come on to the dais, please. Thank you, sir.
Good morning. It's indeed a great pleasure to welcome my teacher, our mentor, Dr. Madhu Pujar sir. I was his student during my undergraduate days. He is currently working as professor of pediatrics and a in charge of PICU and pediatric intensivist in Bapuji Child Hospital and Research Center. He was a central IAP EB member from 2022, honorary secretary of Karnataka State of IAP in 2019, organizing secretary South Zone Pedicriticon 2019, honorary secretary respiratory chapter of IAP, secretary Davangere district branch 2008 to 9, and national pulse trainer. Is a good speaker who we love to listen during our undergraduate days. It's indeed a pleasure to have you, sir. Welcome, Dr. Madhu Puja, sir.
Thank you, Dr. Chandan, for this nice introduction. And good morning to all of you. So at the outset, I would like to thank all the organizers, especially my students, Dr. Chandan, Dr. Ashok, and the IAP TUMAKURU branch and also Sridevi Institute of Medical Science and Research Centers, office bearers, and all the senior dignitaries who are sitting here. So I would like to thank them for giving me this opportunity to speak on this subject of artificial intelligence. I know this artificial intelligence is little off topic. This is not a very core intensive care chapter or intensive care talk that I'm going to give it to you. And you all agree with me that the artificial intelligence nowadays is a buzzword. You take a businessman to a politician, students to a teacher, or even sports person, or even doctors to patients, they would talk about artificial intelligence nowadays. And before I start my talk, so may I ask you in the audience, because there are few students also in the audience, how many of you think that this artificial intelligence is going to take away the job of doctors? So I'm very happy to know that none of the hands got raised. This is exactly I wanted to tell, that AI is not a replacement for doctors, right? AI can only augment the work that what we are doing. Yeah, sorry. How this goes? Yeah, previous slide. Okay. Yeah, the disclaimer is I am not a specialist in artificial intelligence, but I do use artificial intelligence in some ways in my medical teaching to teach the undergraduates and postgraduate students. And here in this hall, there are some tech-savvy persons. Dr. Malesh Gowda is here. He also would have used artificial intelligence maybe in his clinical practice. So what I'm going to tell you is I'm not a specialist in artificial intelligence, and whatever the message that I want to give it to you, so I got it through the literature that I've searched. Just to take you to the incredible journey of the pediatric critical care in India. So in 1990s, I joined in the MD Pediatrics in the year 1999. So at that time, so we usually manage our children, sick children in general wards. Okay. And as you could imagine, most of the sick children, the sickest children, had a very bad outcome. And there were no dedicated monitoring or the protocols to guide us. The teachers were there, they used to guide us, but there are no dedicated monitoring or protocols that guided us. And I still remember, so our college is also attached to government hospital. So in government hospital, at that time, when I was in the third year, they got a ventilator, but the ventilator was there, that there was no ABG machine and there was no monitor for it. So those were the days that we had worked. And what happened further? So probably in the late 2000s or mid 2000s, so we had dedicated PICUs. First, it came up in the centers like metro centers like Bangalore, Delhi, and ventilators were introduced for the first time in the selected cities. We also got ventilators because ours is a medical college hospital, so we got ventilators in the year 2000, so 2001 or 2002. At that time, as postgraduates, we were not allowed to touch the ventilators. So we used to intubate the child and call our teacher to come and connect the child to the ventilator. So those were the days of 2000s. In 2001s, I think the pediatric critical care as a subspecialty got evolved, and we had a lot of national guidelines coming up and a lot of training programs, fellowship programs started, and DM critical care started, and this multidisciplinary care that we usually give it to our sick children nowadays. So we have a dedicated nurses, respiratory therapists, and all those came in the year 2010s. And today, as we stand today, most of our district hospitals, the PICUs have our PICUs, district hospitals have PICU, and they have come a long way in using these sophisticated gadgets like HFNCs, POCUS, and telemedicine. And friends, the future is little different. The focus will be next on equity, and wherever the patient goes, wherever a sick child goes, the child should get an equal care, whether it is in the government hospital or whether it is the private hospital. So the focus will be on that part. And artificial intelligence experts believe that artificial intelligence may have a big role in the management of our patients, because this artificial intelligence, so-called AI models, will get integrated. So they believe that it get integrated to most of the monitors that we use. For example, our ventilators, our channel monitors. So it gets integrated and help clinicians or intensivists, okay, so to recognize the clinical condition early and take care of the child. And also there will be increase in or there will be improvement in the transport system. And next era is data driven care. Friends, we are very fortunate. So we are in that middle period, so where we have been taught how to take care of sick children by great teachers. So they taught us how to take care, how to talk to a child, how to talk to a parent when the child is there in the PICU. So we learned them by just looking at them how they speak, by looking at them how they counsel. So that is already written in their books that they have published. So I am the student of Dr. M.L. Kulkarni. So he has written this book called as Clinical Methods, and he used to teach this for us in every class that he used to take to us. So he said medical practice is a beautiful amalgamation of science and art. 80% of it is art and only 20% of it is science. So that's what he used to teach us. And he used to tell, whenever you see a sick child, touch the feet of the sick child and take blessings. What does he mean by that? A sick child would have come in state of a shock, respiratory distress, or even in shock. So by touching the feet of the child, first you always palpate the arteries, lower limb arteries, posterior tibial arteries. Okay, so that's what he meant. So if you cannot palpate the dorsalis pedi artery and the posterior tibial artery, so invariably your blood pressure should be less than. That's what he taught us. And families, remember your kindness more than your prescriptions. And practice clinical medicine and not clerical medicines. These are the words that used to give him. And he also used to tell one more word, that take it with a pinch of salt whenever somebody comes to you with a report which is generated by a computer. Okay, so twice before considering if somebody comes to you with a computer generated report. So, and Dr. Y.K. Amdekar, in his book, What Doctors Must Learn, he has written, medical practice is becoming more of high-tech medicine, and the traditional high-touch medicine is giving away to no-touch medicine. What a wonderful statement. And friends, it is exactly what is said is becoming true. Right? So nobody of us, when I ask this question, whether AI is going to take over the medical profession. So experts who are in the field of artificial intelligence believe, Bill Gates says that within next 10 years, artificial intelligence will replace many doctors and teachers. Humans won't be needed for many of the things. So that's what Bill Gates thinks. And there is also a doctor who has put up this one more piece of information in the newspaper. So there was a jugalbandi between the artificial intelligence and the experience of a doctor, and when it comes to making a diagnosis in a given child. And to his or to everybody's surprise, so artificial intelligence scored over the 20 years experience of the doctor. And not only the experts, even the politicians also believe that artificial intelligence will take away many jobs or all jobs soon, especially the medical jobs. And you also have seen that, so there is a dedicated hospital which has come up in the China. So the 42 doctors and 4 nurses who are working in that hospital, they're all robots. And the hospital is managed by artificial intelligence only. So these kind of reports that we see. And this is the survey that is done by this Customer Times of the artificial intelligence in the healthcare, how transformative or the potential that it has got. And it is done for the public, general public. And 2 out of 3 people think that AI will be better than humans in diagnosing and treating conditions. 60%, 60 to 70% of the people are already thinking that artificial intelligence will be better than the humans or the doctors. And 1 in 10 think that AI should replace doctors, completely replace doctors in the future. So see what is happening. Okay, so now I am at the crossroads, isn't it? So our teachers has taught us to hold the hand of the child, talk to the family, right? So, and in other things we have innovation where doctors are not needed. Only machines will take care, right? So I am really at the crossroads. I'll just tell you what is about artificial intelligence is all about. So I think most of you may know it. It is the development of the computer systems that are capable of performing tasks, the machines which can perform tasks which the human can perform. They thought that these tasks the machine would not perform, such as taking a decision, object detection, solving complex problems. These are all the tasks that a human can do. But nowadays they have shown that these tasks can be also be done by the machines, by our computers, and they can do in some areas much better than humans. What does it analyzes? What it does is, because it's a computer, no? Because computer has lot of data, correct? Lot of data. So artificial intelligence, what it does, it analyzes large set of data which is there, and by analyzing that, it identifies the patterns. So every data will have some pattern to it, right? So it analyzes the patterns and assists in decision making. So when some question is asked to that artificial intelligence model, okay, and it has got a tremendous capacity to process and learn from the gigantic amounts of the data, okay, in a blistering speed. So which humans cannot do, that artificial intelligence can do. So that's what artificial intelligence is all about. So there are some key concepts of artificial intelligence, how a computer can do all these things. I'm not going in detail because I'm not a technical person. But when we start reading these papers regarding healthcare associated papers with artificial intelligence, you do come across such type of terminologies. The one terminology is called as machine learning. There is a lot of data that has been put into the computer, right? The computer learns from the past data and it recognizes a pattern, okay, and it gives out an output, right? So there are a lot of inputs that have been put into the computer, and what computer does it, whenever somebody asks you a questions, so it scans all the data which has been put into the computer and it comes out with an output, right? For example, this type of machine learning has been used in predicting the length of the hospital stay in the PICU, estimate sepsis risk using the vital signs. I'm just giving an example. Deep learning is a subset of machine learning. In deep learning, what machine does is analyzes the complex data with neural networks. There are so many other computers which are interconnected, so many other data which are interconnected, and it analyzes and comes out with an answer. For example, if you put a X-ray, okay, so to a artificial intelligence, so it analyzes the data and then tell you, so this is where the problem is and this is what the diagnosis is. Natural language process, it understands the process of the clinical notes that they have been fed to the computer, and it helps us in creating documents. It helps us in creating discharge summaries. So many things it can do, and it can all accumulate all the data which have come from the electronic medical records, and then it can give us a summary of all those things. Okay, so now let me ask some questions. Okay, the first question I would like to ask is, are you using AI regularly? Who is using AI regularly? Okay, 1, 2, 3, 4, 5. Okay, so there are about 5 or 6 hands which have gone up where they say that AI will use regularly. And which one do you use? So everybody says Chat GPT. Anybody else? Google Gemini. Yeah, anything? Anybody else? Sorry? Perplexity. Okay, so fine, good, good. So there are beautiful audience here who use differently. Please remember that AI can just be compared to the models of transport. You can see there are many models are there. We have an auto rickshaw. So we have a car, maybe a supercar, a multi-utility vehicle, an ambulance, okay, and a designer car. In a similar way, how these cars are built, the purpose of all these vehicles are the transport. But the way that they are built is different. So as our artificial intelligence models. So they are built in a different. So they can perform in different, in a different varieties. Okay. So for example, if you use a lightweight AI apps like free chat box and LLMs, and you may not get a perfect answer that you're looking for. That's what I want to say, right? So if you want to get an answer, for example, if it is related to a medical field, so you have to use that artificial intelligence model which is built for that, right? So all apps are not the same. So if somebody wants to write a scientific article or a review article, so that's what they use. They use Perplexity as an app which gives a quality resources, data and references. And what they do is, if they after they collect all these data references and they feed whatever the data they have got to another AI called as Claude, and the Claude analyzes your data and it transforms into your text and it gives you a paper that you want to publish. There is one more app called as Notebook LLM. So this usually we use this app for our teaching purpose. So any PDF files you can put into this app, Notebook LLM. So it scans the PDF files and it makes a very important points to you. You can ask this app to prepare an MCQ also for this PDF file. It prepares an MCQ for it. Okay. You can ask the app to prepare a PPT for you based on what the PDF file that you have put in. So it prepares a PPT for you. So different apps are built for different things. If you want to create, if you are a very tech savvy, if you want to create a content, for example, posters, ad pages, creatives, leaflet, designer page, then use ChatGPT. If you want to make a beautiful presentations in your medical thing, so use this AIs like Gamma and Napkin AI, right? Okay. So this AI apps, this slides will show you the AI apps for medical professions. They are still in the development stage. So there is an AI app called as Heady Health and Abridge. So if you open this app, so whatever the conversation that is happening between a patient and the doctor, or whenever this app is opened, when the discussion is happening between the student and the teacher, or from the postgraduates, from the teacher to the postgraduates, everything will get documented. Okay. So you can use this for the documentation purpose. There is no need to type it, and everything will get stored in that particular patient data that can be used. And for example, if you want to diagnose any images by maybe images, clinical images like a dermatology image, X-rays, MRI. So there is an app called as Visual Diagnosis app. Just put this app, put your image into the app, it will try to give a differential diagnosis. And clinical decision making. So there are apps up to date. Many of us do use up to date, but it has got an app, AI app, which can help us in decision making, clinical decision making. And there is one more app which is coming up. So Open Evidence AI. So it is also helpful for clinical decision making. I'm just giving an example. A 6-year-old child presents with recurrent seizures, fever, and delayed milestones, and you put this in an app. So if you use that app for a general purpose app, okay, so like ChatGPT, like Claude, so what we get is some general knowledge regarding that particular problem, clinical problem. It suggests common causes. It recommends some general tests like EEG, MRI, and it gives a broad guidance like that. But if you put that same query in a specialized app, medical AI app, so the data that we get is usually scanned from the pediatric textbooks or guidelines in the literature, and it gives a structured differential diagnosis, and it can suggest a specific tests, and provide detailed guidance and all these things. And even the guidance can be taken up from all the recent guidelines that have been published in the literature. So that is the difference between a general AI app and a medical AI app. And why in PICU? Why an AI will help in the PICU? Because all of you know, as intensivists, there's a lot of physiological changes that is happening in our children. Okay, so we take care of newborns, toddlers, adolescents, and most of these patients in the ICU, they have multisystemic involvement. And to predict their mortality, their length of hospital stay, so we take a lot of clinical parameters, lab parameters to predict it. Like we have SOFA score, Q-SOFA score and all. And high variability in the presentation or in the physiology makes prediction very difficult with the conventional scoring tools that we use. This is where AI can help. And there is enormous amount of data that is being produced in the PICU. Like continuous monitoring will be there. So we have continuously, patient will be having heart rate, SpO2, EtCO2, blood pressures, ventilator waveforms, so many data should be producing every minute, every second. And apart from that, we have frequent labs, radiology, blood gases, and there are a lot of unstructured data as well. And the challenge is no human can track all this data and integrate this data, thousands of data, and come out with a pattern. So it's not possible in the humans. The human limitations, as I told, it is a fatigue, cognitive overload, and there can be variable expertise and delayed recognition of this subtle changes. The strengths of AI is it processes this multimodal data, the streamline, the real time. It detects patterns invisible to the human eye, right? And it provides early alerts, predictive risk scores, and help in the decision making. Okay, so these are the applications that are being used in the critical care section. So when it comes to the AI applications in the critical care, so in the PICU, it is used to detect or to predict length of hospital stay. It is used to predict the readmission and mortality, and it is used to predict the risk of a child developing sepsis, of a child developing ERDS, and also when we can successfully extubate the child. So when the parameters are fed into the AI model, the AI will come out with an answer. So the risk factors or the prediction that we can do. So this child may go for sepsis. Okay, this child, by looking at this, so this child may not be ready for extubation, right? So we do that regularly. I know we do that. We do that by putting all the scores. Okay, but AI generated score can be much more faster and much more reliable. So AI is also used in the personalized care. So we have already available in the market mechanical ventilators where AI already been integrated. So as soon as you put the child to a mechanical ventilator, so the first breath or first or two breaths, so the AI which is there or the AI model which is there in the ventilator, it assesses the respiratory mechanics of the child and it prompts. So this is what this child requires. Okay, so this is the mode you can use it in this child. This is the PEEP that you can use it in this child. So such type of AI models is already there. And it also tells us the ineffective breaths, right? So especially during the ventilator patient asynchrony, isn't it? So whenever there is a ventilator patient asynchrony, so the ventilator breaths are not delivered properly to the patient. So the AI will tell us, so this patient is not getting effective breaths. So you can change your mode or you can sedate the child, something like that, okay? And patient-specific sedation management depending on the parameters of the child, depending on the weight of the child, depending on the clinical condition of the child. So if you feed that, so it will come out with an algorithm saying that these are the sedation that can be used in this particular child. Coming to a few slides of sepsis prediction, I know sepsis is a very important topic for all the intensivists because early detection of the sepsis is critical for survival of children. And the current practice is to use this scores called as SOFA scores, Q-SOFA, all these things, SIMSRH scores we use. But the problem is it has got a variable sensitivity and specificity. I'm sure everybody agrees with me, and often delayed response to subtle deterioration that happens. And sometimes we may end up in recognizing it late. So what they did, there is a study from the Stanford University. So what they did was they collected all the data from the children and fed to a AI model, and they compared. Okay, they compared with who is better, whether the traditional methods that we use, like using Q-SOFA score and other scores, whether that is better, or the prediction by the AI model is better, right? So what they did was, so they collected the data from the paper charts, from the electronic medical records, real-time analytics, okay, and then fed it to the AI. And the AI, it gave alert 2 hours before a first clinical sign of sepsis developed. So that's what they claim. That's what they claim. And there has been study also to show that AI interpretable machine learning models accurate for prediction, and the development of validation of an artificial intelligence predictive model to accelerate antibiotic therapy for critically ill children. Okay, so the objective of this study was to develop and validate local AI models predicting critical sepsis among ED patients, emergency department patients where they were admitted and they're about to go to PICU, and they would not give antibiotics simply like that in the Western countries. Only if they feel the child is having sepsis, then only they give antibiotics. And this is what the AI model predicted, so that these children may develop sepsis by scoring it. So what they did was they put all the vital signs, all the demographics of the children, labs, demographics, comorbidities to the AI model, and hope that AI model will come out with a early alert. And this is what is the essence. So the performance you can see is much more better when AI model predicted the sepsis, risk of sepsis, how early it can develop risk of sepsis when compared to the other vendor models like Q-SOFA and other SCOFA scores. Okay, so the takeaway message is AI tailored to pediatric workflows can dramatically improve early sepsis detection and prompt timely treatment. These are the difference between a traditional and predictive models. I'm not going in detail because it says that AI predictive models, how it is used to predict and what are the the principle behind it. So how it can predict, this is what it says. So I'll not go in detail. So there are many other studies which are also says that length of the hospital stay. So the AI prediction will be much more better than your other scoring predictions that we usually normally do. So there are about 2 papers which are telling about the length of the stay in the hospital, and in both of the studies they mentioned or they showed that the AI prediction is much more earlier and much more accurate, okay, than your human prediction. Okay, so similarly there is also also regarding the mortality. So there are about 2,889 patients were analyzed when they got admitted to the PICU, and they compared with the PIM3 and the PIM-LRM data, and the AURC was 0.82, which was very significantly better in an AI model. Okay, so similarly, there have been some studies for the prediction of ERDS when the child got admitted with the respiratory problem. Okay, so whether this child is going to for the ERDS or not, and for that we do many scoring systems, and they have also have come out with the AI models which can predict the ERDS scoring. Okay, so what we came to know that the traditional models, artificial models, we cannot use it. We cannot use it when we want to get some results for our patients who are admitted in our PICUs. So what do we ideally want as an intensivist? An AI model to have is all these things. Real-time data integration, the AI model should process, early warning detection, decision support, continuous learning process, all these things I want this in my AI model. Is there a one? No, there is no. Okay, so an ideal ICU AI should act like a vigilant junior consultant, awake, always analyzing and always supporting the team. Is there a one? As of now, it is no. Okay, so I will just click the slide and challenges. There are quite a few challenges when it comes to the artificial intelligence. The artificial intelligence is based on those data that we have been provided. Whatever the data that we have been provided to the AI models, so the AI models will predict or will analyze or will pick up the pattern then only it will come, right? So it is the quality of the data that we put into the AI models becomes very, very important. We cannot be relying on an AI model which has come from the outside. Stanford, we cannot be relying, because their data, the patient set of data is different, their demographics is different, their patients are different, our patients are different. So what a good AI model wants is the data. So that is where we lack. And integration into the workflow system, AI alerts must fit in seamlessly into the PICU workflow. So that is a challenge. And cost, of course, because most of the newer technology initially will cost. And if somebody is using Chat GPT, most of the Chat GPTs that we use are free, and a free Chat GPT will not give you so much of messages rather than a paid Chat GPT like that. Okay. And there are a lot of ethical concerns. What happens to this data that has been put? What this data has been hijacked by the technical people? Okay, so all these things are there. So these are the challenges and limitations. And in the global context, India has got a huge volume of pediatric critical care. There is no doubt about it. There is a valuable data source, isn't it? So many patients would get admitted to our PICUs. And recently we had a PICU data. So there are about 488 centers that have been in the PICU data, which has recently been released by the central intensive care chapter. And this national and regional PICU registries have to be maintained, because we have the data now, how many PICUs are there. And we have to promote our own models of artificial intelligence to come up to help our own children. And how we can do that? We can always collaborate as intensivists, as doctors. We should collaborate with those technical people. So there are many technical people or younger engineers who have been trained in the AI. So they want to start up. They want to do some startups. So we can collaborate with them, and we can tell what we want from our side, so that we can come out with the data. Challenges are, in India, there is fragmented health data system. And the biggest problem in India is, even now, most of our data is from the paperwork. Do you agree? Most of our data is from the paperwork. In the Western countries, it is more of EMRs, electronic medical records. And there has been an app which has come out from the Indian entrepreneurs, where they have created an app. All these paper, whatever the data that is there in the paper, is also converted into a electronic data. So there have been already the work is going on. Okay, fine. So many of us, friends, we don't want, okay, somehow we are just reluctant, okay, so to use artificial intelligence. So because it can become quite easy. It can become quite easy if you use artificial intelligence, okay, so in managing our patients. And this person said that every physician in this country in the next 5 years could have 4 or 5 AI interns working for them. Okay, but friends, there is nothing like AI. The machine is replacing the doctor. Okay, so there is something called as irreplaceable human factor. Okay, when a mother comes and asks me, doctor, will my child will be okay? So you can't ask your machine for that. You have to hold the child's hand. You have to take the family into the confidence, right? So medicine is still a human-centered practice. Artificial intelligence, it lacks emotional intelligence. Emotional intelligence is the domain of the humans, isn't it? Like, for example, breaking bad news, calming anxious parents, it demands empathy, which you cannot expect from the artificial intelligence, from the machines. And there are complex clinical judgments that a physician or a intensivist have to make, isn't it? So critically ill children will present with multifactorial conditions. So they can have an autoimmune disease, infection, so many things we can have, right? So all these multifactorial conditions, whether artificial intelligence has a capability, okay, so to delineate is a big question. And human clinicians apply experience, context, and intuition in treating their patients, in treating their children. And guidelines won't always fit every day in the real life, right? Okay, and ethics and responsibility, as I told, because there are too much of data that is generated, and this data can be misused if you are not know very careful enough. Okay. Okay. My take-home message. Just spare me about 2 minutes. My take-home message is: artificial intelligence is a tool, but not a replacement. Artificial intelligence just assists the intensivist in monitoring, prediction, and decision support. It can augment vigilance, but cannot replace human judgment. Augmenting care, it only augments our care to our patients. It doesn't replace the compassion that we have as doctors. AI can detect patterns, but only humans will provide empathy, context, and ethical decision making. Clinical value, of course, it has got some clinical value. So AI offers earlier recognition. It reduces the it reduces the alarm fatigue, and so many. It can make our work better. So-called the paperwork, okay, and sometimes some clinician take it as a donkey work. So all that AI can do, right? And it supports intensivist making timely data information. And the challenges remain that data bias, interpretability, ethical consideration. These are all the challenges that remain. The human element, my friends, is central. So AI may guide us with insights, but compassion guide our actions. So, friends, I would like to tell the future of the PICU is not man versus machine, but the man with machine, always guided by compassion. Thank you for your patience.
Thank you, sir. I would like to welcome Dr. M.R. Hulnaikar, sir, Chairman and Managing Trustee of Sridevi Group of Institutions. We welcome you, sir. And I also request you to join the dais along with Dr. Ashok, sir, and Dr. Chandan, sir, to felicitate our speaker, Dr. Madhu Pujar, sir.
I forgot to mention earlier, Dr. Madhu Pujar sir is the president-elect and is going to be the next president of Karnataka Pediatric Intensive Care Chapter. Congratulations and all the best for you, sir. Thank you.
I also request Dr. Hulnaikar, sir, to felicitate our chairpersons, Dr. Ashok, sir, and Dr. Chandan, sir.
Thank you. Thank you, dear Madhu Pujar sir, and thank you, dear chairpersons. With this, we conclude the keynote address. And with this, we also continue with the Hall B sessions. Those who are interested to join us in Hall B, they can proceed with that. We'll continue with the Hall A sessions. The next session is on oncological emergencies. For the introduction of the speaker, I would like to call upon Dr. Shivprakash BV. He is a senior consultant pediatrician working at District Hospital.
Good morning, sir. Dr. Shivprakash BV, He's a consultant pediatric department in District Hospital Tumkur. He developed Department of Pediatrics in District Hospital from 2018. He upgraded SNCU with 40 lakh CSR funding. Started thalassemia unit in association with Sankalp Foundation, now having 55 children with thalassemia. BMT done successfully for 5 children, and he's running 10-bedded nutritional rehabilitation center in District Hospital premises successfully. Over to you, sir.
Thank you. At the outset, I would like to thank the organizers of this conference for calling me as chairperson. Dr. Stalin Ramprakash is a consultant pediatric hemato-oncology specialist and doing BMT also. He is attached to Aster Group of Hospitals, Bangalore, and he has worked abroad in Royal College of Pediatrics and Child Health. He was invited speaker for many national and international conferences. He has 50 research articles and national and international journals. And his area of expertise is pediatric hematology, oncology, and bone marrow transplant. I would invite him to speak.
Thank you very much, Dr. Shiva Prakash, for the kind introduction. And thanks for the organizers, Dr. Arun, Dr. Pallavi, and the institution for giving me this opportunity. So we'll just go ahead with talking about the pediatric oncological emergencies. So on completion of this lecture, we should be able to recognize the common pediatric oncological emergencies and avoid potential mistake where we can do things wrong. So that is the an urgency of the treatment. So the pediatric oncological emergency can present in various reasons. Either it's infectious and inflammatory reasons, or hematological complications, metabolic complications, and mechanical effects because of the size of the tumor. So the most common pediatric emergencies are septic shock, hyperleukocytosis, tumor lysis syndrome, mediastinal mass, acute spinal cord compression, respiratory failure, and CNS events. I will just quickly go through these things. So first we'll start with the case. 14-year-old girl with AML, currently on treatment, on chemo, and she's having a neutrophil count of less than 100, and she's been complaining of abdominal pain, and a surgical review is requested. So she is obviously come with fever. So febrile neutropenia is one of the important complications of in oncology. So where there is a fever more than 38 degrees and there is neutrophil count less than 500. So if there is, so you have to do a thorough clinical examination, do the cultures, and most of the patients can quickly go into shock. So that is why it is very important. So we need to understand how this historical context of febrile neutropenia came along. Previously, people were treating like general pediatric patients, where you just try to judge whether the patient is sick or not. In these patients, they don't give time, so you don't think too much. So if they are neutropenic and is having fever, you straight away do the right things and start antibiotics. And often the reason is because there is no neutrophils and there is mucosal barrier has been damaged. So bacteria is free to enter the body from the gut and go anywhere and causes severe illness. So 12 hours after the admission, she's complaining of severe abdominal pain, and it is getting worse in the right lower quadrant. So what would you do? You do a chest X, CT abdomen, and the CT abdomen shows thickening of the bowel wall. So this is the sort of classical presentation of neutropenic colitis or typhlitis, what as we call it. So a lot of conditions can mimic it, but so most important in a neutropenic patient is the typhlitis, which has to be aggressively treated with multiple antibiotics and nil by mouth. And sepsis, in terms of what is the clinical presentation of sepsis in a neutropenic patient as opposed to any other patient, most of the time the clinical presentations are the same, but they don't give you time. So they can deteriorate. Morning patient can come in with fever. In the evening, they may be in the ventilated with multiple inotropes. So that is the most important thing we worry about is the gram-negative rods, so which is the causes severe septicemia. So we have to start them on empirical antibiotics, and if the patient is hemodynamically unstable, we'll have to go to the PICU. And any lines, most of the time, this is one of the reasons. So don't delay removing the lines, because that is often the source of infection, or most of the gram-negative multi-resistant bacteria stick to these lines and they don't go away unless you if you don't remove the line. So that is very important. So sometimes they can progress onto ARDS because of multiple comorbidities and other issues along which happens in these patients. So as you all know, the sepsis, so systemic inflammatory response due to infection is sepsis, and it can progress onto severe sepsis with multiple symptoms, and it can progress onto multi-organ failure and then eventually septic shock. So as pediatricians, we need to know what is the difference between the cold shock and warm shock. So warm shock is where there is peripheral vasodilatation, and which is a little relatively easier to manage. And cold shock often comes later, where there is peripheries are cold and they are in actual shock with low blood pressure. So one of the things which many people don't realize is that the difference in the progression of shock between the adults and children. In adults, because their systems are not very the compensatory mechanisms are not very good, so they will sort of gradually quickly they will drop the blood pressure and will become unwell, whereas the children will hold on to it until the last minute. So if the child has actually dropped the blood pressure and gone into septic shock, it is actually quite late in the progression of the septic shock. So the ideal aim has to be avoid this situation. You treat before the patient drops the blood pressure. This is one of the clinical findings. So ecthyma gangrenosum, where there is often multiple emboli from the in a neutropenic patient, where you can have these lesions, which shows that the child is quite sick. And if you see that, you have to recognize it. And sort of another such thing which can happen is that so this tender rash, which with purplish hue, which often progresses. If you see that, that is a real medical emergency because that is necrotizing fasciitis. So if you see that, urgent surgical debridement is needed, and you have to call the plastic surgeon immediately. Often it is due to Staphylococcus, streptococcus. Most often they will progress to septic shock very quickly. And early and aggressive management in the first hour is very important outcome. So febrile neutropenia is a medical emergency. Cutoff temperature is 100.5 or 38 degrees. Early antibiotics without delay and aggressive treatment is needed without waiting for confirmation of infection. And so the other inflammatory emergencies which can present in the pediatric oncology age group is pancreatitis and sometimes hemorrhagic cystitis, and other metabolic and electrolyte imbalances. So we'll go to the next case. 11-year-old boy presented with 3-week history of lethargy, pallor, and last 3 days he's developed spontaneous bruising. You did the initial blood test, hemoglobin is 4.2, white cell count 300, and platelets of 3. And most of the white cell counts are blasts. So what are you going to do now? The hemoglobin is very low. Are you going to give a blood transfusion? Are you going to give a platelet transfusion? So you discussed with the oncology center, and they asked you to give some platelets and urgent transfer and start hyperhydration. So after starting the hyperhydration, suddenly child develops ventricular tachyarrhythmia and then goes into a cardiac arrest. You did a blood gas. The blood gas shows potassium of 8.4. So what happened here? So this is a tumor lysis syndrome. So where there is tumor lysis, the features of tumor lysis syndrome are inside your cell, you have got a lot of potassium and phosphate. And so when there are a lot of cells break down at the same time, they release all the potassium in the system very quickly. And then if you're not able to clear it, then you are going to go into arrhythmia. And that is one of the important medical emergencies which we need to deal with. And so mostly in case of high bulky disease, so either it is a high white cell count leukemia or in Burkitt's lymphoma, T cell leukemia, lymphoma, where it can happen. It can happen spontaneously as well, even before you have started any treatment. Sometimes it can start with the IV fluids, and sometimes inadvertently, if you give steroids without recognizing it, you can precipitate a tumor lysis syndrome, and you can quickly kill the patient if you don't sort of recognize it fast. So that's, and most of the time where there is already, say, leukemia infiltrate into the kidney, this is more likely to happen because the kidney will not be able to clear the potassium fast. So these are the things we sorry. So that is what so and another tendency to correct the hypocalcemia, unless the patient is having a seizure or something like that, don't go and give IV calcium to correct a slightly low calcium because you will actually precipitate because the calcium is low because the phosphate is combining with the calcium and precipitating, and that will increase the tumor lysis. And you give more calcium, you will precipitate it more. And hyperuricemia is the other features because the cells have got a lot of DNA in them. When they get metabolized, they form the uric acid, which will go and precipitate again. So treatment, best we have to prevent it, anticipate it, and start hyperhydration, 3 liters per meter square per day. And then urinary alkalization was previously advised, but nowadays we don't do it very much because again, it can cause more precipitation. That's the reason. And the drug which we use is allopurinol. Allopurinol is a drug which inhibits the xanthine oxidase, and xanthine oxidase actually converts the hypoxanthine to xanthine to uric acid. And if the hypoxanthine is actually relatively more water soluble compared to uric acid, so you want to prevent this step so that you don't allow the thing to build up. And uric oxidase is another newer medication, or I mean not so new, as a rasburicase, which is a costlier medication. So if somebody is a very high risk of tumor lysis, better to go for this rather than trying the allopurinol. And sometimes even with all these measures, the potassium may go out of control. In that situation, you have to go for a dialysis very quickly. And then coming to the hematological emergencies in cancer. So hematological emergency can be anemia, due to anemia, thrombocytopenia, which I assume was dealt in a previous lecture on the hematological emergencies. And then you can have something called leukocytosis, hyperleukocytosis, and coagulation abnormalities. So hyperleukostasis or hyperleukocytosis is a situation where your leukemic white cell counts are very high, and often this it is more common in AML than ALL because AML blasts are quite sticky and they are big and they produce more inflammatory things. So even at a white cell count of 100 or 100,000, you can start developing this hyperleukostasis. And if in ALL, often when the white cell count is 200 or more, then you will start developing the leukostasis. So when do you suspect this? So you suspect it when patients with a high white cell count having either some unexplained neurological symptoms or some unexplained respiratory symptoms. So they can present with headache, vomiting, drowsiness, and seizures, and any respiratory symptoms, oxygen requirement, hypoxia, or any chest X-ray changes. So this is very important. Once the patient sees these things, the patient should be in the PICU, oncologist has to be involved, and treatment be started urgently. I had heard from my colleagues in situations like this where the family wanted to decide, they just delayed decision making by 24 hours, patient developed the intracranial bleed and died. So the hyperleukocytosis is a real medical emergency. The other hematological emergencies, sorry, I think it's coming back. Okay, so the pulmonary leukostasis, where there is a thickness of the blood is increased and it is clogging all the blood vessels in the lung. So in the X-ray, you may see some diffuse infiltrates and often hypoxia, which is present. And in the CNS, this cerebral blood flow is compromised, and so that you can have some infarcts, and then eventually there is coagulopathy as well, and then they can bleed into the infarct as well. So you can have both infarcts as well as the hemorrhage. So what is the therapy? So again, hyperhydration, avoid the use of diuretics because that will increase the viscosity of the blood, and then avoid PRBC transfusion because nobody's going to die with a hemoglobin of 4, whereas if you transfuse and make it even more thicker, they may die of hyperviscosity. But the platelets has to be transfused. If the platelets are low, at least keep it about 20,000 or close to 50,000, and if there is a bleeding, keep it up close to 1 lakh. And so the PICU support may be needed. Sometimes patient may be going to the ventilator and things like that if they're neurologically compromised. And anti-cancer treatment of some kind has to be treated urgently. And then coagulation problems in cancer. So in AML, particularly the M3 type of AML, acute promyelocytic leukemia, the prognosis is very good, but they can present with DIC. So that is very, very important. So we need to recognize it fast and then address it accordingly. And any leukemia or cancer with thrombocytopenia, sepsis, or malnutrition can present with bleeding. So in consumptive coagulopathy, that is DIC, so you will often have thrombocytopenia, you will have decreased fibrinogen, you will have increased PT, APTT, and increased D-dimer. Most of the time, the treatment is correcting the cause, and then if you are giving blood, you have to give blood, platelets, and FFP. Just don't give blood. Because the problem is here all the consumption of all the coagulation factors which we need to replace. And vitamin K, always give in such situations vitamin K, and keep the ionized calcium in the normal range. So if the ionized calcium is very low, again the consumption coagulopathy will not stop and there is more risk of bleeding. And if the if you're giving blood products, vomit before actually giving it. And then next is the mechanical effects. So this is often due to the pressure effect of the tumor itself. 12-year-old girl presented with three-day history of breathing difficulty, fever, and cervical lymphadenopathy, treated overnight as asthma. Sometimes that's what happens. A patient comes with the breathing difficulty and you put a stethoscope on the chest. There is a wheeze, so you made a diagnosis. And the child was sedated for a CT scan, and the senior anesthetist attempted the intubation, lost the airway, child did not able to resuscitate, and the patient died. What is the reason? So this is often a mediastinal mass with superior mediastinal syndrome. Other compression syndromes are spinal cord compression, cerebral herniation, and cardiac tamponade, and some obstructive symptoms like intussusception, bowel obstruction, urinary tract infection. All can happen because of the tumor. So this is an X-ray of mediastinal mass. So any patient presenting with first episode of wheeze at an older age, and there is no history of atopy, please do one X-ray at least first time, because you can miss a mediastinal mass because it can present just like a wheeze, like an asthma. So most common type of mediastinal tumors. So in anterior mediastinum, often non-Hodgkin's lymphoma, Hodgkin's disease, T-cell lymphoma, leukemia, germ cell tumors, and middle mediastinum lymphoma, and posterior mediastinum, often germ cell tumors and neuroblastoma. So this is another X-ray of a patient with mediastinal mass. You can see that the top bit of it is not narrowing as the normal X-ray will show. So these are all different reasons. Say, for example, one on the right-hand side is a teratoma with multiple calcifications which are seen. What we need to realize is that the mediastinal is not just the airway. All the blood vessels are going through the superior mediastinum. Anterior mediastinal mass, if the child is sitting and leaning forward, it is not pressing on the tissues. Once you make the child lie down, then it is actually going to compress not only the airway, but all the blood vessels as well. So you can quickly lose the cardiac output. And presentation and symptoms, often history of cough, fever, and dyspnea, and mainly the orthopnea, where the patient is not able to lie down. So SVC syndrome, often because there is an obstruction to the flow, there is going to be a facial swelling and edema. So how do we evaluate these children? So sort of many of the diagnostic decisions are controversial, so you need an experienced team to deal with these things. Often don't sedate the patient for the sake of imaging if you don't have to. And if there is a stridor which is present in a mediastinal mass, already more than 50% of the airway is compromised. And also you have all the PICU colleagues, so you need to understand that the mass is further down. Intubation is not going to help because the carina, which will be compressed, and then you put a tube down, you still won't be able to ventilate. So inability to tolerate supine position is a grave sign. And like I said, it can compress the major blood vessels. If it is an untoward situation where you have to do something and you have to sedate the patient, actually you should need to have an ECMO ready, because that is the only way to save the patient without losing the airway and still maintaining the circulation. So of all the different symptoms of mediastinal mass, the only thing which came very prominently predictive of mediastinal mass is orthopnea. So other things like wheeze, cough, dyspnea, everything can be present in every patient. Say, for example, if you connect the patient to a monitor, so here you can see that it's not working. So if you can see that if you have an arterial line, actually there is a dip and then coming up. So this is pulsus paradoxus. And similarly, even in a saturation monitor, you can see the saturation going up and down with each breath, so that when the patient is lying down. So that is, if you should be able to recognize it as a problem. And there is another clinical sign called Pemberton sign. You ask the patient to lift both arms so that it touches the side of the face, and then the problem increases. And if the child is not able to lie flat, then also keep that in mind. Say, for example, this is an CT scan of a mediastinal mass, which is completely compressing the airway. And if you do a lung function test, it will be significantly reduced. So the management, keep the child sitting and left lateral position. Don't put the child completely flat. And if you are giving anesthesia, don't give neuromuscular blockade, and don't give medicines which you will not be able to reverse. Probably ketamine will be better. And then sort of face mask oxygen. And if you sometimes to get a diagnosis, if you have to intubate this patient, if you can get the diagnosis by other routes, for example, pleural fluid, pericardial fluid, or some lymph nodes outside, that can be done under local rather than sedating the child. So I talked about what needs to be avoided. So in neurological emergencies, sometimes it can present as spinal cord compression because of the tumor in the spine. So it can present with acute onset of weakness, bladder bowel control, or sort of urinary incontinence, sensory abnormalities. So if that is present, it is again a medical emergency, because many of the children don't normally complain of back pain. So if a child complains of a back pain, take it very seriously. And so get an imaging done, and sort of sometimes you need an emergency surgery or emergency radiotherapy or emergency chemotherapy based on what we think it is. And so whatever is feasible, we have to proceed urgently, because otherwise you may end up with a permanent paraparesis, even though the child can be saved later, but once the damage is done. So often steroids are given as the first instance to reduce the amount of edema. The other sort of neurological things in the central nervous system and brain, so it can be because of infection, seizure. Press is a very common feature in many of our patients, and sort of peritumor brain edema, and sometimes sudden bleeding can happen into the brain and can cause hydrocephalus. So this is an sort of a posterior fossa tumor which is actually blocked the CSF pathway and resulted in hydrocephalus. So again, that is an emergency. So you can give dexamethasone, 3% saline, mannitol, and then quickly send the patient to a neurosurgical center, because that is the one thing which is going to save the child. And intubation and ventilation, so you know the normal things of intubation, maintaining normocarbia, head and elevation, and sedation. So in terms of diagnosis of brain tumor, the most important, if you take these 4 symptoms, headache, vomiting, visual symptoms, and gait abnormalities, individually they are common, but combination of any of these things is high risk of brain tumor. Suspect brain tumor and do the investigations. And any sudden personality change or sort of school performance decrease, then you have to take it seriously as well. So other emergencies, obstructive emergencies, gastrointestinal obstruction, urinary tract obstruction, or biliary tract obstruction. So in terms of outcomes in intensive care, once the patient lands up with a severe shock in intensive care, the outcomes are quite poor, but it is improving nowadays. But early recognition is the most important thing. So pitfalls as a general pediatrician, steroids in the first episode of VEAS, think about it. Not being aggressive in the treatment of febrile neutropenia, delaying the antibiotics, and then not being aggressive in the tumor lysis syndrome, not performing CT scan prior to line neck replacement, especially if there is not of lymphadenopathy. Make sure the anatomy is not damaged. I have seen patients, arteries being poked. Not thinking about the central cause for vomiting. So if the child is having vomiting diarrhea, it is quite easy, but not sort of having only vomiting, you have investigated everything, please do a CT. Think about a CT head. And sedation and a mediastinal mass, which I have already sort of informed about. So that's the end of my talk. Thank you very much.
So it was a wonderful talk. Any questions from the audience?
Sorry, repeat that again, sir. Tumor lysis syndrome.
Can happen both ends, sir. Very low count, less than 500.
No, sir. Normally, low count doesn't lead to tumor lysis syndrome. Tumor lysis syndrome, either it can happen in sort of lymphomas where their blood count is normal, but they have got a big mass. So that can also suddenly go into tumor lysis. Mostly it is hematological malignancies. Solid tumors like say neuroblastoma or Wilms tumor, they will not generally go into tumor lysis. It's high white cell count or big massive lymphadenopathy. Those are the two situations.
So electrolytes, everything is normal. Child was wanted to go tomorrow.
Yes,
so
sir.
overnight it has become deteriorated and died in spite of being counts are 1.5 lakhs.
Yes.
But what could be the reason suddenly?
So one is sometimes when you start the IV fluids alone, sometimes that alone will precipitate the tumor lysis. So the hyperhydration is important. So if you suspect tumor lysis, what we normally do, we start allopurinol, we run the high hyperhydration. And also another important aspect of the hyperhydration is that we have to understand that it is not only the fluid going in, it is also that fluid has to come out. So sometimes if there is a renal infiltration and you drive the fluids and the patient will go into pulmonary edema and then succumb, or if the electrolyte monitoring has to be very close. So that is the next important step, because once you start IV fluids, you have to keep watching for it. Sometimes every 6 hours, sometimes even every 4 hours. So depending on how bad things are, then you can increase the frequency. But monitoring is important, because once you know that the potassium is going up, then you may have to give salbutamol, insulin dextrose, and many other things to keep it under control. But sort of, yeah, that is the most important thing. Finally, dialysis, if nothing works.
Thank you.
Thank you, sir. Thank you very much.
I would like Shiva Prakash sir to felicitate Dr. Stalin with a memento.
Thank you, sir. May I call upon Dr. Muktamba Madam to felicitate our chairperson, Dr. Shiv Prakash Bevi. With this, we move on to the next talk, that is a cardiac bundle. For this, to chair the session, I invite upon Dr. Satyanarayan sir and Dr. Shamsuddin sir to chair the session, please. Dr. Shamsuddin. First, Dr. Bharat.
Good morning, dear friends. It is very great pleasure to attend this session. Yesterday it was very fantastic items regarding the ICU chapter. I am very happy to know that in our country it has gone advanced last 25 years. I was working outside. I was facing all these last 20, 30 years back. But I'm very happy to know that all our pediatricians, all our intensivists, all are involved in this actively. I want to welcome Dr. Bharat AP, is MD Pediatrics, MBBS, Assistant Professor of the Department of Pediatrics, Sri Siddhartha Medical College, Tumkur, Karnataka. His work under renowned pediatric cardiologist, work in the outpatient department emergency department as well as ICU as a part of routine curriculum and take care of critical patient. Trained in transthoracic, transesophageal fetal echocardiography in evaluation of congenital heart disease. Does it change in device, design after device, size and selection, comparison of conventional. The theme of the topic is small heart and big challenge. So all yesterday's and today's topic, all are around heart. If heart is perfectly working, everything what we have learned here, it is successful. As you know that our heart beats 1,15,000 per day, a normal heart, adolescent heart. And you know that vascular distance about more than 100 kilometers from the head to toe. So what we have yesterday learned, what we have today learned, just now what we have learned about tumor and all, everything intact when our vascular system and heart is working properly. So please welcome. Go ahead.
Thank you, sir. Respected teachers, friends, and colleagues, I would like to thank Pedicriticon for giving me this opportunity to present this talk. Today, my talk will be on acute heart failure in children, the challenges that we face in them. So I would like to begin with the slide. Yeah. So myself, Dr. Bharat, pediatric cardiologist. I am working in Aster Hospital, Bangalore, and also in Manipal Hospital. Next slide. So before we go into to make the presentation interesting, I will be presenting only the case scenarios. After this 1 or 2 slides, we'll be going through only case scenarios. So heart failure, it is an abnormality of cardiac function whereby heart is unable to pump at the rate commensurate with the requirement of the metabolizing tissues or does so only at elevating filling pressures. So CHF in children is usually due to a correctable cause, and primary aim of the pediatrician but subspecialist must be to identify that cause and to offer correction. So this all of us know how to recognize signs, symptoms. It based on the age of the child. Neonates and infants, refusal of feeds, irritability, crying, sweating, poor weight gain, desaturation. Older children, dyspnea, reduced urine output, edema, easy fatigability, desaturation. Again, you can separate them into left-sided heart failure and right-sided heart failure. And some of the symptoms can have both features of heart failure. Next slide. So we'll go with the case scenario. So now we have a 2-month-old child, which is weighing 2.5 kg, birth weight of 2.4. That means over a period of 2 months, it has gained only 100 grams. History of significant failure symptoms, continuous murmur. X-ray shows cardiomegaly with increased vascularity. So this is the echocardiogram that we do. As a pediatric cardiologist, bread and butter is echocardiogram. Here you can see this is the 4-chamber view, left atrium, left ventricle, right atrium, right ventricle. And this is the parasternal short axis view to show the ductal view. This is the main pulmonary artery continuing as PDA. That red color, what you are seeing is actually the tubular PDA. Because of that, there is a cardiomegaly and increased lung vascularity, and the child is suffering because of failure to thrive and congestive cardiac failure. So what will be the plan of management? N number of medical, it will be refractory for medical treatment because of a large PDA. So this child was referred to us, and this child was taken up for the procedure. So this is the procedure what we do. So now PDA can be closed in 2 ways. One is PDA device closure also can be done, and also ligation. Since device closure has more advantages, we went ahead with the device closure. So this is the PDA. Here we have come from the right femoral vein, IVC, RA, RV, main pulmonary artery, crossed the PDA and parked our catheter in the descending aorta. And we have given an injection. This is the tubular PDA that is opacifying the pulmonary artery. So through this catheter, we came up with a device. Specially designed devices are there, and this device will come and it will plug the PDA. One retention skirt will stay in the aorta, and the other retention skirt will stay in the pulmonary artery, and it will plug the PDA. Parallelly, on table, we'll be doing the echocardiogram. This is the place where the device is sitting, and the PDA is completely sealed off. The blood that you were seeing earlier, the flow, it is not seen now, and the PDA is sealed off. Next slide. So baby underwent procedure successfully. Failure symptoms resolved, and child is catching up growth, gaining weight, and doing fine. So this is one scenario. Another scenario: 4-month-old child weighing 4 kgs had uneventful delivery and neonatal period, presented to us with failure. Child had only systolic murmur. X-ray showed cardiomegaly. Here you can see the previous slide. Go back to the escape and go back. This one. You can run that. You can run that slide. So you can see this is the 4-chamber view, where you can see left atrium, left ventricle is pumping the blood into the aorta, but you see so much of flow turbulence across the aortic valve. That means there was a severe aortic valve stenosis with minimal AR, and because of that severe aortic valve stenosis, child had severe ventricular dysfunction. So it was an emergency. Next slide. So the child was taken for cardiac catheterization laboratory. So we have gone from the right femoral artery, descending aorta, arch of aorta, and ascending aorta. And we have given a pigtail injection here. You can see that there is a doming aortic valve, and because of the bicuspid aortic valve, there is a post-stenotic dilatation, and these are the arch vessels. So we went with the appropriate sized balloon, and balloon dilated the aortic valve. So post balloon dilatation, the echo gradient came down from severe stenosis to mild stenosis with mild AR. Ventricular function improved. Now child is around 1 year and doing well, and with only mild aortic stenosis. Next slide. So one more scenario: 3-month-old baby weighing 3.5 kg, uneventful birth history and neonatal period, presented with failure symptoms, and also baby was presented in shock. You can see the baby had upper limb pulses were feeble, lower limb pulses were absent. X-ray was having cardiomegaly. Again, the child had, this is a left atrium, left ventricle with severe ventricular dysfunction. And this is the arch view, where you can see ascending aorta, arch of aorta, and descending aorta. There is a significant flow turbulence. Till here it is pulsatile. Beyond that, there is no pulsatility. If you put a continuous wave Doppler, there is a continuous flows in the descending abdominal aorta. And this is the flow pattern. Normally it should be pulsatile, but here there was a diastolic spilling also. So this baby had a severe juxtaductal discrete coarctation of aorta with LV dysfunction. Next slide. So the plan is, class 1 indication is for all infants less than 1 year. It is repair only, end-to-end anastomosis with resection of the coax lesion and end-to-end anastomosis. Since the child was very sick, we went ahead with balloon dilatation of coarctation. So we came from the right femoral artery, descending aorta, and this is the discrete coarctation. We crossed it, and we gave an injection to delineate the coarctation. Once injection is given, we delineated that, and the appropriate sized balloon is taken there, and we balloon dilated the coax segment. Post dilatation, the flows have become pulsatile, lower limb pulses were well felt, and baby's ventricular function improved slowly, and child is discharged within few days, gradient abolished and kept on follow-up. So that was a infant that came to us. This is a 6-7-year-old child presented with easy fatigability. BP, there was a difference between upper limb and lower limb. Echo showed a gradient of 50 millimeters of mercury with normal function. So that child had a severe coarctation of aorta. You see that we have taken a pigtail from descending aorta across the coax segment into the arch of aorta. We can see a three sign. So this is the tight discrete coarctation, and we just balloon dilated that. Post dilatation, lower limb pulses started, it felt, and child improved well. And this is kind of a procedure where you can discharge the child next day itself. So I showed 3 coarctations back to back because that was an infant, ideally surgery. Next was a 6-year-old child. We could not place a stent. We did only balloon dilatation. This was a 15-year-old boy evaluated for hypertension. Turned out to have coarctation of aorta. CT also confirmed the same. So this was a coarctation where there is hardly any flow into the descending thoracic aorta. So we took an appropriate size stent there, placed it, gave injection, confirmed that it is exactly in the place where we wanted to stent it, and deployed the stent. Post stenting, you can see a nice pulsatile flows in the descending aorta, and child will go next day only. So those were some of the scenarios of coarctation. Now 2 months, so both of them are a tetralogy of fellow, but one baby is 2-month-old child, the other baby is 6-month-old child. Both presented to us in deep cyanotic spell in shock, and both had oligemia with boat-shaped lung. One turned out to be a extreme form of tetralogy of fellow with pulmonary atresia, where the ductus was supplying the confluent branch PS. The other one had only trickle of antegrade flows. Next slide. So this is the slide with pulmonary atresia. We came from the right axillary artery, subclavian artery, innominate artery, and this is the aorta, and this is the ductus. So most of the time, ductus in tetralogy of fellow, we call it as a vertical ductus. It won't be like a normal ductus. And you can see there is a tight narrowing where the ductus enters the pulmonary artery. This is the right pulmonary artery, and this is the left pulmonary artery. So we came up with the appropriate size coronary stent, and we placed it across the ductus and deployed it. Post stenting, we can see a good flows across both the branch PS. This is equivalent to BT shunt. BT shunt is a surgical procedure, but here we did without surgery. So that the baby will come for the surgery, corrective surgery, with a fresh native heart. So saturation immediately increased to 80%. Discharge on aspirin not to get that stent clotted, thrombosed, and we advise them to come for corrective repair after 1 year. We'll be keeping the child on follow-up every 3 months once. That was the second scenario where the child had trickle of antegrade flow, 6-month-old child. So this is the IVC, RA, across the tricuspid valve, we gave an injection which delineated a tight infundibular stenosis with minimal opacification of the branch PS. So then we crossed it across, then this is the RVOT. So IVC, RA, across tricuspid valve, RV, RVOT, pulmonary artery, right pulmonary artery. We took an appropriate size stent here, deployed it. This is called RVOT stenting. So post stenting, you can see good flows across the RVOT with good branch PA flows. Child's cyanotic spell disappeared. Saturation improved to 80%. On aspirin, we discharged the child and told to come for corrective surgery at 1 year of age, which is VST closure plus infundibular resection plus pulmonary valvotomy. So all of you are following. Yes. So this is one more scenario. 3-month-old child. This is the medical scenario that we keep seeing in our practice. 3-month-old baby exclusively breastfed by a primary, uneventful, no past history, suddenly developed refusal of feeds, irritability, shrill cry, moaning, cold peripheries, features of failure, but tachycardia, no murmur. X-ray shows cardiomegaly. Next slide. So if you do the echo, this is the 4-chamber view. LA, LV, RA, RV, severe TR, TRZ gradient of 56 to 60 with RV dysfunction, suggestive of severe PH. This is the interatrial septum. You can see that is bowing towards left. And there is a PFO that is opened up, shunting right to left. The same plane in bicaval. So you can see a PFO, the blue color blood that is entering from right atrium to left atrium. Normally it should not happen. So this is a classical case of a thiamine responsive PH. So thiamine was given, and child, all the metabolic parameters, the cardiac parameters, everything normalized within few hours. And as per the protocol, we continue thiamine 100 mg IV for 3 days, followed by oral thiamine 25 mg twice daily for 3 months. And we supplement the mother with thiamine for 3 months. So these are the classical features of a thiamine responsive pH that everyone knows. Some mechanisms are like superoxide, oxygen radicals, nitrogen radicals, mitochondrial Krebs cycle failure. All these finally causes vasoconstriction in the pulmonary arteries and elevate the pulmonary venous pressure and right heart failure. So this is one more scenario. 8-month-old child weighing 4 kg, significant failure to thrive with all failure symptoms, saturating at 100% only on oxygen. But if you take out oxygen, it comes to 90%. All features of signs and symptoms of failure. Liver is down. You can see such a cardiomegaly with such an increased lung vascularity. You can see the ECG we call KW phenomenon. KW phenomenon means mid-precordial leads. V2, V3, V4. We have a equiphasic R waves and S waves. That is a feature of a large shunt lesions. So that is called KW, Katz-Wetzel phenomenon. Next slide. So this child's echocardiogram we did. This is the 4-chamber view, left atrium, left ventricle. This is the ventricular septal defect. It's a large unrestricted ventricular septal defect. This is the short axis view. You can see there is a septum dropout and the red color blood entering from left ventricle to right ventricle. And in that child, the VST this defect is measuring around 1.2 centimeter. Next slide. So we medically stabilized, offered VST surgical closure. Child underwent successfully, uneventfully discharged. Child is now catching up growth and doing well. So the previous scenario is only the VST. That does not mean that that scenario exists only to the VST. Any post tricuspid shunt, not only the VST, AVCD, PD, AP window, cyanotic heart disease with increased flow, all will have common factors. They are unrestricted lesions and all are post tricuspid with direct pressure transmission from ventricles to pulmonary artery so as to cause hyperkinetic pH. Other conditions like RHT with severe valvular regurgitations or endocarditis with valvular involvement all have to be offered surgery so that it's a curative procedure. So these are the okay, next slide. So these are some of the echo collections. Okay. Can you go back? Just echo collections. One is the PDA in this large PDA. This is the AV canal defect, large primum AST. This is called a snowman appearance in a supracardiac TAPVC. All pulmonary veins join, ascends up and ascends up and joins the innominate vein. It's like the head of the snowman. This is the AP window. This is the aorta pulmonary artery. There's a large gap between the aorta and pulmonary artery. So they all have to be repaired at the right time so that it's a curative procedure and child need not come back to us for follow-up. Next slide. So one more scenario, 7-month-old child weighing 4.8 kgs, failure to thrive with significant failure symptoms, tachycardia, tachypnea, pulses failed, gallop, liver down. You see the X-ray, such a huge cardiomegaly, CTR of more than 80%. So all children with failure, preferable to do ECG also. Here the ECG is pathognomonic in this case because normally we don't get this Q waves in one and Q waves in AVL. Normally in all of us, everyone, even in children, the Q waves will be there in 2, 3 and AVF. But here child had deep Q waves in 1 and AVL and V4, V5, V6. So all suggestive of Al kappa. So Al kappa, even if we can miss clinically, even we can miss by echocardiogram, but ECG will definitely tell us whether it's Al kappa or not. Next slide. So you can see we did the echo. There is a echogenic papillary muscle in the left ventricle, significant ventricular dysfunction. You can see Al kappa is anomalous origin of left coronary artery from the pulmonary artery. So this is the pulmonary artery branching into right pulmonary artery and left pulmonary artery. You can see this line. This is actually the coronary artery that is actually entering into the pulmonary artery. So surgeon rerouted this coronary artery to the aorta and the coronary flow normalized. Next slide. So medically stabilized and all kappa surgical repair was offered. Surgery underwent successfully, uneventfully discharged. LV function recovery, it's all dependent on the other features like whether the fibrosis has set in already in the myocardium or not. Otherwise, with anti-failure measures, child will slowly gain back its ventricular function in some of the cases. So one more scenario, 1.5-year-old child, 9 kgs, fever since 10 days, failure symptoms, tachycardia, tachypnea, muffled sounds, gallop, liver down, sinus tachycardia. You can see around 70% CT ratio. This is the echocardiogram, which showed heart is floating in a tub of fluid. So it's a large pericardial effusion with almost chambers are getting collapsed. So this is a large pericardial effusion. Next slide. So child underwent pericardiocentesis successfully, completed the course of antibiotics based on the organism isolated, and child is doing well. So one more scenario, 12-year-old child on penicillin prophylaxis since last 2 to 3 years, developed increasing breathlessness, orthopnea since 2 years. This is the echo shows left atrium, left ventricle. You can see this is the mitral valve, which is thickened, doming with less mobility. Color flow interrogation, you can see such a turbulence across the mitral valve. So this is a classical feature of a juvenile mitral stenosis. So till the child reaches the stage where we can offer the corrective repair for the mitral valve, and it was amenable for balloon mitral valvotomy, we went ahead with the balloon mitral valvotomy. So we went with the IVC RA, poked the interatrial septum, punctured it, entered the left atrium, and then we took the balloon. There are Acura and Innova balloons which are meant for balloon PTMC, we call mitral valvotomy, and balloon dilated that. Next slide. And those children had to be on benzathine penicillin prophylaxis forever. So one more scenario, 4-year-old child, uneventful past history, presented to ER with fast heart rate of 250 plus, otherwise X-ray normal, echo mild LV dysfunction. This is the ECG. You can see the rate is more than 250 with almost absent P waves. No P waves are seen at all. So this is the classical ECG of a supraventricular tachycardia. So injection adenosine, theoretical rule, everyone like 100 mg per kg. No, don't give 100, give 200 mg per kg. You can give up to 300. Give preferably in the proximal IV line with rapid immediate saline flush. If possible, record the ECG for diagnosis of arrhythmia. If the child is in hemodynamic compromise, go for cardioversion. If refractory, refer to a cardiac center. Less than 5-6 years, we just manage them on medical management by beta blockers and calcium channel blockers. If the body surface area offers more than like 20 kgs and all, we can offer them radio frequency ablation. So this is a slide to show that the failure related to so children can present with heart failure with n number of conditions depending on the age of the child. Day one, non-cardiac causes, other cardiac causes like TAPVC, valvar regurg, critical AS, coarctation, HLHS, myocarditis, SVT. There will be overlap, but in infants, it's majority of the time it's obstructive lesions and acyanotic heart diseases and cyanotic heart disease with increased pulmonary blood flow. Older children, rheumatic, infective, valvar, and SVT and myocarditis. Thank you. Next slide. So final conclusion, the aim must be to offer definitive treatment at the earliest. Medical treatment is for only few days to weeks till you are planning for surgery. All correctable causes should be offered surgery or intervention at the earliest. There is no cutoff of weight that the child must attain for cardiac surgery and intervention. Next slide. Thank you.
Thank you, sir, for that exhaustive talk. May I request you to please be seated on the front row. We'll continue with the next talk and we'll later call you back. Over to the chairpersons to introduce our next speaker.
Hello, good morning, everybody. It's my privilege to introduce Dr. Sridhar, who is MD Pediatrics and done fellowship in pediatric critical care. At present, he is working in Ashraya Hospital, Bangalore. He has also worked at Apollo Hospital, Hyderabad, Lotus Children Hospital, Hyderabad, Fortis Hospital, Bangalore, Rainbow Children Hospital, Bangalore. His areas of interest is pediatric critical care. Over to you, sir.
A very good afternoon. So today's my topic is hypertensive crisis in children. So presentation outline, a little bit about introduction, common definition we deal with, and the common causes, pathophysiology of hypertensive crisis. A few words about cerebral autoregulation, the common clinical features, primarily because of hypertension itself, as well as because of the end organ damage. The common investigations we do when we are dealing with hypertensive crisis, general principles in the common medications used, few flowcharts, and take-home messages. The hypertensive crisis is nothing but sudden elevation of the blood pressure with failed compensatory mechanism. That's most important, failed compensatory mechanism. It's often underdiagnosed in emergency department as well as in the intensive care department. The data on incidence and prevalence is lacking. Each study says its own data. Especially from India, we don't have any standard data to say what's its prevalence and its incidence. And coming to the management also, there is a lot of gray areas because most of the management guidelines, of course, we don't have. Whatever the practical guidelines we have, that is all derived from the adult data. And again, in adults, most of the time they deal with the primary hypertension. On the contrary, in pediatrics, we deal with secondary hypertension. The basic one physiological equation, which is very, very important to understand hypertension, is the blood pressure is nothing but the blood flow into resistance. Most of the time, if blood flow increases, the resistance decreases. On the contrary, if resistance increases, blood flow decreases. That is how the compensatory mechanism happens in the body. If the compensatory mechanism is overwhelmed, that is the point of time the hypertensive crisis starts. And coming to the classification of the blood pressure, we all know that as per 2017 American Academy of Pediatrics, hypertension means, the normal blood pressure is anything less than 90th percentile for the age, sex, and the height. Elevated blood pressure is between 90th to 95th percentile. And the hypertension is anything more than 95th percentile. And again, hypertension is categorized into stage 1 hypertension and stage 2 hypertension. Stage 1 is between 95th to 95th plus 12 millimeter of mercury. And stage 2 hypertension is anything more than 95th percentile plus 12 millimeter of mercury. A few definition, as I already said, hypertensive crisis is a life-threatening elevation of the blood pressure. Again, for management purpose, we subcategorically define that as hypertensive emergency as well as hypertensive urgency. Hypertensive emergency is hypertensive crisis with end organ damage, whereas hypertensive urgency is without end organ damage. This is very important for management perspective. If we are dealing with a patient with hypertensive urgency, no need to hurry up. We can manage this patient in the step-down unit or sometimes in the ward with most of the time with oral medications. On the other side, if you are dealing with hypertensive emergency, you should be literally like on the war foot because it can progress into end organ damage and irreversible damage. So here, most of the time we manage in intensive care department and we use all like high gadgets and most of our medications are intravenous. The common causes for hypertension in children is, the most common is the renal diseases. Again, it is like glomerular nephritis or some kind of HUS, reflex nephropathy, so on. The second most common is the vascular. It may be coarctation of aorta or renal artery stenosis or some vasculitis like Takayasus, so on. And the other one more common cause is some catecholamine secreting tumors like pheochromocytoma, Wilms tumor, neuroblastoma. And of course, with new generation and the latest things, we often should not neglect drug abuse and drug related. And again, one more thing, though it's not very common, is primary hypertension. Nowadays, because of the obesity epidemic, the incidence is increasing. So we should keep that also in mind. So what exactly happens in hypertensive crisis? The first thing is whatever may be the trigger because of like failed compensatory mechanism, there'll be hypertension, severe hypertension that causes mechanical wall stress, and that leads to the endothelial damage. When there is endothelial damage, again, a lot of like chemical mediators will be released. That leads to severe vasoconstriction, and that worsens tissue ischemia, and that sets a vicious cycle. However, parallelly, because of endothelial damage, there'll be activation of the coagulation cascade that causes microthrombi in all like vital organs, and that can cause microcirculatory failure later on. A few words about cerebral autoregulation, because this is very, very important when we are dealing with a patient of hypertensive encephalopathy. Normally, we know that the cerebral blood flow is maintained constant between a mean arterial pressure of 50 to 150 millimeter of mercury. Anything less than 50, that goes into failure. Anything more than 150, that also fails. That means the cerebral blood flow is constant between this. Anything more than that, there may be like cerebral edema. Anything less than 50, there may be ischemia. But in a patient who is already having hypertension, this autoregulated curve will be shifted to the right side. Sorry. So it will be shifted to the right side. So these are the patients we should be very, very careful when we are managing hypertensive encephalopathy, where we should take extra caution while reducing the blood pressure. The common clinical features, we categorize into clinical features secondary to the hypertension per se, or it may be because of the end organ damage. The common clinical features, the kid can manifest with lethargy, irritability, headache, dizziness, blurred vision, and rarely even with epistaxis. Coming to the end organ damages, the common organs which are involved, one is neurological, the other one is the heart and the kidney. Coming to the neurological manifestations, the common one is hypertensive encephalopathy. They can manifest with seizures, altered sensorium, coma, and focal neurological deficit sometimes. And the second neurological manifestation is acute stroke, where it may be hemorrhagic as well as sometimes ischemic. And of course, retinopathy is commonly associated with hypertensive crisis in the form of retinal bleed or retinal edema. The other common organ involved is the heart. The heart, because of sudden rise in the afterload with the left ventricle, that can go into the myocardial ischemia. And especially after this post-COVID event, I think the incidence is increasing. And next is because of increased afterload, there may be left ventricular failure with pulmonary edema. And not though common, like aortic dissection can also happen. It's very, very common in adults. The renal manifestations are acute renal failure and microangiopathic hemolytic anemia. The pathophysiology we already discussed initially because of the capillary injury, endothelial injury, and microcirculatory failure. So the common investigations, when we are doing the investigation, we do for two reasons. One is to find out the end organ damage. The other one is to find out what exactly the cause of the hypertension. Because as we discussed already, most of the time we deal with secondary hypertension rather than primary hypertension in children. The common laboratory investigations are complete blood count, the RFT, serum uric acid, lipid profile we do it, and catecholamine levels we analyze to find out the causes, and urine toxicology screening, especially in adolescent patients, and some imaging studies like renal ultrasonography with a Doppler to understand renal vascular causes, and echocardiography to understand left ventricular function as well as the hypertrophy status, and chest X-ray, and some renal scans to find out the causes. I found one simple flow chart, very interesting in the recent edition of Nelson textbook. Here, like they have made the diagnostic approach very, very simple. The first thing they say is just document the hypertension in 3 consecutive different timings. If you are getting the hypertension, then you see the gradient between the upper limb and lower limb. If there is a gradient, probably you are dealing with a case of coarctation of aorta. If there is no gradient, then send simple urine analysis. If you find something in the urine, then probably you are dealing with renal or renovascular. And if there is no abnormality in the urine examination, then look at the possibility of essential hypertension or renovascular or endocrine. And again, in the urine examination, they have made it very simple. If you are seeing anything like more WBCs, then it's probably a reflux nephritis or infection related. If you are seeing more RBCs, you are probably dealing with acute glomerular nephritis category of things. Coming to the general principles in the management, the most important is the goal is to prevent the end organ damage, not to normalize the blood pressure. That's very, very important. Then the BP reduction should happen slow and steady. That is, the 25% of the calculated blood pressure reduction should happen in 8 to 12 hours. Another 25% should happen in another 8 to 12 hours. And rest 50% reduction should happen in next 24 hours. If it's a chronic hypertension patient, you should take 48 hours. Only exception to this slow reduction is aortic dissection. Whenever you are dealing a patient with aortic reduction, the blood pressure drop should happen rapidly. And one more important thing is when you are dealing with a stroke, you should be very, very careful. You should understand whether that is a cause or the effect, because hypertension can cause stroke, or if there is a stroke, then hypertension can also happen because of the secondary mechanism. So if you are dealing with any patient with stroke that is leading to hypertension, you should be very, very careful, and you should not reduce the blood pressure rapidly. At least you should allow it to stabilize for 48 hours. Then correct hypovolemia. Though we are dealing with hypertension, you should correct the hypovolemia, because if hypovolemia is there, then when you start antihypertensive medications, the blood pressure will drop rapidly. And in some of the patients, especially the post-op cases and those who are in the ICU, they are on ventilated and other thing, often we neglect analgesia and sedation. So they should be sedated adequately, and adequate analgesia should be given. The common pharmacological agents we use in management of hypertensive crisis, there's a big list. I just read it out. Clonidine, isradipine, minoxidil, nifedipine, and intravenous like enalaprilat, esmolol, phenyldopam, hydralazine, labetalol, nicardipine, sodium nitroprusside. But in our practice, commonly we use labetalol, and then we use sodium nitroprusside, esmolol, and we use AC inhibitors. Just let us understand those medications in detail. The intravenous common medications are like sodium nitroprusside, labetalol, esmolol, and nicardipine. And oral medications we use is nifedipine, amlodipine, labetalol, and AC inhibitors. Few words about sodium nitroprusside. It's a non-selective vasodilator. The standard dose is between 0.3 to 0.5 microgram per kg per minute. The onset of action is in 30 seconds, peak effect in 2 minutes, T-off is 2 minutes. It's very rapid onset, rapid peak, and rapidly metabolized. The only known side effect is reflex tachycardia. And we should be very, very cautious when you are using in hepatic and renal dysfunction, because it's metabolized and excreted in these organs. If you are using for more than 24 to 48 hours, especially as a continuous infusion, you should be watching for cyanide, thiocyanate, and methemoglobinemia as the side effects. The next commonly used medication is labetalol. It's an alpha-1 and beta-adrenergic antagonist. The medication dose is 0.25 mg per kg bolus, then 0.25 milligram per kg per hour infusion. The onset is between 2 to 5 minutes, peak is 5 to 15 minutes, T-off is 6 to 8 hours. It's a little bit longer. Again, the caution is in case of asthma, bradycardia, or known heart block patients. Esmolol is ultra-short acting beta-1 adrenergic antagonist. The loading dose, we give it as a 300 to 500 micrograms per kg. Then we give continuous infusion 25 to 200 micrograms per kg per minute. The onset of action is 2 minutes. Peak effect is between 6 to 10 minutes, and T-off is about 8 minutes. It's contraindicated in case of second or third degree heart block and cardiogenic shock. So one more medicine I have not used personally, that is nicardipine. That's a calcium channel blocker. The bolus dose we give as a 5 to 10 mics, then 1 to 3 mics per kg per minute as an infusion. Onset of action is between 5 to 15 minutes. Peak effect is in 30 minutes, and half-life is between 2 to 4 hours. Again, the caution in case of hepatic and renal dysfunction. And one more commonly used oral medication as a maintenance therapy once we come out of the critical phase is AC inhibitors. The commonly used medications are captopril, enalapril, and most of the cardiac intensive care we use ramipril. The dosage of captopril is between 0.3 to 0.5 milligram per kg per dose. Maximum is 6 mg per kg per day. Onset of action is 15 minutes. Half-life is 4 to 6 hours. It is contraindicated in severe renal failure when creatinine is more than 3 milligram per deciliter. And also it's contraindicated in case of bilateral renal artery stenosis. That's why when you are dealing with hypertensive crisis, always it's mandated to do a renal Doppler before using these medications. Management algorithm, it's very, very complicated. I found it in UpToDate. I just made it very simple. Whenever we receive a patient in the emergency room, first you rule out head injury, any patient with hypertension. Then you stabilize airway, breathing, circulation. Assess mental status and look for signs of congestive cardiac failure. Look for a papilledema and focal neurological deficit. This will give an idea about the end organ damage, and you will be able to categorically say whether it's hypertensive emergency or urgency. Obtain IV line, give bolus dose of hydralazine or labetalol. We prefer labetalol. If unable to obtain IV, give IM hydralazine. Then if there is any seizure, then load the patient with anticonvulsants, whatever preferred choice. Like you can use Eptoin, you can use valproate also if there is no liver dysfunction. Obtain initial workup, like whatever we discussed, CBC and some renal chemistry, urine analysis, ECG, chest radiograph. Repeat bolus of hydralazine or labetalol if required. Then you make arrangement to shift to the intensive care unit. Before shifting, if you have an option, please do neuroimaging, then shift the patient to the ICU. Then once it's in the ICU, obtain intra-arterial line, then start nicardipine or labetalol continuous infusion. In our unit, we used to use either labetalol infusion or sodium nitroprusside infusion. And again, as we discussed, aim to reduce the blood pressure slowly, that is 25% in the initial first 8 hours. That is, again, it's very, very challenging to reduce the blood pressure slowly initially. And thorough history and physical examination should continue to find out the possible underlying cause, because we should remember we always deal with secondary hypertension. Until unless you treat the cause, you will not be able to achieve the end result. And you should also continue laboratory and imaging workup to find out the etiology. Once the patient is stabilized, transition to the oral antihypertensives. So again, titrate oral antihypertensives. Basically, we use again calcium channel blockers plus or minus AC inhibitors. And then in the maintenance phase, target the blood pressure less than 90th percentile. And still, if you are not finding the cause, continue your workup for the cause of the hypertension. And most important, educate the patient on lifestyle modification if needed, if you feel that patient is having obesity or the overweight. So the take-home messages: the hypertensive crisis is a life-threatening elevation of the blood pressure. It's often underdiagnosed in the ER as well as in the pediatric intensive care unit because it mimics other common diseases like meningitis, encephalopathy, so on. Early diagnosis and management is very, very important to prevent the end organ damage. Hypertensive crisis in children, it's most of the time because of the secondary causes. And always, like, the reduction of the blood pressure should be like, organ perfusion targeted, and it should be slow and steady, watching any other like organ ischemia associated. And most important, know your drugs very well before use. There is a big list of medication. It's not necessary that you should know all the medications. Have a handful of medicines like commonly what we use, like labetalol, sodium nitroprusside, esmolol, but you should know when to use, how to titrate. Thank you very much.
Thank you, sir. You have literally managed a hypertensive child within a time. Thank you. May I request you to proceed towards the dais, towards the felicitation. May I request all the both the chairpersons to felicitate Dr. Sridhar. May I also request Dr. Bharat Tepi to join on the stage. May I request Dr. Ramappa KG to come forward to felicitate our chairpersons. Sir, certificate. Sir, certificate. Certificate. Thank you, both the speakers. Thank you, both the chairpersons. Sir. Our next talk is going to be a renal replacement therapy, correct concepts and the challenges. To chair the session, I would like to invite Dr. Shashikiran KB. He is a nephrologist by profession, pediatric nephrologist by profession.
Very good afternoon. AKI in a pediatric intensive care setting is pretty common. Yeah. So the need for renal replacement therapy in such a situation leads to an uncomfortable situation between an intensivist and a nephrologist at times. So the jugalbandi goes on. So to settle this debate for once and for all, we have Dr. Pooja. She has done a DNB Pediatrics and fellowship in pediatric nephrology. She is presently working as assistant professor and consultant pediatric nephrologist in Sridevi Institute of Medical Science. Madam, over to you.
Thank you, sir. A very good afternoon to all of you. At the outset, I would like to thank the organizing committee for providing me this opportunity. So So my today's topic is renal replacement therapy, the current concepts and challenges. So according to the recent update, we have the terminology has been now coined as kidney replacement therapy. But for the ease of understanding throughout the presentation, I've kept it as renal replacement therapy. So the overview for this talk would be the need of RRT, the various modalities that we use, which are PD, intermittent hemodialysis, and CRRT, and the concepts behind each of the modality, as well as the advantages and the shortcomings of each of the modality. So what is the need of RRT? We use basically RRT in cases of acute kidney injury, especially if there is fluid overload, that is refractory to diuretics, as well as refractory hypercalcemia, as well as severe metabolic acidosis, also in rapidly increasing azotemia conditions, and if there is symptomatic uremia. Along with that, if there is persistent oliguria or anuria. So it's not just restricted to AKI, even certain non-AKI conditions are also use renal replacement therapy, such as whenever there is drug toxicity or in case of toxin ingestion, in case of severe hyperammonemia in IEM as well as in acute liver failure, then in tumor lysis syndrome as well as sepsis. So what is the current burden that we see of AKI? This is a study which is done in India, a recent study, which is basically based on a questionnaire. And we find that almost 10 to 30% of AKI requires RRT. And the modality most preferred is PD, even if other modalities are available in that particular center. So what are the different modalities? We have we have intermittent hemodialysis. Next, in case of prolonged intermittent, we have SLED. That is when CRRT is, the resources are not available, we can use SLED. SLED is nothing but sustained low efficiency dialysis. Then next is the continuous variety, wherein it is peritoneal dialysis as well as the CRRT. So how do we choose amongst each of this modality? So basically, what is the goal for the dialysis? Whether we require ultrafiltration, or it is the solute clearance, or it is the toxin removal. Next is depending on the clinical status as well as the hemodynamic stability of the patient. And then is how feasible is it to get a peritoneal or a vascular access. And next is the institutional preference and also the training of the medical professions. And next is the requirement of coagulation. And lastly, very importantly, is the cost of the treatment. So first, looking into peritoneal dialysis, basically the concept, all of you are aware of it, is for the solute clearance, it is generally the diffusion and the convection which is being used. And in convection especially, it is the fluid along with the solute that has been cleared. That is what we call as solvent drag. And the next in PD, for the fluid removal, osmotic ultrafiltration is used, wherein an osmotic agent is used in the dialysate. In peritoneal dialysis, basically we fill the peritoneum with dialysate, and then the filtration happens. So the peritoneal membrane acts like a semi-permeable membrane with many pores. The smaller pores are very important for the small solute clearance, like urea and creatinine. However, there is a very sparse evidence of large pores on the membrane. So larger molecules are not generally cleared in PD. So this depicts the various sizes. So small molecules, we have urea creatinine. Middle molecules, we have beta-2 microglobulins and certain interleukins. And in the large molecules, we have albumin and the TNF alpha. So when do we choose PD? If the child is hemodynamically unstable, or in case of very small babies wherein we cannot access vascular access, and in cases with coagulopathy where anticoagulation is not recommended, and also based on the expertise available. And if we are targeting small molecules and some middle molecules, PD can be used. And if we want better preservation of residual functions, PD is required. And what are the absolute contraindications to PD? It is omphalocele, gastroschisis, and bladder extrophy, diaphragmatic hernia, severe adhesions, and severe peritonitis. So these are basically the hardwares that we use. First is the rigid catheter, and the next we have the Tenkov for the double lumen. Then we have the pigtail, and we also can use improvised catheters like central venous catheters. And these are the fluids which are available, the commercial ones. So prescription, I'm not going in detail, but just that the dose that we use is around 20 to 40 mLs per kilo per cycle. We can reduce accordingly. And what are the main challenges that we see are the with respect to the rigid catheter. Basically, the bladder or the bowel injury can be seen. So in that case, we can use tunnel soft catheter. And if peritoneal filling worsens the respiratory distress, it is better to reduce the dwell volume. And if ultrafiltration is required more, we increase the concentration gradient, make the cycles more frequent with shorter dwells. And then for inefficient solute clearance, we increase the dwell volume along with increasing the dwell time. And if we find that there is a dialysate leak, we reposition the PD catheter. For outflow failure conditions, we heparinize the dialysate prophylactically and also instill streptokinase, also improve the gut motility by giving laxatives. For peritonitis, we prophylactically use antibiotics, provide proper hand hygiene, use a closed circuit, and replace a rigid PD catheter after every 3 days. Moving on to hemodialysis, the concept again for solute transport is same, diffusion as well as convection. Diffusion here depends on the surface area of the dialyzer, which should be around 80 to 100% of the body surface area. The flow of the dialysate should be at least 2 times the blood flow rate, and also depends on the concentration gradient of the solutes and the size of the solutes. So this table basically depicts the various surface areas so that you can choose different dialyzers. And this is to maintain a perfect concentration gradient. We use something called the counter current circuit, wherein a stagnant concentration gradient has been maintained throughout the dialyzer. And the next modality, convection, is used again for ultrafiltration, also for certain middle molecule clearance. Next is for the fluid removal. In hemodialysis, we use hydrostatic ultrafiltration, wherein a positive pressure is applied over the blood compartment and a negative pressure applied to the dialysate compartment. This we call as TMP, or the transmembrane potential, the pressure difference between the two. So this is the hardware that we generally use. Basically, the catheter size varies according to the age. We use a double lumen catheter, and also we must be very sure that the maximum amount of the extracorporeal volume, that is including the dialyzer as well as the blood lines, should not exceed 10% of the total blood volume in the child. So how do we choose the dialyzer? Which dialyzer to be used is based on something called ultrafiltration coefficient. This very simpler terms, it is basically depends on the removal of the middle molecules, that is the beta-2 microglobulins. So for example, if a dialyzer has a cuff of 500 pressure, that is TMP pressure, will be required to remove fluid of about 1 liter. So the next concept is mass transfer coefficient, which again involves the removal of small solutes. So a dialyzer with high efficiency but with a low flux removes urea very well, but there won't be any beta-2 microglobulin clearance. So this shows the various cuff as well as the area coefficient graphs. You have different modalities of dialyzers and also the body surface areas. So how do we choose patients for hemodialysis? Basically, they have to be hemodynamically stable, should have a good vascular access with a very good blood flow, and when it is generally used whenever there is when we require rapid and effective volume clearance, like in cases of pulmonary edema. And for efficient and rapid removal of small as well as middle molecules, like in cases with life-threatening hyperkalemia or acidosis, and in severe hyperammonemia, especially in children with IEM or acute liver failure but hemodynamically stable, we can use hemodialysis, and for toxin removal. So the challenges we face in hemodialysis are dialysis disequilibrium syndrome. So for this, we can initially use low efficiency dialysis, that is giving shorter sessions and using co-current circuit in place of counter current circuit, and also use osmotic agents like glucose or mannitol. Then for systemic heparinization or heparin induced thrombocytopenia, this can be avoided if there is underlying coagulopathy by heparinizing the saline priming, as well as uh, giving regular saline flushes. For catheter related problems such as exit site infection or the catheter related bloodstream infection, proper exit site care has to be done, as well as antibiotic lock solutions has to be used. And for thrombosis within the catheter, it can be avoided by using heparin or citrate based anticoagulation locks. So next, moving on to CRRT, or the continuous renal replacement therapy. So we have various modalities in CRRT, that is the CVVH, which is the continuous veno-venous hemofiltration using convection as the principle. Next is the CVVHT, which is continuous veno-venous hemodialysis, and CVVHTF, which involves both convection as well as diffusion, that is CVVHTF, involving hemodiafiltration. Then next we have is the SCUF, that is slow continuous ultrafiltration. So in SCUF, generally we do not use any dialysate or replacement solution. It is only removing the excess fluid. That would be the indication whenever we are using SCUF. So for CVVH, we use a replacement basically to for the solute clearance, especially of the middle or the large molecules, and also fluid can be removed by ultrafiltration. So again, replacement here can be given either as pre-dilution or post-dilution. So next is CVVHT, wherein a dialysate is used and there is no replacement solution used here. And this is very effective for the removal of small or mid molecules, and generally large molecules are not removed in this modality. Next is CVVHDF, which is much superior than the other modalities. And it effectively removes both small as well as large molecular substances. It is basically used mainly in septic or very hypercatabolic patients, wherein we use both dialysate as well as replacement solutions. So when do we choose CRRT? Whenever we have a good vascular access, and in case of hemodynamically unstable children, and AKI related to metabolic as well as fluid abnormalities, as well as in certain non-AKI conditions like hyperammonemia, drug toxicity, toxin ingestion, and hypercatabolic states like sepsis or burns. Sepsis basically because it removes the cytokines, which are the large molecules. And if you want any additional nutrition needs, suppose the child has oliguric or anuric, then nutritional needs can be met by using CRRT. So this is the smaller gist. So again, we have different filters that can be used in CRRT, which is HF20, with having a surface area of 0.2 can be used in even smaller children. And next is M60 and M100. We also have commercially available fluids for CRRT. And then coming to the CRRT dose, this is the most controversial thing. So through various studies, it has been found that almost 30 to 35 mLs per kilo per hour is a standard dose. So we can also use a high dose, high volume CRRT that is up till 80 when you want to clear ammonia, especially in IM or acute liver failure cases. So the blood flow again changes with respect to the different age. And then next, it requires anticoagulation. We can use unfractionated heparin, can be made heparin free as well by replacing it with saline flushes. And even regional citrate can be used. Newer centers are using epoprostenol as well. What are the troubleshooters for CRRT? Basically, after we attach CRRT, we find these warning signs like telling axis extremely negative, which indicates that there is low arterial pressure. Alarms are activated. This happens whenever there is a clamp which has been left in place of the arterial end of the catheter, or there is a kink, or there is a clot. Also, if the patient is moving, this alarm gets activated, or the pump speed is too fast, again this alarm gets activated. Next is whenever there is high venous pressure, the alarm again gets activated and it indicates as written extremely positive. So this happens whenever there is clamp, kink, or there is disconnection on the venous side of the system, or there's an obstruction between the filter and the venous pressure sensor, or the pump speed is way too low. So if the alarm is suggesting that there is high TMP, it indicates that the filter is slowly getting clotted. It needs replacement or a saline rinse. So the complications that we see are okay. So basically, RRT is the most life-saving therapy in children with AKI. So again, the choice of modality depends on the age, the weight, the hemodynamic stability, as well as the clearance that we are aiming at, and mainly depends on the resource and the available expertise. So PD is generally is the modality of choice in small children and in resource limited settings. HT being the choice in hemodynamically stable children requiring rapid removal of solutes of fluid, and CRRT is most preferred for hemodynamically unstable children for efficient clearance of solute of a large spectrum. Early referral, individualized care, and multidisciplinary approach is the key for improved outcomes. Thank you.
Thank you, ma'am. Now I request Dr. Shashikiran sir to felicitate Dr. Pooja.
I'd like to call the next chairperson, Dr. Anand Narayan Gowda, sir. He's a professor and senior consultant pediatrician. And the speaker, Dr. Shashikiran, sir, under the dais.
Hello. Hello. It's my privilege to welcome Dr. Shashikiran as an associate professor and head nephrology, Institute of Nephro-University in Mysore. His achievements are as a secretary of IIP Karnataka branch 2024, secretary IIP Mysore 2021. Over to you, sir.
Very good afternoon. At the outset, I thank the entire IIP TUMAKURU and the intensive care chapter of pediatrics for giving me this opportunity. While it gets loaded up, fluid and electrolyte balance is one subject which has intrigued right from our undergraduate days, right through our post-graduation days, during the doctoral degree, and even in practice. Every time we go through it, we come across something new and we learn new every time we go through it. So Arun sir has given me 20 minutes, probably 20 minutes to speak about it. And I'm sure that if I say that I'll be covering all the aspects of fluid and electrolyte balance in this 20 minutes, that I'm a bigger fool. So I'll just introduce two significant concepts while we approach sodium and water balance. And if we can keep that in mind in our way of approach of our kids while we manage these important tricky situation, probably we'll be moving in the right direction. I'll not confuse you with too many formulas that we are always, we can see it in our textbooks. If water and electrolyte balance is not complicated enough, why have I put this evolution slide, which is much more complicated to learn? There is a connection between my presentation and this, because when the life evolved from water to on land, there was something which was developed, which is very important that I'm going to talk about today. One is animals, you started using air, oxygen in the air from the dissolved oxygen. That is, development of lungs is one important evolution. The second most important is what I'm going to talk today. That is ADH and the concentrating ability of the kidneys. Because you imagine if that wasn't there, our half of our life will be to drink water because we are thirsty very often. And the next half is if we don't concentrate in the bathroom. So we would have spent half of our life in the kitchen and half of our life in the bathroom, and we wouldn't have been in this hall today. So let's begin with this case. We have a 10-year-old boy. He has steroid-resistant nephrotic syndrome. He has come with severe generalized edema. His creatinine is 0.6, sodium of 140. He has a weight gain of approximately 10%, and he's been treated with diuretics. So the next day, we have achieved a good urine output of 2.6 liters. Creatinine has remained the same, but as sodium has gone up. So is it common when we use diuretics, say Lasix, does the sodium go up or come down? Okay, what do you do next? Stop diuretics, give free water, stop diuretics and give free water, discontinue diuretics and give free water, and add tolvaptan. Someone can shout out your answers if at all you have any impression on it. So the next 15 minutes we'll try to answer this question. That's all. Okay. So the objective is to understand the distribution of water and electrolytes in the human body, to recognize the systems that control and regulate sodium and water contents, and to understand the difference between this sodium content and sodium concentration. That's the crux of the talk. Then there is a concept called steady state. We all know the total body water is distributed as mentioned here. We have ECF, ICF, and as per the age, the composition of total body water varies. The one important thing which I would like to bring your attention is that sodium is the major element in the extracellular fluid. So it is the sodium which guides the water quantity in the body. So here the total body water is divided into two compartments. So the extracellular fluid and the intracellular fluid. The two segments is mainly divided into two parts by cell membrane. See, the one regulation is between the ECF and ICF, where the cell membrane is the one which is keeping those two apart, and there osmolar regulation plays an important role. That is one. Second is, of the extracellular fluid, we have two components. One is the plasma volume, that is the intravascular volume, and the extracellular fluid, that is the interstitial fluid. Here, the capillary wall is differentiating between these two segments, and here the Starling's forces, which we all read, plays a very important role in keeping those two segments apart. So there is two membranes, two segments, which is keeping two parts of the total body water apart, and two parts of the ECF is being separated apart by equilibrium. And the regulation occurs in a, though there is some overlap, there is regulation of the respective compartment accordingly. So few definition we need to know. Osmosis, we all know that is movement of solvent molecules, and diffusion is movement of solute molecules, and filtration is movement of both solvent and solute. So this is very commonly we would have come across, we have read very often. What is this osmolarity? It's nothing but the percentage of solutes in the solution, in the solvent. So it is mentioned, given as milliosmoles per kg. And when we calculate, we use this formula 2 into sodium plus glucose plus urea. And the normal osmolarity is somewhere around 283 to 292. So the regulation mechanisms occurs in two. So when I have mentioned there is sodium, there is glucose, and there is something called urea also, isn't it? All the three are playing a role in osmolar regulation. But here there is a concept of tonicity, if we can know. Tonicity is something which is effective osmolarity, and that is guided only by sodium. Urea and glucose do not contribute to it. Urea and glucose move across the cell membrane. So these two are ineffective osmoles. Okay. So somebody said, so if there is a fluid that is going on or moving somewhere, it only follows the sodium. That is why the Kannada proverb, Up tindono, neer kudilebeku. Sakra tindo neer kudilebeku anta helilvalla avaru. It's because they knew that somebody was a physiology expert who gave that gade. He knew that glucose is an ineffective osmole. Okay. So that being a part, that is the concept of osmolarity and tonicity. Now there are two main regulating mechanism. One is the osmolar regulation, other one is the volume regulation. Okay. This osmolar regulation is achieved through the thirst and the osmoreceptor ADH system. Here, though it also regulates volume, but osmolar regulation mainly keeps your ICF and ECF accordingly. Okay. Regulation of volume occurs through all these things. And when I say volume, it's not the total volume of the body. Here, it is mainly regulating the intravascular volume, what we call as effective arterial blood volume. For this, we have lot of mechanisms like the stretch receptors, renin-angiotensin-aldosterone mechanism, natriuretic peptides, the kinins and the prostaglandins. It's the same what I already mentioned, that is the osmolarity is nothing but just the ratio of plasma solutes and plasma water. Tonicity is the effective plasma osmolarity. That means only the sodium. Let me go through this. See this, yeah, it's the same. Let me go ahead. The osmoregulation, the first part of it, how does it happen? The serum osmolarity must be precisely controlled, which determine this distribution of fluids between the ICF and DCF. The two main mechanism, one is the osmoceptors ADH system, other one is the thirst mechanism. In this slide, we see that when our serum osmolarity is around 280, we don't neither have a thirst or nor ADH is secreted. As we pass our time, there is a osmolarity that goes up in our body, and the first thing that's going to produce in our body is it's sensed by the osmoreceptors and the ADH is produced, so that we start conserving water. Only after it has crossed a critical period of 290, then the thirst gets stimulated. If the thirst was so very sensitive, then probably every now and then we need to have a carry bag along with us through which we drink water every now and then. So it is very important that a ADH system is there so that we can follow the system. The second part is the ADH which is secreted. It acts in the distal part of the nephron in the collecting tubules, so where water gets absorbed and it is conserved. So the almost 99% of the filtered glomerular filtration is getting absorbed, and only 1% is getting converted to urine and getting thrown out of the body. So the osmoregulation occurs in this way. If there is a situation of water excess, the plasma osmolarity increases, thereby plasma ADH declines and thirst is inhibited, thereby increasing the renal water excretion. And then plasma osmolarity normalizes. In the contrary, when there is water deficit, plasma osmolarity increases, that leads to plasma ADH rise and thirst is stimulated, thereby decreasing the renal water excretion, and the plasma osmolarity is set. This is how a ECF is regulated. Now let us come to the regulation through volume receptors. When I say volume regulation, this is predominantly the intravascular volume which is getting regulated. There are various factors. One is the stretch receptors, the baroreceptors in the aortic arch as well as in the carotids. Then we have renin, angiotensin, aldosterone system. This is one system which has made nephrologist life possible. If the system wasn't there, probably nephrologists wouldn't have existed. Then the natriuretic peptides, then the kinins and the prostaglandins. I'll not go into the complete details of it. There are different effectors, there are sensors and the central system which is involving. Hope you all know the gist of it. Ultimately, it leads to sodium retention, and thereby, once the sodium is retained, water is retained. Moving forward, when I said the volume regulation, I use the word effective arterial blood volume. What does it mean? It reflects the adequacy of circulation. It is the amount of arterial blood volume required to adequately fill the capacity of the arterial circulation. And it is also determined by cardiac output and systemic vascular resistance. We know that this effective arterial blood volume, or simply we can say plasma volume, it's a very small component. It's only 10% of the total body water. In an adult, if we have say 40 liters of total body water, only 4 liters is the effective arterial blood volume, but that is the one which is very well regulated. Okay, so the effective arterial blood volume and the ECF volume. ECF, we know effective arterial blood volume is a part of ECF. Okay, but both are regulated differently. Some overlap might be there, but they are regulated different. Why is this important? Because we can have a situation where you have water deficit but a sodium content being different. I'll tell you, we'll come to the subsequent slide. So it is a condition where both are differently regulated, but still they are independent of each other. Now that brings to the very important concept. Whatever I've told, you can forget it. Just remember this slide. It's about sodium content versus sodium concentration. What is this sodium content? Sodium content andre total amount of sodium in the body. Eshtu uppu nam shareeradallide. This sodium content drives the ECF volume. Okay. Then sodium concentration. Sodium concentration means number of sodium molecules per amount of fluid. So when we see this hyponatremia, hypernatremia, these are sodium concentration and not sodium content. We'll go further and we'll see. So the term hyponatremia and hypernatremia are actually misnomers. Okay, it is a situation where it has got nothing to do with sodium. Sodium hyponatremia means it's actually water excess, and hypernatremia is water deficit. So this is sodium concentration. When we talk about hyponatremia and hypernatremia, it is sodium concentration. Okay. Sodium content disorders are hypervolemia. Here the total body sodium content is high. Sodium is excess. Because sodium is excess, he is drinking more water and he is edematous. Hypovolemia is dehydration. There is a situation of sodium deficit. So I would like you all to underline this statement. Hyponatremia and hypernatremia are not disorders of sodium balance. They are disorders of water balance. Okay. So this is how the mechanisms happens, how the ECF is regulated. I'll just skip through this. The basic funda is that it is the sodium content that regulates ECF volume. See here, it is ultimately whatever the mechanism, ECF expansion lead to arterial pressure, kinins, ANPs or anything, it's all lead to the decreased renal tubular sodium reabsorption or increased renal tubular sodium reabsorption. So it is the sodium which is driving the total ECF volume. Next, whatever I talked till now, this is the summary slide. We have a osmoregulators and we have a volume regulators. In osmoregulators, it regulates the sodium concentration. What is sensed here is the plasma osmolarity through the hypothalamic osmoreceptors. Through its effectors are ADH stimulation and thirst mechanism. What is affected? Water excretion and water intake. The disorders are hyponatremia and hypernatremia. I reiterate again, disorders hyponatremia and hypernatremia are disorders associated with water excretion or water intake. Then we go to the volume regulation. Here it is the total sodium. It is the sodium content. Here what is sensed is the effective circulating volume through the carotid sinus, afferent arteriole or through the atria. And these effectors are the RAS mechanism, natriuretic peptide and sympathetic. Along with this ADH overlaps here. ADH plays in both. What is affected here is the urinary sodium excretion. So here volume depletion, edema or volume depletion, that is dehydration. They are problem of edema or dehydration is a problem of urinary sodium excretion. All right. So here, so if that is the case, can we have both together? We have certain situations where you have a hypovolemia with hyponatremia, like hemorrhagic shock with good oral intake. We have hypovolemia with hypernatremia, like diarrhea in children and elderly. We can have hypervolemia with hyponatremia, like in advanced congestive cardiac failure. In our case, what we saw. Then we can even have hypervolemia with hypernatremia also. So there are two mechanisms, osmoregulation and volume regulation. That is through sodium content and sodium concentration regulation. Okay. So there are various solutions that we use with various concentration. For want of time, I'll skip through. But here I would like to bring to your notice that whenever we are using a osmolar free fluid like a dextrose, the distribution is mainly guided by the osmotic gradient. So whatever is the proportion, like 2/3 ICF, 2/3 ECF, like that way it distributes and hardly anything stays within the intravascular compartment. That is why when we use normal saline, which is isoosmolar, when we give it into the fluid, here it distributes only in the ECF. There is nothing from the NS that is going into the ICF. It's only in the extracellular fluid. It divides into the intravascular component and the extravascular component. So that is why we all remember that whenever you are having a head injury or if you want to resuscitate a child in shock, always use a isotonic or a better fluid, not a hypotonic like D5 or D10. So this is the concept. Okay. One more thing is the steady state. For want of time, I'll just not skip through. I'll tell it in one sentence. Steady state is nothing but whenever there is anything extra, our body through various hormonal mechanism wants it to bring it to normal. That's all. Whether it is sodium, whether it is potassium, whether it is fluid. So one example I would like to tell is that, see, if you are being normally functioning kidney individual, if you give orange juice, which is very high in potassium, or say tender coconut water, TUMAKURU is tender coconut water. So on a day one, he consumes 3 or 4 tender coconut waters in a day. Do you think his potassium will go up? It doesn't. His urinary excretion of potassium will increase. So after 5-6 days, even if he drinks 10 tender coconut water, the potassium will not go up. That is what is steady state. The same thing is happening for sodium and ECF ICF balance also. That's what is the concept of steady state. With that, I bring my talk to a conclusion with saying that the basic principle is essential for appropriate treatment and management of fluid and electrolyte disturbances. Hypo and hypernatremia are disorders of water balance. Hyponatremia is primarily due to the intake of water that cannot be excreted. Hypernatremia is primarily due to the loss of water that has not been replaced. Edema and dehydrations are disorders of sodium balance. So hypovolemia represents the loss of sodium and water. Edema is primarily due to sodium and water retention. Okay, if you can just remember this one slide in the last 19 minutes, it's my job is done. So let's go back to the case and analyze here. So what happened? This child had edema to begin with at the time when he came. So what was the problem then? Pointer doesn't work. Was it a content problem or concentration problem? Initially, the boy of SRN is admitted with severe generalized edema. Generalized edema means content problem. Total body sodium is high. At that time, concentration was normal. Sodium was 140. That's normal, ECF. Then we gave him diuretics, furosemide. We achieved a good urine output. What happened to the serum sodium? It has gone up, isn't it? So here, do we have another problem now? We have an added problem of sodium concentration. Okay. Have you understood the difference between sodium content and sodium concentration? Sodium content was the edema or dehydration. So he has edema, sodium content. So next we have encountered an additional problem of sodium concentration going high. Now how to treat this? Stop diuretics. If I stop diuretics, what will happen? We might address the concentration problem. The content problem, will edema decrease? It doesn't decrease. So we have to continue diuretics time. So that's not the answer. Give free water. If I give free water, what will happen? Intravascular free water will increase, thereby the concentration will come down. But what will happen to the content? He'll still remain edematous or it will further worsen. So can I just give free water to him? No. Stop diuretics and give free water. What will happen if I stop diuretics? Edema will not come down. We are giving free water. So it will not serve any purpose. We will not be solving. He will further put on weight. His problem will not be solved. Then tolvaptan, it's got nothing to do with, isn't it? So that's the ruled out. So that leaves us with continue diuretics and give free water. We have two problems here. Sodium concentration problem, which has arisen because of the diuretic use. To set it right, we can give him some free water. But his essential problem was the sodium content problem, that is edema. To throw out sodium out of the body, we have only one Ramban, that is diuretic. So we have to continue diuretics. So this is a simple case to explain the importance of sodium content and sodium concentration. Thank you.
Thank you, Shashi. You made it so simple. Whenever I listen to you, I feel like I want to learn more and more from you. It was such a simple talk, such a complicated talk, yet you made so simple. Thank you. May I request our chairperson, Dr. Anantnaran Gowda, to felicitate our speaker for the day. I saw even Dr. Anil Sapare, senior consultant, was also taking your snapshot. He was so impressed with the talk, I think. Thank you, sir. Now, may I call upon Lakshmikant, sir. Lakshmikant, sir, to felicitate our chairperson, Dr. Anantnaran Gowda. The next speaker for the over to MCs.
So I'd like to welcome our next chairperson, Dr. Sunil Kumar. He's a professor and unit chief at Adi Chinchagiri Institute of Medical Science.
First of all, I would like to thank you, IAP Tumkur and organizers for calling me as a chairperson. Now I would like to introduce Dr. Pramod VU, who is a lead consultant in PICO in Om Mother and Child Hospital, Hoskote, Bengaluru. He had 5 national and international publications and is interested in pediatric critical care, pediatric emergencies, ICU procedures, and pediatric nutrition. Dr. Pramod, please take up the stage.
ಅಲ್ಲಿ ಇದಾಗ್ತಿಲ್ವಲ್ಲ. Hi, good afternoon, everyone. Myself, Dr. Pramod. So I would like to thank organizers for giving me opportunity to speak on post-ROSC care. It is quite complicated topic, but I'll try to concise within next 20 minutes. I'll try to make you understand what actually is there in post-ROSC care. So I'll be speaking on post-ROSC care under these headings. So what is ROSC? It is a restoration of spontaneously perfusing rhythm after cardiac arrest. And what is the main goal of post-ROSC care? It is to increase the survival to discharge with a favorable neurological outcome. Epidemiology and outcomes. In USA, pediatric outside hospital cardiac arrest rates are reported to go around 6 to 8 per 1 lakh person years, with the 10% of patients surviving to the hospital discharge. And the same rate of survivability is more than like around 52% for inside hospital cardiac arrest patients. And then coming to the pathophysiology, so usually those patients who undergo cardiac arrest will have a state of disturbed homeostasis. There will be a syndrome called post-cardiac arrest syndrome, which constitutes the post-cardiac arrest brain injury and post-cardiac arrest myocardial dysfunction and reperfusion injury and persistent precipitating pathology. So these are the phases of post-cardiac arrest syndrome. From first 20 minutes from the ROSC, achievable of ROSC, it is termed as immediate phase. And from 20 minutes to 12 hours, it is termed as early. And from 12 hours to 72 hours, it is termed as intermediate phase. And after 72 hours, it is termed as recovery phase. So usually what happens in post-cardiac arrest brain injury? There are primary injuries and secondary injury. Primary injury is entirely because of acute cessation of blood flow to the brain, which resulted in shifting from aerobic oxygenation to anaerobic oxygenation, resulting in decreased ATP production. So there will be a failure of sodium-potassium ion exchange pump, and there will be influx of water and sodium, resulting in cytotoxic edema, and there will be a potassium efflux and membrane depolarization, resulting in opening of voltage-sensitive calcium channels, and there will be calcium influx and accumulation of calcium within the cell. So secondary injury starts once the circulation is restored. Once the circulation is restored, there will be more blood flow to the area of previously ischemic areas, and the calcium will be moved towards the area of ischemia, and there will be release of excitatory neurotoxins such as glutamate, which stimulate the receptors and which further increases the calcium intake into the cells. This increased calcium within the cell will stimulate the opening of mitochondrial transition pores. From the mitochondria, there will be a release of, through that pores, there will be a release of lytic enzymes, caspases, and proteolytic enzymes, which promotes apoptosis and cell destruction. So what are the key principles of the post-cardiac arrest care? We need to support the organ function and minimize the secondary brain injury and reverse the etiologies of arrest and prevent complications. And there should be a multidisciplinary approach towards such patients. So then coming to the management. Management starts with optimization of the hemodynamics, and improving the BP. So there are few studies, observational studies, which said that maintaining a BP less than 5th percentile in post-ROSC care increases the mortality and also increases the poor neurological outcomes. So that's why maintaining the BP appropriate for age is very important. So always we need to go for invasive BP monitoring and titrates the inotropes to achieve the required map. So if the patient is usually in post cardiac arrest syndrome patients, there will be myocardial dysfunction. If the patient is hypotensive and also having myocardial dysfunction, we need to start adrenaline. If the patient is having myocardial dysfunction along with that normotension, we can start with dobutamine or milrinone. And we need to address reversible causes of cardiac arrest as soon as possible, such as acidosis, hypothermia, and hypoglycemia, toxins, tamponade, and thrombosis. And arrhythmias, occurrence of arrhythmias is most common in ROSC patients, so we need to address promptly. And we can institute ECMO in such patients who has got a cardiovascular instability despite of giving maximum inotropic support. And then coming to oxygen. So we need to use the lowest possible FiO2 to target oxygenation between oxygen saturation between 94 to 98%. And in such patients, we need to avoid hyperoxia and also hypoxia. And immediately after starting ventilation, within 10 to 15 minutes, we need to get a ABG to titrate the carbon dioxide and also oxygen, because even 2 minutes of hyperoxia will also increases the chance of brain injury through oxygen-free radicals. So when it comes to the ventilation, available evidence proves that we need to maintain PaCO2 between 35 to 45 mm of Hg. We need to avoid both hypocapnia and hypercapnia, because of hypocapnia causes cerebral vasoconstriction, which again further accentuates the damage of ischemia, and hypercapnia increases the blood flow by causing cerebral vasodilation. Again, it increases the cerebral intracranial pressure. So the treatment of persistent precipitating pathophysiology is very important, because we need to prevent the rearrest. So that's why we need to take care of 5 reversible causes of cardiac arrest. So then coming to the targeted temperature management. So here we have got, we can go ahead with controlled hypothermia, or we can maintain normothermia. Strictly we need to avoid fever in these conditions. And if you are choosing hypothermia, then target temperature should be around 32 to 34 degrees centigrade. And we need to achieve this target within 6 hours of achieving post-ROSC care. And we need to continue this hypothermia for next 48 to 72 hours. What are the methods to induce systemic cooling? So we can use intravenous ice saline and cooling blankets and ice packs and also fan. After 48 hours, once the patient improves, once the patient condition improves, we can start rewarming by 0.5 degree every 4th hourly. And if there are any contraindications for hypothermia, such as active hemorrhage, coagulopathy, and sepsis, then we can maintain strict normothermia, maintaining the temperature between 36 to 37.5. Again, here we can maintain that temperature by using ambient temperature control, fan, and cooling blanket. So what are the effects of systemic cooling on body? So there are both positive and negative effects on body. So the positive effects includes it decreases the neuroinflammation and decreases the oxidative stress and decreases the blood-brain barrier disruption and also decreases the excitotoxicity, which is main pathophysiology behind brain injury in post-ROSC patients. And it also comes with side effects such as increased blood viscosity, hyperglycemia, hypotension, and thermogenesis and coagulopathy. So what is the evidence says? So TAPCA trial, which is concluded in 2017, it says that there is no benefit between maintaining normothermia and hypothermia, but strictly we should avoid hypothermia or induction of fever. And the fever should be treated very aggressively in such patients. And even one meta-analysis also showed that there is currently inconclusive evidence to either support or refute the use of targeted temperature management between 32 to 34 degrees centigrade. So next, coming to sedation, analgesia, and neuromuscular blockade. So it is very important to start sedation and analgesia in patients who have undergone post arrest. So because it is quite important to treat shivering associated with hypothermia. And neuromuscular blockade can also facilitate cooling of the patient with post-cardiac arrest syndrome. And also it will help in tackling the patient ventilator asynchrony. So if there is asynchrony, there is a chance of raised ICP that needs to be treated with a neuromuscular blockade. So one needs to be cautious while prognosticating the patient who is receiving sedation and analgesia and neuromuscular blockade. So before prognostication, there should be at least, we need to let 3 to 4 off-lives for particular drug to pass by before assessing the patient for prognostication. So again, we also know that in post-ROSC kids, occurrence of seizures is quite common. In 10 to 15% of the children with post-ROSC care, they will face 1 or 2 episodes of seizures. Active seizures needs to be treated very aggressively, and usually we need to prefer continuous EEG monitoring to pick up seizures earlier. But routine prophylaxis of AEDs are not used in post-ROSC care. So if there is any occurrence of seizures, then we can use levetiracetam or valproate. So next, coming to hypoglycemia and hyperglycemia, both hypoglycemia and hyperglycemia is detrimental to the patient. So we need to maintain a strict glycemic control. So if there is a persistently high hypoglycemia more than 120, so 180, so it needs to be treated with insulin infusion. But there is insufficient evidence to support the routine use of hydrocortisone or steroids in cardiac arrest patients. Then coming to the management of infections. So infection is quite common after pediatric cardiac arrest. That is quite commonly seen in hypothermic patients more than normothermic patients. But we need to monitor the signs and symptoms for infection. And the starting antibiotics, it's depending upon the local PICU protocols. Then coming to the futuristic therapies, what is there in our kit? So we have got a lot of medications targeting mitochondria. We know that in post-ROSC care patients, mitochondrial injury is very important, which needs to be addressed. So there is an alternative mitochondrial fuels such as liposomally encapsulated nicotinamide adenine dinucleotide phosphate. This can be given to prevent the brain injury, but studies are still undergoing and they're in preclinical study. Still we need to wait for results to use these futuristic therapies. And MPT, mitochondrial transition pore, also plays very important role in a pathogens of ROSC children. So in order to block the MPT pores, we have got a cyclosporin. Again, the efficacy is not yet established, but it's a futuristic therapy. And we know that there is a formation of oxygen-free radicals within the cells. So we can use mitochondrial targeted electron scavengers such as nitrosothiol and emigramicidine. So, and we have one more futuristic therapy, that is targeted temperature management in syringe. We know that systemic cooling has got a side effects also. So in order to avoid that, we have got some cocktail of medications like fibroblast growth factor 21, irisine, and sex hormone binding globulin, which can be given through IV, which is going to simulate hypothermia in local areas such as brain without any systemic complications. And erythropoietin has been largely studied in adults. They have got there is a yield trial. So this is published in 2019 in adult population. They found that theoretically what happens with the erythropoietin is it prevents apoptosis and also it may promote angiogenesis and neurogenesis. But what evidence says is yield trial has been conducted in 2019, but they didn't get any benefits after using erythropoietin. So stem cell therapy has been used in post-ROSC care with variable results. Next comes prognostication in post-ROSC patients. Prognostication starts with the clinical examination. The first is absence of motor or pupillary responses within 24 hours after post-cardiac arrest has got a poor prognosis. But we don't know when to start using neurological examination. At least we need to postpone it by 24 to 48 hours before assessing a neurological examination in a post-ROSC kit. So next, coming to the EEG. EEG performed within the first 7 days after pediatric cardiac arrest may be considered in prognosticating neurological outcome at the time of hospital discharge, but we cannot use it as a sole criteria to prognosticate the children's. So these are the few EEG patterns which shows poor prognosis, such as burst suppression and excessive discontinuity, severe attenuation with lack of reactivity, and normal reactivity and sleep spindle shows a good prognosis in kids. So these are the few pictures of EEG. First one, left side, shows a burst suppression pattern. It is a malignant pattern. And next one, suppression without discharges. This is also malignant pattern. Both of them have got a very poor prognosis. Next, coming to the CT scan, the published evidence is inadequate to determine the timing and whether brain CT in first 24 hours after cardiac arrest is useful for prognostication of pediatric cardiac arrest care. So, but there are few observational studies. They have said that brain CT taken without within 24 hours after starting post cardiac arrest care, if it shows poor gray white matter differentiation, then it has got a poor prognosis in post ROSC care. And again, when it comes to the MRI brain, abnormalities detected in basal ganglia and in brain lobes in DWI has got a poor prognosis. We also have biomarkers such as neuron-specific enolase, glial fibrillary acid 14, and SNRED-B. If we measure these biomarkers after 24 hours after post-ROSC, if they are elevated, then again it shows poor prognosis, but there is insufficient evidence to support the use of biomarkers to predict the outcome after pediatric cardiac arrest. So finally, there is no particular test or clinical variable which have high accuracy for prognostication on own. Always we need to combine clinical variables with the test, which improves the accuracy of outcome prediction. So the final take-home message is, the main goal of post-ROSC care is to stabilize the perfusion and prevent secondary brain injury. And we need to take care of airway and avoid hyperoxia and hypoxia and avoid hypocapnia and hypercapnia. So hemodynamics, hypotension needs to be treated aggressively and targeted temperature management based on local unit protocol. And neurological monitoring needs to be done frequently to assess for prognostication. And EEG needs to be done continuously to pick up seizures early and avoid routine prophylactic AEDs. And there should be a strict glycemic control, and reversible causes needs to be treated as up. And prognostication and communication wise, we need to defer definitive neuroprognosis until confounders are resolved, like confounders such as sedation and hypothermia, and coordinate this multidisciplinary care and communicate plan with the family. Thank you. If there are any questions,
Thank you, sir. You have finished well within the time. Any questions? Okay.
I request Chairperson, sir, Dr. Sunil, sir, to felicitate Dr. Pramod with mementos. I request Dr. Anand Kumar, sir, to come onto the dais to felicitate Dr. Sunil Kumar, sir. On for the next speech. The next chairperson, Dr. Anand Kumar, sir. Anand is the professor and HOD of pediatrics at the Medical College. On to you, sir.
Good afternoon, everybody. At the outset, I would like to thank the organizers of Pedicriticon for giving me this opportunity to chair this important session. Since yesterday morning, we're all bombarded with the core subject related to the children's health. Now, we are going to hear the subject related to pediatricians itself for our well-being. So I would like to introduce Dr. Mallesh Gowda, done his MBBS 1992 JNMC and DCH also from Davangere, consultant pediatrician, so Gauri Shankar Child Care Center, Raichur. So he is a chairperson for scientific committee, state nephrology chapter ID, and state respiratory chapter, executive member, South Zone, national master trainer for many health programs, and is well versed with the personal finance. Is going to enlighten us regarding the financial aspect for the pediatrician's well-being. To be frank, most of us doctors are not well versed with the finances. We work hard day and night, but we are not well versed with the personal finance. So I am sure Dr. Mallesh sir will enlighten us. Over to you, sir.
Thank you, sir. Good afternoon to everybody. Thank you for being till the end to listen this little half-bit topic, and also thank you to the whole team of IAP Tumkur for calling me to share a few thoughts on finance. Disclaimer, whatever I going to tell the name of the mutual funds or the stocks or the representative, please not to jump directly because it may have its own problem. And it is an educative talk, and don't take that stocks mutual fund directly. See, whatever my talk is, maximum has come from this single person and this single association. Please try to join this association, WealthCon, run by Dr. Ramnath Gute sir, the radiologist from Mumbai, and we have about almost more than 1 lakh doctors of the MBBS doctors throughout the India and abroad. And if you join there without, it's all free of cost, and we can learn a lot of things without spending a single price, because doctors like us will ask many queries, and there are few thousands who are going to respond for all your small doubts. Whatever you feel silly also been asked. Your 99% of your own personal questions asked by somebody. Without revealing yourself, you can learn a lot of things. And you can search on in WhatsApp, there is a channel also in his name, you can join through that. As I told, I thought we'll tell thanks beginning only, so that I don't know at the end of talk how many people are remaining. And I also will, is the reverse the take home message before only, because at the end most of them will go home and there is nobody to take the message. That's why I thought I will tell, even if you learn at the end of my talk, and these are the one point. I am going to discuss this whole topic in these easy tell, ESI and TIL. And each 1 or 2 points in these earning, if you remember, there's more than enough. Earning, you try, there are 2 types, passive earning and active earning. Try to increase the passive income as much as possible. That is a freedom. How you to make your money work for you. That is the passive income for you. Spending, avoid what is called as pops than the pawns. Product of prestige pops. Try to avoid, pay yourself first by investing. How to invest? Finance, you should remember, finance and romance should never be outsourced. It's your effort. You have to learn yourself, and you are going to get a lifelong benefit for that. Do it yourself. Start early, because power of compounding is there always with you if you start early. See, whatever I learned so many things after last 10 years, I don't have advantage of young people, many of like you, because the age is your side and your investment is going to earn a lot more money. Even if I do circus and put all earning money also, I can't beat you because you have a time with you. By investing stock, gold and ETF and mutual funds, tax is good. Don't try to avoid it. Early you have to plan. Don't avoid, plan early and properly. Insurance, should never buy insurance as an investment. Investment and insurance should be kept separate. Loans, avoid consumer loans, bad loans, and try to take only good loans. These are, I'm going to detail each of these points. See, we feel doctors are difficult to learn, but I tell that always doctors are always have a good position to learn my finance on themselves, because they are create a value for them as well. If they earn most of us will put back into the different in the equipments and hospital and bigger hospital. That money is put into the society use. They are always the bright students. We are 1% of, see, lakhs together write a NEET, but only few will qualify. That itself tells that you are above rest of the majority. Only over 1% of Indian population. They are very bright students. Hard working is there from there in blood, because you are entered because you are working hard. Then only you are entered your medical field. We are elite 6%. Now it has become 8%. Total out of 1,20,000 crores, only 8% Indian population will pay. Among them, doctors are the most honest to pay the tax. You have very best learning skills, good decision making, open-minded to change, and you have quick adaptability and stable mind. We are not dependent on stock market to earn for day-to-day earning. That is why we have very stable mind, and we don't bother about how much every day, because other persons maximum they will try to earn only by stock market and then land in the problem. But if it is so, why doctors are lagging behind the financial literacy? Many busy in medical practice. That is why many agents will come and tell you, sir, give the money, sir, you are busy and I will manage the your money. Indirectly, they are telling that you are a fool, you don't know how to manage the money, and give me, I will manage and enjoy. Whatever rest remaining, you will give to you. We rely on agents and relatives. Before fifth year of my practice, most of my insurance has been given by my relatives, my teachers, sons, my in-laws. Everybody come and told, before I could, it is useless, they are already given for 5 to 10 insurance. Many time it happens for us also, because of face value, because of my relative pressures or politicians. Somewhere we don't know what is, they come and we give without seeing. They'll tell all glorified, and we don't know, we don't ask the questions because we don't know ourselves. It is not wrong on them, because everybody who comes, Ram sir tells, the person who comes to your door is always has the first priority in his interest. Nobody will come to make you as a priority. You have to remember, if anything comes in life very easy to your door, you be little worried, because you have to go into details and ask. No learning opportunity till there is no systemic learning opportunity. I used to learn. I have spent more than 5 lakhs. I have attended about few live workshop in different parts of India by different persons to learn what Ram sir has told on online and offline within few days. And nobody is monitored like this association, because your investments are judged by some other doctor colleagues, and immediately they will jump if they tell wrong things or right things. No dedicated groups for doctors till now. Now we have a groups of few, like almost 1 lakh it is crossing, and we have dedicated doctors who are very much they are as good as any other investment professionals. See, it is true in general, and specifically in India, 95% of Indian total money is managed by only 5% of the club, and only 5%, 20% will manage other rest of the 5%. Why it is so? It is because just that what makes the difference between 80% of total invest or the 95% of the total is financial education. Today we are there here to learn few points in financial education, so that we'll try to come in that elite 5% group. What is the importance? Why you should learn financial education? What is the importance of financial education? You should remember, if you take as 60 years as a standard life, what is called as a retirement, though doctor doesn't retirement it till end, but still we take 60 years, means about 25 to 30 years we are living beyond our retirement age, because of increased life expectancy and cost of living. Almost every 10 years your cost of living is doubling. For example, my Innova, when I taken 10 years back, it is 17 lakhs. Now you remember what is the Innova cost? I think many of you have Innova, is nearing 40 lakhs. Is it drastically decreased so much? No, not much, because of cost of living it has gone up. For medical education, I have finished my medical education less than 1 lakh. For my kid nursery entry, I have given 2 lakhs. This cost has gone so high. Children's are not retirement plans. Don't please not to depend on children's. It's not anything bad about children's. We don't know because we're going to stay. I have built 100-bedded pediatric hospital. I am not sure whether they're going to come and be in my hospital. We don't know because first of all, they are not ready to join pediatric. He joined in the medicine. But I don't know because it happens. Most of us don't try to depend on your kid for your retirement plan. And don't tell them that we are going to look after. They are looking after. Most of us kids are good, but it is not guaranteed. We have to depend on don't depend your retirement life expectancy or the life expenses on your children's. I told in these headings we are going to discuss. First point is in mind that is earning. There are two types of earning for us is active income and a passive income earning. Active income either in the form of your employee or self-employed or the small business. Passive income is you will earn by investment in different areas. As a business owner like this, I wondered, I thank Tumkur people. I think it is there in Tumkur here. This medical college is owned by a doctor. Yesterday, what we have done in the night party is owned by a doctor. It's very rare to see a doctor entrepreneurs. We know to work like a donkey in others hospitals and go do everything, but it's very difficult to do our own hospital. And because we are ready to see 200, 400, 500 patients, but somebody comes and tells that Aya has not come and cleaner is not come, we'll get irritated because we are not trained to run our hospital. We are trained to see the patients in the form of royalty, rights and rents. These are the passive. If you earn passive income, you can enjoy like this fellow at the beach. Still your institute runs in your name and you will earn. But you tell me honestly what group most of us belong, active or passive? Most of them are active because we are nothing but a glorified daily worker. The moment you stop working, our earning will stop. And it has happened especially in the corona time. In Hyderabad, there are more than 200 hospitals are closed in just about that 6 months of corona period because we are dependent solely on the hospital. We don't know anything other than seeing a patient and getting the money. Now we are coming to earning or spending. You have to remember, this is the rule. What is the Parkinson rule? No matter how much money people earn, they tend to spend the entire amount and save a little. You can see the upper one is learning curve, earning, and lower one is spending. The moment your earning will increase, your spending also increase. So at the end, whatever you earn, the amount you saved will remain same. You can imagine, if you yourself judge at the beginning what car you have, what house you have, what phone you have. Now how much you are earning and what you are getting, it will becomes almost same. Like why it happens is difficult to make. We are differential. You can't differentiate different type of expenses. If you can make out the difference between different types of expenses, then we can try to say what are the different types of expenses. We'll expend either it on the product of need or the product of prestige, what you call it as a pawns and pops. What is the difference? How to differentiate? Pawns are always required for living utility and convenience. Day-to-day living, you need that, like a living expenses, like a routine car to take from point A to point B. For pops are not required for survival. Really, they are not required for day-to-day survival. Only for prestige and style stake. It may hurt many of us, but it is a true sentence. What is the example? We have luxury car, jewelry, and hi-fi phone. In my place there are few doctors, both husband and wife. Every year they take an iPhone. What they do? They receive and call. That is all. They don't do anything else. But they will, because it is a prestige. The show to iPhone is a prestige many times. It has its own advantage, but many are using just to show off. How to differentiate? Is there any way to differentiate what is the pops and pawns? What we tell it is a Facebook or the party test. The product which are usually put on social media usually will belong to pops, not on the pawns. What usually we are doing routinely is we'll earn, we'll spend, whatever remaining amount we'll invest in an insurance, imagining that it is an investment. But what you should do now from now onwards, whatever you are earning, try to save maximum, and whatever you are saving, try to invest maximum. What is the thumb rule? We call 50, 30, 20 rules. 50% of daily or earning, what is monthly earning, should go to the living expenses. 30% is a lifestyle shopping like travel or enjoy. See, life is there for enjoyment. I'm not going to tell you save till death. At the end age of when you say 70, 80, where you can't move, you have enough money, but you don't have age to enjoy. You should enjoy, but this should be the target. 20% of whatever remaining should have a investment and saving. This should be the minimum amount. If try to push saving instead of 30%, it is 40% is best, and 20% instead of 40% is best. Try to. This is the minimum criteria. I always tell that we know very famous like systemic investment plan. Before that, you should have a systemic saving plan so that you can do a systemic investment plan. If you have a saving, then only you have to invest. Otherwise, you can't. Money saved is a money earned. It's very difficult to earn, but it's very easy to spend. What is the difference between saving and investment? Many times we feel that saving is equal as an investment. In my place, principal of one of my medical college have a few crores in a saving account. When I said, why are you keeping, sir? What I can do? There is a facility to automatically go to FD every moment. Next, within few hours, whatever you are earning, we can go. There is a sweep out facility. But persons who doesn't know that it is the facilities. I can't go every day. I can't to fix FD. There is a facility. If you tell a standing instruction that same day, except for certain amount, whatever you specify, everything will go to FD. Saving account will save only 3% earn, and FD will earn minimum 6 to 7%. By sitting without doing anything, by just one saving instruction, you can earn double, but still many will be ignorant of that. What is the difference between saving investment? One sentence: buying appreciating asset. You remember what is asset? We'll discuss, which beats inflation and tax. Again, there are three types here, three words here. What is asset? We'll discuss. What is inflation? We'll discuss. What minimum investment? I told 20%. Increase, try to as much as possible. What is asset? Anything which pays for you is asset. What is liability? Anything which takes away money from you is a liability. With that definition, we can divide what are the different types of assets. For example, sorry if I hurt many dog lovers here, it is not a asset, it is a liability, because I have, since about 1 year, I have started taking care of dog. It is 5,000 to 6,000 every month we have to spend to take care of your dog. And there are other benefits. If you only money, it is different, but there are other benefits. Just to compare, that is the asset, this is the liability. These are the true assets. If at all you want to think what are the true assets, easy to sell, no emotional involvement. Examples are cash, FD, policy, mutual fund shares, land, plots, commercial building, and gold coins. What is pseudo assets? Difficult to sell, emotional involvement is you can't sell easily. What are the different? This is house, car, furnitures, gadgets, jewelry. My wife has so many jewelry, she never sell anything, but she tell some reason to buy, but she never sell. That is not true. We believe that gold investment, physical gold investment is an investment. It is not investment, because you remember they are going to cost 20% more than it's called as making charges. And when you give back, they have breaking charges. Both way they will cut in 20%. There is no way you can make a benefit out of your what is called hard gold. It hurts many ladies, but it is a true thing. If at all you want to invest in a gold, go for a paper gold. What is that? We'll discuss. When you want to invest, that time you can sell the paper gold and take a hard gold. Assets we can broadly divide into physical, financial, and intangible. Physical is the gold, real estate, machines. Financial, where the equity and debt. Intangible, your brand name itself can be an asset. Trademark and copyrights. Then you come to investment. What are they? We want to invest now. What are the ways to invest? What are the different assets we can invest? We broadly will divide at a grid. Gold, real estate, equity, and debt. These are the four real assets which beat the inflation. You should know each points in these four assets so that you can invest easily. How to, if you are ready to invest, how much to? This is the rough rule is 40% should go to equity and real estate. only 10% should go to the gold and debt products. Gold has given exceptional earning in last 3 years. This has reached 2 days before highest in the lifetime. 10 grams or 1 tola is gone to 1,10,000 rupees. But it's very rare it happens. Roughly towards anything, madam? I want you people to guess how much it could be the cost of this gold. I think it's difficult for males, but at least there are ladies who can guess. What is the amount, madam? You will guess. Whatever it may be. Whatever you feel. No, I think they let them. Anything? 10 lakhs, 1%. Anything? Anybody else? This has cost 5,000 rupees. See, now the gold has become so fake. If a rich person puts this, they will think that it is gold. If the poor puts that, they think that it is a roll gold. It's very difficult to make out. That is why I don't feel that gold, putting a gold is a very prestigious, because everybody is putting a gold like this gold. What is the real gold then? Paper gold. We call it as a paper gold is the real gold. These are the broadly three different. You have to remember the sovereign gold bond has gone now. There is, because government has withdrawn that, they are not giving any new. There's the biggest advantage. I invested, but now they have stopped. Now only we are the physical and a gold ETF. What is the difference? You can be returns lower than the actual, because they cut 20% on this side. They are exactly on the same because they are traded into the everyday into the gold rate. Safety always a problem for in a physical gold. In during undergraduate, one person in the ophthalmology department came with the one eye has gone. I asked why it is a problem, because he has bought a roll gold in the finger. When he crossed in the railway crack, one person thought that it is a real gold and hit on the eyes. For 5 rupees gold, he has lost his eyes. Purity of gold is always a problem. I tell many times ladies to see the hallmark mark. Many ladies doesn't know what is hallmark. If at all you want to go physical gold, you must check please hallmark, because that tells about 99% of purity of gold. But many times we go to the gold shop, they don't have hallmark at all. Now the government has made a compulsory, whether it is really happening or I don't know, any ladies only has to tell. If it is marked, then only you take. Otherwise, don't go. Many times we'll know the person who has personal family friend. We sells the gold. There is no gold mark. They tells that you please bring, I will take 100%. Many times it never come back, because then I know the ladies will never going to sell it. They are very assured. Many times they will give a gold without taking. My wife will give 1 month afterwards, because they sure they will take and they will never going to come back. That is why please take, if at all, pure gold to the hallmark. Capital gain is same for both. Collateral against, we can put a collateral both. Many gold schemes are there now. Tradability, gold can be bought in a single minute and sold, and immediately the money will come. It is very difficult in case of physical gold. Then we'll come to the one is gold. We go to gold. We are told now the equity. What is the meaning of equity? Is you should remember you become a equal. It is not a equal. Just to remember, I'm telling you will become an equal partner in a big company. Because let's see, any big company will run by two methods. Either will take a loan from the government or to the bank, or you will go to the open market. He'll invest lakhs or crores of money, and then you will invest in, and whatever the profit he earns, you will give the amount you are investor proportion. For example, if you invest in a Reliance, you may become 0.0001% of Reliance company, and all your shares or rights are equal to the. But you are only small portion. Whatever profit he gets, equal to that proportion, you will get a benefit. That is the equity for you, simple terms. What are the different way of investing in equity? We'll see. What is the advantage is it can beat inflation. I told, create a value for portfolio, long-term growth. Indian economy is going to surge. We are about 40% of populations are less than 30 years, and we are going to become a third. We already become fourth largest, and we are going to become a third largest. And it is going to be invariably, whatever government comes. If this government comes, it may faster, but any other dirty government comes also, it will grow, because not because of politician, because of our people purchasing power. If the good government comes, definitely it's going to increase. But if the bad government comes, because you remember so many ministers, the prime minister has happened, but still Indian continuously it is increasing. What are the different way of buying equity? These are the two types. Broadly, I tell equity is a two types, either directly into the stock market in particular company, or you have mutual funds. These are the two broad way. What are the, how to differentiate? I will tell you roughly. Equity is stocks is directly investing in a single company. It can go very high. For example, there are, for what is the costless stocks available in Indian market now, sir? MRF. It is more than 1 lakh. One stock will cost more than 1 lakh. When I invested, it was about few thousand, less than 10,000, 2,000, 3,000. Now it has become 1 lakh. But equally, it can become zero also. When I started investing in 2001, I invested lot of Anil Ambani companies. That time I don't know, because whoever runs used to invest. I have not learned anything. Now, even now they are stocks, because I'm not keeping, because they are increasing. I am not able to sell. Nobody is ready to take. If Yesh Bank is one of the top, now it has gone rich. It can go in both way. That is, if you don't have a time, if you don't have a knowledge, if you don't tolerate a risk, and you don't want to earn that much of headache, you better to go to mutual fund. What is a mutual fund? Mutual fund is a bunch of stocks which is managed by a expert in that field, so that what is, we have take of 50 stocks, we, even if one goes to zero, 49s are doing well, or 46 are doing, 45 has a reliability is very high. But remember that they won't give us double triple amount, but equally they don't go for zero. They are in between. Like you can compare, you want to go from here to my Raichur, either I can go to the bus, or you can go, I want to go to fast, I don't want to stop anywhere, I can take a car. But you have to go fast, and you chances of accidents are more here. But you can reach early, and you can your own speed. But I don't have a time, I don't have a money, I don't have a patience, I want to sleep, put a headache on driver and go in back seat and sleep. Like a bus, you have to give a partial, small amount of money to the driver, but you are going to take its own time, it is going to stop middle and all. That is the difference between stocks and mutual funds. These are the different types. What are these points only I have told you already. Among the mutual fund, there are two types. One you called as index investing and general investing. Index investing, what is the index investing? Means these are the indexes which are bunched together by the stock exchange of India, like a BSE, NSE. They will have taken largest 50 company, largest 100 company, largest IT companies, largest cement companies and different sectors. And there is no stock market manager there. There is no mutual fund manager. Automatically it's built in, because accordingly the largest, if you take a number of stock into rupees, whatever the cost of that stock, they will have a largest. Then that they calculate top 50 and top 100, top 200. There is no manager is involved. If the company becomes bad, ultimately the stock prices will go down. That will go automatically, they will be kicked off, and next good companies will taken. That is index for you. You want to earn more like a stocks, but you don't want to take a headache of stocks, but advantage of mutual fund, then you go for index investing. At the end of my talk, if at all you want to go directly, one point you want to take, start investing from in tomorrow onwards, index funds. They are the very, very least troubling, easy to learn, easy to invest. Minimum about 12 to 15% you can earn. For 20, 30, 40 years you can invest without seeing in a single day, because it is automated and it is advantage its own. These are the told index I told. These are the Nifty 50, top 50 companies of India. They are investing. These are the top 50. You imagine who can go to bankrupt in tomorrow or day after tomorrow. This is the next 50. 51 to 100 top companies of India. That they are going to 12 to 15%. This is going to increase, earn by about 15 to 16 or 2-3% more than the large first 50 companies. The index investing. This is what I told you. Remember 1980 oil and gas was the maximum sectors. 2000 financial, 2020 is internet and services. Now again in 2025 financial, because these are automatically balanced, and that is why it changes accordingly. Because of that, we call it as a like Hero Honda advertise: fill it, shut it, and forget it. If you invest this, see, we are discussing yesterday, we don't want to take headache for your retirement or your kids' education. Just invest and forget a certain amount on certain date. Direct, there are two ways of investment in any of these two. Direct funds or the indirect funds. What the direct means? You are going to invest directly to the mutual fund house. That is only 1% cost. But if you go through the agent, it is a 2.5 to 3% cost. Many of our own colleagues in Raichur, they will invest through the agent. It is well, if you don't have time, at least do that. But remember that costs a huge amount. For you people, you will ring another 1%. What's the makes the difference? You remember, it is not a 1%. It is a 1% of not your investment. It is a 1% of your total accumulated amount. For example, if you invest 1 lakh per month, at the end of 10 years, it becomes 1 crore. 1% of 1 crore means 1 lakh rupees you are going to waste on that agent. Without doing anything, one time work, your agent will earn 1 lakh from your side every year. Whether you earn or not, that mutual fund is earning or not, he is going to continuously get 1 lakh. That is why many of my our colleague agents, they are going abroad for journey or the enjoyment, because they earn lakhs together just by agency. Inflation, what is inflation? What is it called as a decreasing power of purchasing? What is simple meaning means the amount which is there today is by certain amount, can't buy it tomorrow because increasing cost of their production. That is why I have to pay more and more. That is a simple word of inflation. It is general, government tells that 6 to 7%. Is remember, it is not 6 to 7%, especially health and education is 10 to 15%. Karnataka government itself increase the medical seat every year, almost alternate year 10%. It is very high. That your investment minimum should be able to beat about 12 to 13%, then only it is a real earning. See, these only equities, mutual funds and gold and real estate will earn the more than inflation. That is a minimum aim of your investment. No other thing, fixed deposits, all ULIPs, insurance policies, all insurance policies will not earn more than 6 to 7%. Next is the taxation. The death and taxes are certain. You can't avoid taxes at all. If you earn income, what you do, either you will spend, you have to pay as a GST, as a tax. If you invest, you will pay as an income tax. As a better you to earn more, give a little tax and be relaxed, rather than spend and give the tax there. Anyhow, you have to give a tax, because Modi government is going pushing, and all other assets is blocking, all block money, and he is trying to increase the white money. Better you only start so that you can invest and earn more. Cash generation by avoiding tax is a big no. These sale. How many of you are there in new tax regime, sir? See, I definitely feel that in next 2-3 years they are going to close the old tax. This is all for just a name's sake. If at all you people are as in old tax, you try to save in these different avenues. Everybody knows. I'm not going to tell in details about that. Insurance. Next is insurance. Insurance in expense. Don't waste the time to study expenses. Never mix insurance and investment. This is the, I think, insurance is the most horribly sold, wrongly sold product in India, and biggest partner is Indian government. In life insurance company, sorry to say that this is one of the biggest fraud company which sells so many insurance for everybody, which earns only about 6 to 7%. If you go and calculate what they will tell, for you it looks very lakh. They tell you invest 5 lakhs for 5 years, live for 20 years, you will learn 1 crore means you will be so happy. You same amount you put in mutual fund 12%, and calculate yourself. There are so many SIP calculator. You will earn 4 or 5 times more than the simple insurance. What is the difference between, if at all you want to take insurance, you take only these insurances, not any other insurances. One is term insurance. How many of you have term insurance of more than 1 crore? See, 1 crore means they will put the hands many, because we take only 10 lakhs, 20 lakhs. Please take a term insurance, minimum of 20 times of your annual earning, or minimum of 1 crore. Please enter at the early, because you try to early in the late, its cost is going to jack up many times. Never invest in a endowment policy. What endowment means, some amount of money they will give back. They will never beat inflation, hardly earn more than 6%. Never take a ULIP. What is a ULIP? Unit linked insurance policy. they take 30-40% as expenses. Before, now it has come down, but still it is more than the mutual fund. Rest amount they will invest in both. They will try to invest and insurance. That is not going to play. Either you put into insurance or you can investment. Never try to mix it. General insurance, these are health insurance. How many of you have taken insurance of more than 20 lakhs, sir? Health insurance? See, even you work in the hospital, medical college, even if you are admitted in your own hospital, I don't think nobody will go into it free of your cost, because you have saved so many and earned for them so many. They are going to cost equally. That is why please take a minimum 20 lakhs, best is 1 crore. First you take a base and then take a top up. Base of 20 lakhs will cost about 30,000, but top up will cost only 1 crore will cost about 10-20,000 rupees. That is why always try to divide and base and top up. Take a car insurance, professional indemnity, and travel insurance. Very less expenses travel insurance. Whatever you finish, whatever. No problem. In next 5 minutes, I'm trying to finish up. If I speed up, sorry me. And if you had any doubts, we can ask afterwards. What is the next? We discuss about the loans. See, loans, modern slavers are not in chains. They are like a credit cards and other different debits. Loans, we can't get away loans, because you have to take a loans, but only certain loans, which is a good loan. What are the good loans? That increase the productivity, create assets, save a tax. What are the examples? Like business loans and home loan. Bad loans are non-productive, doesn't create asset, doesn't save the taxes. Consumer loans, car loans, personal loans, gazette loans, credit card loans. Credit card loans, please don't take, because it costs 30% interest for, and that's one of the highest. Personal loans about 15 to 16%. Gazette loans, there is one study yesterday I was reading, 80% iPhone purchasers in India will take iPhone on loans. You can imagine. Like, I'm ready to invest, sir. What is the problem? As a busy professional, can I invest successfully? Only 2 points. Either time is required, you tell it is a busy, you are busy. Knowledge is required, I don't know anything about it. From today onwards, it should change. You have a few times, depending upon the whatever time, productivity, or the money you have, we will decide what type of our investor. Depending upon that, we will try to merge in those two groups. See, depending upon this target, time, age, risk appetite, goal, and expertise, and time to track the market, we can divide ourselves into a passive investor, active investor, and a trader. Overall, you should keep your investment keep it simple and stupid. KISS principle. If you want to do that, you should have a lot of PDF, patience, discipline, and a faith. Patience on yourself and the Indian market, discipline of not looking for next 10 to 20 years, and faith in Indian youth and India growth story. And you should manage yourself first. Mind and risk manage before the money. Money you have, don't try to manage the risk, because risk is inbuilt. If you have a long time, your risk is automatically taken care of. What are the type of passive investor? You have a limited time, but you want a respectable return in the 12 to 15%. If you want to do that without any headache, once in 6 months, once in a year, invest in a mutual fund, either directly or in ETF. Track once in every month. ETF you invest, you don't need to see at all. Active investor, they give a little more time and follow and sip and dip. And what is a sip and dip? Systemic investment plan. Whenever there is a fall, then you have a dip investment. Buying and track monthly, that can earn roughly about 20%. If you have a minimum about half an hour, 5-10 minutes in a day, you can do this. Seasonal investors, if you have more time, you can trade, not like a day trader, but about 2-3 months trader. Day trading and tips trader, you should never buy it. Whenever I go and talk, many investors, many of my friends will tell that I don't have a time. I will give a money, you manage, you take certain amount and take, because they're not ready to learn at all. Many of us, we still telling so much, they're not ready to earn themselves. And they're ready to give for agent who takes a lot of their money. How to depend? These are the different points. If you have a rough age is 100 minus age, your investment. If you are for 50 years, 50% should go to the equity. If for 80 years, only 20%, because you have a less time. Goal and duration. Few months, if you have, you would go for FD or RD or liquid management. Few years, go to mutual fund. If you're 3 to 5 years balanced mutual fund, more than 5 years, you go to large and multi-cap fund. If more than 10 years, go to small and mid-cap and real estate. Small and mid-cap will give about 20 to 25%. Large cap will give about 15%. ETF will give about 12 to 15%. See, if you are ready to invest, I told what are the ways. What are the ways to invest? There are only two types: SIP or the lump sum. SIP means, many times I told whether you are investing, my friends will tell that I am. SIP is not a product. It is the way to invest. Systemic investment plan. It is nothing but a glorified recurrent deposit, age-old recurrent deposit. You fix some amount on some day and some years together and some product. That is all SIP for you. And lump sum, when you want a large amount of money, you try to invest in the single time. You can both. You can do it. Remain 20 to 30% SIP, 70% in SIP, 30% in dip, because Indian stock market always gives a 10% of a dip every year, 3 to 4 times, and 30% once in 10 years, like a corona. Please remain 20-30% you shave for a dip buying, 70% should go for a SIP buying. In that way, you can push up your investment more than 4 to 5% of routine SIP investments. Adult SIP will cost averaging, compounding, easy, no need to time the market. If you are minimum 7 years, you invest SIP. If you are less than 5 years, don't come to the market. How to do? These are the different ways of doing a SIP investment. If you do only SIP, you may not earn much. If you do a investment increments every year, for example, this fellow invested 20,000 for 25 years and same investment of earning 12%, he earns 3.75 crores. But if you increase 10%, just 10% every year, he has earned the 9 crores, almost 3 times what he was earning, just by increasing a 10%. Why it is so? Because not try to markets haphazardly behave, suddenly fall and suddenly rise. You can see these, they are clusters. Nobody in the earth is able to pick up the what falls and when it rises. That is why blindly you have to fall few years, it will average your cost. For example, if you try to pin the market, try to market and try to time the market, this is what happens. For example, 10 lakh invested for 10 years, and if you are all the days invested, it will become 60 lakhs. Miss 5 days, 39 lakhs. Miss 10 days, 30 lakhs. Miss 20 days, 21 lakhs. If you miss good 30 days, it may even go to the negative. Means nobody on the earth can time the market. Time in the market is more important than the timing the market. That is why it's called SIP is always compared with what is called as a Chinese bamboo. Chinese bamboo, when you put it will for 5 years, it doesn't come beyond the ground only. Next 1 year, 20 feet it grows. Like your SIP is like that only. First 4-5 years, it won't earn much. After 5-6 years, compounding happens, large amount of money starts pulling up. Why it happens? This is, see, for example, what is the difference between compound earning and simple earning? 10,000 you invested for 5 years, simple, it will earn only interest, because exactly the same amount earns. It is a simple interest like your FD, 5,000 only it earns. For compounding interest, interest also earns the interest. It will be merged towards the principal amount. You can see here 6,100 instead of 5,000. That is the beauty. Like it is like a chess game. One fellow has gone to Raja and asked, simple, I want a rice grains just to double from one to end of the chess. This is what happens if you double. So you see, this much amount of grains, it is more than the height of the Everest. It's in that much of rice grains you can give, just double, just to imagine what is the effect of your compounding. That is why Einstein has told this famous statement, compounding interest is the 8th wonder of the world. He who understands it earns, who doesn't pays for it. Then if you are ready to invest, what tomorrow, what is the right time? Today is the right time. Each day is important. For example, you can see here, for example, this anybody can read. I can see that it's a famous rule of 15%. If you invest 15,000 every month, earns 15%. For 15 years, it is going to earn 1 crores. But if you invest 15, same, everything is same, duration is doubled, it is going to increase the 10 crores. You remember that much because of compounding effect. For example, if you double only the time, money, instead of 15,000, if you invest 30,000, everything remains same, 1 crore will become 2 crores. But if you double the time, the 10 earning will become 10 times. Friends, if you know finance, you can become like anything. If you don't know, you can land in the problem. For example, you have seen a cinema, I think you heard the story of Mahanati Savitri. She is one of the richest actor during that time, and she has highest number of high-end cars. But she's died in a boring hospital, and somebody has recognized that she is a Savitri because she could not handle her finance properly and landed in the problem. Next is a live present example is first Croropati, which is owned by Amitabh Bachchan. The person within 5 years is gone to bankrupt because he could not manage the money. Friends, money is not the solution. How you manage is the solution. In the same way, these are the two, I think it's inspiration for everybody, more so for the ladies. Leelavati is a single mother, and she's one of the richest actor in Karnataka, in Kannada, because she has invested from the day one of her earning. And you can see here, Malvika Hegde, her husband died, Coffee Day owner, because he could not manage the loan. But within few years, she could repay all the loans and make it profitable. See, ladies also has a big role to play, and especially for requesting you to please take an interest. I have seen many, including my wife, that tell that give certain amount of money, you do whatever you want. But many are not lucky, because I have heard horror stories where mismanaged by the money by husband. They don't know what is the number of locker number or the password of their own bank account, and they are on the bankrupt on the road. Because I try to, at least I'm not telling to suspect everybody, but you should also know, because we don't know life which takes turn, who meets what fate. But equally, health is also important. Please spend money before spending. You take care of your health before earning. The best investment you can make is invest yourself. To more you learn, more you learn, more you earn. These are the different ways to learn. There are YouTube, there are books, there are the movies, there are the websites. Easy to learn. I have spent a 5 lakhs, but you people are not need not to spend a single paisa. You can go through in these and you can learn. If you are anybody is interested, you can pin me or take a WhatsApp number or mobile number. I can answer afterwards also. If you don't find a way to make a money while you sleep, you will work until you die. That should not to happen to us, and we should be able to earn a passive income, which is much more than the active income. With that hope, I already finished this take-home message at the beginning. Thank you for patiently hearing. Thank you.
Thank you for this wonderful talk, sir. No. Means I wanted to include this talk, but what I could not handle. When I had called sir, he told, if you are going to give me 5 or 10 minutes, definitely I'm not going to come. So my first promise was, you're definitely going to get 30 minutes talk. So no matter whatever it is, I'm going to give it. So the best was saved for the last. Hope many people had a financial education for today. So may I request our chairperson to felicitate. We can discuss during the lunch hours. So last talk for the day. Certificate courses. Last talk for the day. I would like to call upon Anil Sapare sir to facilitate our chairperson, Dr. Anand sir. One more last talk for the day. That's it. We are going. ಇದೆ. ಹೇಳಿದ್ದೀನಿ. I would like to call upon Lakshmikant sir, please chair the session. Dr. Lakshmikant sir is a senior consultant pediatrician. He works at district hospitals.
Straight away we come to Dr. Russell, youngster, just come with great hopes to TUMAKURU as a neonatologist, and I hope he'll continue to stay in TUMAKURU and do a good job. Please, over to you, Dr. Russell. Thank you, sir. Thank you.
Hello. So we'll discuss today about changing landscape of respiratory syncytial virus prevention with nirsevimab, a newer mononuclear antibody for all infants. So first we'll go through the disease burden of respiratory syncytial virus. So as we know, common and contagious seasonal virus that can cause a respiratory virus, and it's transmitted mainly by infected people through cough and sneezes, and can survive on hard surfaces for many hours. And it has seasonal preferences, and actually it is all around, but it has many seasonal preferences, and it changes in the many regions of the India. So respiratory syncytial virus is highly contagious. It's called RO.